The first session is on complex total joint arthroplasty, and I would like to invite Dr. Bhavuk Garg and Dr. Abhay Allens to moderate this session. And Dr. Dhansekar Raja and Dr. Bhavuk Garg to moderate the first session on complex total joint arthroplasty.
He's on. He's online. Yeah. So welcome back to the third day of the current concepts in arthroplasty program. So first talk will be by Dr. Neil Seth. He's going to talk about management of acetabular bone loss and pelvic discontinuity.
Good morning, guys. Can you guys hear me?
Yes, we are able to hear you. Please go ahead. So good evening, Neil.
How are you? I'm just trying to share my screen real quick. And let me just make sure I can. Great. Can you see those slides?
Yes.
Okay, very good. Thank you again to Dr. Malhotra and the organizing group, to the committee for the invitation. Again, I wish I could be there in person. We had a really nice session last night, our time, regarding DAA and anterior hips, with regards to a lot of tips and tricks and things to think about as you're going through your learning curve. Tonight I'm going to talk about an update on management of severe acetabular defects and revision total hips, specifically looking at chronic pelvic discontinuity. My disclosures are not really pertinent for this presentation, because I'm going to be talking more about concepts. And I'm going to start out by talking about a case, and then we'll talk about the case at the end and talk about the treatment of this type of defect. This is a 71-year-old patient who came in with a right total hip replacement that was performed 21 years ago with this discontinuity. And it was not initially treated by me, but Ryan Martin, when he was at the Mayo Clinic, gave us a nice view of how to actually determine if you can expect to see a chronic pelvic discontinuity when you're in the operating room. If there's a medial breach or a violation of Kohler's line, if there's an asymmetric foramen here, as you can see in this X-ray, if you have medial translation of the inferior segment, those three things put you at a very high risk of having a chronic pelvic discontinuity. And on top of that, if you add a lateral view of some sort, then you can basically get up to 100% guarantee that what you find intraoperatively will correlate with what you thought you would see preoperatively. When we think about goals of acetabular reconstruction, again, I think this is really definitely the US perspective of trying to do everything cementless when we're looking at these concepts. On the pelvis side, I think this is starting to hold true around the world. I know there are centers still in India for specific patients and specific constraints that we may not have in the US, where cement still may be a good option. But if you're going to do a cementless fixation device, you have to have intimate host bone contact. You have to put in a stable mechanical construct that minimizes micromotion and allows for biologic fixation. And this also allows you to physiologically distribute the stress across the remaining host bone stock of the acetabulum. Everything in revision total hip arthroplasty is based on this concept of getting column fit between the anterior superior and posterior inferior column. When these columns are deficient, they need to be restored or they have to be reconstructed. And if they are present, then you have a better chance of getting good, stable mechanical fixation of your construct. The Paprassi classification has been now out for 27 years. And you can see this is based off of 4 different components on an X-ray, looking at the migration of the hip center compared to the superior obturator line, the amount of osteolysis in the teardrop and in the ischium, and then looking at violation of Kohler's line, again, that hip center going medial to that ilioischial line. If I look at these 3 defects, which are the tougher defects to take care of, is a type 2C defect where you have medial migration without a lot of superior migration. Columns are typically still intact, but this is the first time that we see violation of Kohler's line. Typically, you can treat this with a hemispherical shell. The type 3 defects are clearly the tougher defects to handle, 3A and 3B, so that's up and out or up and in defects. Unlikely a isolated hemispherical cup alone will be enough to treat this defect. These are the three that you might have a chronic pelvic discontinuity associated with the defect. And again, in the 3B defects, this is the more common scenario that we see the chronic pelvic discontinuity. Why is this still an unsolved problem? So chronic pelvic discontinuities, there's still healing potential that is an issue. And the reason is I think we should look at this as a chronic non-union or a fibrous non-union. And I think that's why we're not sure that we can get this to actually heal. Chronic discontinuities, I think, have a few different options. You have the cup cage construct, custom triflange components, hemispherical shells with modular augments. Some centers are now looking at 3D printed technology and custom acetabular components. And I'm going to talk to you about acetabular distraction technique with or without the use of augments, which is my preferred technique. Three main principles for distraction. Number one, you have to define but not destabilize the chronic pelvic discontinuity. Number two, if you're going to have to use augments, you need to understand the function of your augments. Augments are not there just to fill in bone that's missing. And number three, you have to make sure to get inferior screw fixation to prevent abduction failure of your component. Step one, again, defining the chronic discontinuity intraoperatively. I use a Cobb elevator, which is easy to do. But once you figure out that you have a chronic pelvic discontinuity, it is important that when you do a debridement of that scar tissue, you do not do it too aggressively. And if you don't, then you can avoid destabilizing the discontinuity. I will also bone graft the pelvic discontinuity before putting in my final components. Second thing I talked about is porous modular augments. Every company has them. It doesn't matter which company you use, but I think it's important to understand the function of what your augment is doing. If you have deficient columns, then I put the augment in first to reconstruct the column. That is now for primary stability of your overall construct. If you put your cup in and you don't like the screw fixation or the number of screws that you were able to get, then you put an augment in for supplemental fixation. Again, this extends your construct and increases the number of screws that you have in your construct overall. Again, augments should not be thought of just as pieces of equipment they're using for volumetric bone loss. And if you're going to put an augment in with a cup, you have to always unitize that augment to the cup with cement. Okay, that makes the whole entire construct a lock construct and essentially allows you to unitize the entire construct as one piece. You see here anteriors to the left, posteriors to the right. That augment was placed initially before putting in the cup. There's some cement actually on the inside surface of it between that and the cup. That augment is for primary stability. Once that augment goes in, you ream between that augment and the ischium, and you can get a sense of what size cup you want to put in. If you're not happy with your screw fixation, again, then you can put an augment posterior-superiorly against host bone, supplemental fixation augment, and again, cement will be in between both those augments and the cup to create a complete unitized construct. Inferior screw fixation is the last thing to really think about. This is a case that was sent to me 4 days after this patient underwent a revision at an outside hospital. You can see how the cup has failed in abduction. That inferior screw, I'll tell you, is a 15-millimeter screw and clearly did not have enough purchase. And so even though a discontinuity is not the case here, the concept, I think, is very clear that if you get inferior screw fixation, have to be able to put a screw into the ischium or into the superior pubic ramus in order, again, avoid that type of abduction failure. We have put together a technique just recently on how to get that superior pubic ramus screw. Actually, Krishna Kiran is one of the co-authors with Wayne Paprassi and myself on looking at how to put this screw in and how to do this properly and safely. I use a femoral elevator, which you can see here. The little half circle shape gives me an idea of what the center is of my pubic ramus. And when I use the drill, I'll use the drill on oscillate. We have just recently gotten the technique accepted to JBJS for essential surgical techniques. We also talk about using two specific views in the operating room, an inlet view and an obturator outlet view, which can help you with making sure that you're in the center of the pubic ramus on two views to make sure you're not breaching in any direction. Distraction, again, this is what the distractor looks like. It looks like a glorified lamina spreader. There's two holes to allow for a K-wire to be placed over it. And essentially the distractor gives you lateral or peripheral acetabular distraction, and it causes medial or central compression across the discontinuity. This is kind of what it looks like in a cartoon format. You can see that that's what the distractor looks like with the K-wires in place. I need to place an augment for primary stability, I would put that in first, then put my cup in with additional screws. And if I'm not happy with this, again, another augment postero-superiorly with screws, and again, putting cement to unitize. So this allows me to intraoperatively customize my construct, and the cement allows me to unitize the entire construct. Lots of data out there in the early to midterm cup cages have shown very good results, 85, 90% plus. You do have to be careful if you're going to use a cup cage. The typical tendency is to place the cup a little bit more vertical and retroverted to accommodate the cage. You can change the version of your liner, but you just have to be cognizant that that's what you need to do. The flange, inferiorly, when it gets fixed in the ischium, can be a problem with someone who has significant osteolysis, so that could be an issue. Looking at tri-flange constructs, again, a little bit longer term results, so midterm to longer term out to 10 years. Pretty good results, 90% plus for most results, but there's a high cost associated with this construct. There's a lag time for the implant to be manufactured. There is complex pre-op planning, and typically your bone loss pattern does not fit exactly what your pre-op plan showed. The hip center can be lateralized with this construct, and dislocation rates anywhere between 12 and 21%. Bob Sershon from the Anderson Clinic just recently published their series of 50 patients with 20-year follow-up with a dislocation rate of about 12%. Discontinuity treatments with just porous cups and augments. Again, these studies are not as clean because these are plus minus discontinuities, but again, pretty good results, similar in the high 80s to 90s to almost 100% in some studies. And then 3D printed acetabular components. This is a relatively newer technology. Some studies are being put out there, and some centers are looking at this, but you can see most have very small series of patients and very short-term follow-up of 3 months out to a year or two. But again, early results are pretty promising. I will tell you again, the same thing of cost and time lag, but the pre-op planning phase, I think of this is really similar to a tri-flange, where you have these nice plans and you can plan out the length of screw and the position and trajectory of your screws. But again, if your bone loss pattern does not fit to exactly what your pre-op plan was, you may end up in a situation like this where the screw is outside of the bone and not actually engaging the issue. Distraction technique, only a couple of studies out there. Wayne Poprosky and Scott Sporer wrote the original paper back in 2012. We did a follow-up paper in 2018, and Matt Abdel's group in the Mayo Clinic has put out their paper just last year as well. What we've basically demonstrated with this technique is you're getting 70 to 90% healing of the discontinuity radiographically. I'll give you some preliminary data from my own data set, 27 patients with chronic pelvic discontinuity that have a minimum of 1 year follow-up. A little less than 20% of the patients have died from other causes subsequently after their surgery several years later. But 22 patients final, which have a minimum of 12-month follow-up out to 9 years of follow-up. Thankfully, I've only had 2 patients who've had an infection that required an IND, really head exchange, not so much a liner exchange because these are cemented liners. And thankfully, we've had no instability and no revisions for aseptic loosening of the components. Post-operatively, these patients are seen pretty regularly at 2 weeks, 6 weeks, 12 weeks, and then beyond that, 6 months and a year. I keep them touchdown weight bearing for the first 6 weeks. When I have 3 serial radiographs that have not changed, then we will basically move them on to 50% weight bearing, and then hopefully their weight bearing is tolerated by 12 weeks. And I typically have them use a walker and a brace like this for 12 weeks just to protect them as they're rehabbing. So I'm just going to go back to this case quickly. This patient was treated by an outside physician. Thankfully, the patient was not infected. They planned on plating this because they thought this was an acute discontinuity. And you can see that the hip center was really elevated about 2 centimeters compared to the native hip center. Unfortunately, they decided to remove the stem because they had gross instability. And in that, during that time, they fractured the femur, and they had to dual plate the femur and revise the stem then to get it stable. The patient was sent to me about 3 weeks later. This was our 2-week post-op x-ray, but you can see at 3 weeks, that bottom screw in the ischium is starting to pull out. The patient was in a significant amount of pain, couldn't even move in bed without pain. So I think this patient needed another revision because I don't think that construct was holding. We had the hip aspirated, even though her sed rate CRP were normal and she did not have an infection. But we went in and took everything out. And I can tell you this was a very complicated discontinuity because one of the discontinuity pieces had split into 2 pieces. So now we're dealing with 3 fragments actually all together trying to get this to hold. But the principles were the same. We put the distractor in, distracted the acetabulum to get some compression across, put 2 augments back here to span the defect, put a cup in, very nice 50 millimeter screw down the pubic ramus, another screw posterior for supplemental fixation, and we revised the stem because the stem was slightly undersized. And she's now at about 6 months follow-up, actually ambulating without any pain, and has now come off of her walker. Thank you for your attention.
Thank you. Thank you, Dr. Sheth. We will get back to you again after the talk for the discussion. And now we move to the next speaker, Dr. Jana Bunstein, regarding this topic on spinal hip relationships in total hip replacement.
I'm assistant professor of orthopedic surgery at Yale University, and today I'm going to be talking about the spine relationship in the simple way that I use this in my clinical practice. So why should you care? Well, up to 40% of patients with hip osteoarthritis that undergo total hip have age-related lumbar spine disease, and this number is just increasing. As between 2002 to 2014, there was almost 300% increase in patients with prior lumbar fusion undergoing total hip. And that 17% of patients with postoperative instability have unknown etiology, and the best treatment for dislocation is prevention. It's important to recognize these high-risk patients ahead of time so we can potentially treat them. And then we may want to optimize their treatment. Does approach matter? Even though we know that patients with total hip and concomitant spinal deformity have a high rate of total hip despite acetabular position and traditional osteotomy, it's still important to take extra care of those patients. So the first step is to understand the normal hip-spine relationship. So that is a healthy flexible lumbar spine and lumbar pelvic complex interacting with healthy flexible hips, with the goal of having the center of gravity of the trunk position so that it is supported by the femoral heads. So first we're going to go through some terms to understand that allow you to better interpret the patient's lumbar spinal relationship. So that the sacral slope between here and angle 1, the pelvic tilt in angle 2, pelvic incidence, which is a morphological parameter constant for a patient independent of position, angle 4, and lumbar lordosis in angle 3. Angle 5 is the acetabular tilt or anti-inclination, and angle 6 is the anterior pelvic plane. Other things to know is that when we talk about anterior tilt of the pelvis, we talk about the upper portion of the pelvis tilting forward, and that the change in sacral slope is considered a good surrogate measurement of pelvic tilt change, and is overall easier to measure and more reliable on 2D radiographs. So normal motion for the pelvis is a standing position. You have relative anterior tilt of the pelvis. The sacral slope increases. There's decreased acetabular anteversion, a vertical anterior pelvic plane, and increased lumbar lordosis. And sitting in a normal flexible spine is just the opposite. There's posterior tilt of the pelvis. The sacral slope decreases. Have increased acetabular anteversion and decreased lumbar lordosis. We have to discuss late dislocations because after the first 12 months, we're not quite out of the woods yet. Many of the popular studies talk about early dislocations associated with spinal pelvic abnormalities, but it is also caused by factor for late dislocation, as these spinal pelvic abnormalities can just develop as patients age and result in instability. So it's important to screen for this in patients undergoing revisions for instability. And this is seen with both anterior and posterior dislocations. The vast majority of these patients did have spinal pelvic abnormalities. So first we want to classify lumbar spine pathology. First we want to decide if the spine is stiff or flexible, and then decide if there's appropriate sagittal balance. So for flexible imbalance, these are patients with no prior spinal conditions, with fully mobile spinal pelvic junction, and they're actually able to normally compensate for any motion between the pelvis or spine, so they're able to move flexibly. The flexible and unbalanced are those with post-laminectomy kyphosis and increased pelvic retroversion during standing to accommodate for sagittal balance, which can lead to posterior impingement and anterior dislocation. Then there's rigid imbalance with patients with significant degeneration, long local sacral fusions, and the spine's balance in a standing position results in less posterior pelvic tilt when transitioning to sitting. And because of this rigidity, the acetabular anteversion doesn't increase during sitting, it can lead to loss of anterior clearance, anterior impingement, and posterior dislocation. These are traditionally called substanding patients. And finally, there's rigid and unbalanced. Those patients with significant ankylosis or long local sacral fusions with lumbar flat back deformity result in unbalanced spines. These are pathologically unstable. When they sit at normal acetabular anaversion, when they stand, they maintain this increased anaversion, which leads to posterior and anterior dislocation. And these are radiographic examples of each of those types of spinal pelvic abnormalities. You see flexible and balanced are able to compensate fully all the way to rigid and unbalanced, where the patient has very little lumbar lordosis, even when seen. So once we've identified the type of pathology, the question is, what do we do about it? And these are some basic recommendations that can be made. So for flexible and balanced spine, you just stick with your standard seat zone. For a rigid and balanced spine, you want to be slightly more anterior than normal to prevent anterior impingement. For flexible and unbalanced spine, you want a standard safe zone. And for a rigid and unbalanced spine, you want to do slightly less inversion to prevent posterior impingement and anterior dislocation. With both the flexible and unbalanced and rigid and unbalanced spine, there is a role for spine surgery to be done first if patients considering that to convert them to a rigid and balanced spine, which is slightly easier to deal with. Other considerations include navigation or robotics to make sure you're more accurate with your cup position, as well as using dual mobility in some patients who are extremely high risk. So for preoperative evaluation, I screen all patients with recurrent lumbar sacral disease, especially those with lower back pain or history of spine fusion. I also look at all their standing feet and pelvis to see if there's any sort of abnormality with the way that they're holding their pelvis in space. For those who I'm concerned about, I get lateral lumbar radiographs in the sitting and standing position. And I would recommend using EOS if you have it, which allows you to not only see the spinal deformity, but also to see that as a result of hip flexion deformity instead of coming preoperatively from the spine. Intraoperative consideration. So if you have an accurate goal, accurate tools needed. So the navigation robotics and fluoroscopic-based navigation have all been shown to improve accuracy. There's still no evidence that this decreases dislocation rate, but it does increase precision. And additionally, the use of dual mobility has to be weighed with the risk of using this device. So we know that dual mobility implants have total hips stable when compared to patients with unstable total hips with conventional implants who both have similar cup position. But we're not going far enough to recommend these for all high-risk patients at this point. The concern for the backside wear of lymphocysts. So we do recommend potentially on spine degenerated elderly patients, or consideration in patients with kyphotic spines or stuck sitting deformities, as these pathologic imbalances cannot be overcome by a cup position. So this is my stepwise approach to hip spine relationship and total hip replacement. Preoperatively, I get AT pelvis and standing, which includes the lower lumbar spine, and I screen for lumbar spine disease or prior surgery. If concerned about possible lumbar spine pathology, then I obtain sitting and standing lateral lumbar spine films. I calculate the numbers and classify if the patient has a flexible or stiff spine based on the change in sacral slope. Then classify if the patient has a balanced or unbalanced spine, looking at pelvic tilt and pelvic incidence minus lumbar lordosis. I decide on my goal acetabular version. I consider using dual mobility in unbalanced patients or elderly rigid and balanced spines. I consider using intraoperative technology to improve accuracy and precision of cup placement, especially in high-risk dislocation patients. And very importantly, I make sure patients with spinal disease are educated preoperatively about their elevated risk of dislocation. So thank you for your time, and I'm very happy to be here.
Go to the question answer. Thank you, Jenna. Thank you, Jenna, for a lovely exposition of spinopelvic balance. So the floor is open for questions if there are any. So can I ask Neil a question?
Yeah.
You there? Yeah. So
Yeah.
how often do you feel there is a need to bone graft these pelvic discontinuities, especially the chronic ones? And what kind of a graft do you use in case you do?
Yeah, so I think that the graft that I was using was cancellous bone chips, right? Just basically packing them in and impacting them into the discontinuity. I will tell you, I think over the last 3 or 4 years, I've decreased the amount of graft that I'm using. And I just think that having good compression across that area with a porous metal implant will be enough to get that to heal. So I'm just using less allograft just because I'd rather not put dead bone in that situation where, again, there's high risk for these big surgeries, and I don't need it to basically wait for incorporation.
Do you think would there be any concerns when these patients come up for revisions? Because a lot of them are younger patients as well.
Yeah, I think that I think there is, I still think there's a role for some of these younger patients for impaction bone grafting and cement, trying to reconstitute some of that bone. My experience has been most of these patients are elderly patients or have had hips in for a long time, and a lot of them are small women with a small stature pelvis, which we don't have a lot of options, especially when the defects get big. So I'm not sure what's going to happen long term with this, but I think if we can get that bone to heal, I think we have a better chance to revise it if we need to. The other thing is that some of these augments are so well incorporated that they become part of their bones, hard to remove. So it may become a situation where the cup may loosen over time, but the augments have still remained in position and are well ingrown.
So on that topic itself, you have a patient with a small pelvis where you can't use a large tantalum cup. What are the results of plating and reconstruction with uncemented socket?
Yeah, so this is a problem I think you guys see in India very commonly, because I think most patients have a smaller pelvis and not getting to a big size. In those situations, the Mayo Clinic has some very clean data on the fact that plating of a chronic pelvic discontinuity does not work well. They've tried that and it doesn't seem to work well because, again, that biology is disrupted and it's probably not going to heal. So I have not had any experience with that. The only time I've ever plated anything in the discontinuity situation if it's truly acute.
Okay. Neil, I want to ask you that, do you have ever encountered a situation where you have to cement a cup after putting augments or bone grafting? And second, what do you do in a cup cage construct? Do you cement the cup?
Yeah, so I have not come across one. I mean, at this point, it's 11 years. I have thankfully not come across a situation where I've had to cement a cup, meaning just a fresh liner and not into an already porous metal shell. And I have I've not used a cage yet. Again, I think this allows me to essentially create an intraoperatively customized tri-flange based on what I see. And again, I worry with cages using that flange inferiorly into the ischium, specifically when the ischium has a significant amount of osteolysis and bone loss. The other thing is that I think over time cages break. It's a flexible, over time it's not going to get ingrowth, it'll become flexible, and at that point, your cup may be already healed, but again, it's another surgery for the patient that if we can avoid that, that might be better for them.
Neil, one question to me. If there's a severe posterior superior bone loss, would not prefer to give a high hip center instead of using graft or the augments and put a jumbo cup? And if high hip center, how much you can go, how far you can go for the high hip center?
Yeah, very, very good question. So there's some good data out there. If you look at Mike Reese's paper, it's actually about 10 years ago, I think 2010 is when they put this out, looking at the effect of high hip centers in bone loss cases. I think the higher you go with your hip center, you end up losing a little bit more bone anterosuperiorly as you're trying to accommodate this full hemispherical shell. That's number one. Number two, I think there's some situations, depending on the length of the deformity and how short they've been, it may be very difficult to restore that hip center perfectly. If I look at that, you do not want to have your hip center more than 50% of the height of your teardrop. So that should be the limit of max of what you can do, which is probably about 1 centimeter higher than the native hip center. But I think in all of these cases, I think restoring the biomechanics is critical. So getting your hip center perfect is an extremely important part. I think that helps with the biomechanics of the soft tissues. I think also helps with implant longevity. And again, if you can get that hip center right, I think you have a less likelihood that you're going to get unstable and have abduction failure, especially in that case where you have a lot of posterior superior bone loss.
My question to Jenna regarding the spinopelvic problem. So most of the literature is from older literature where the spine fusion has been done in a odd position. They are not addressed the sagittal alignment. So now the spine fusions are happening in the proper alignment. Is it going to be a problem in the future, or is it not going to be a problem? Because we don't face that many problems in our country, except in ankylosing spondylitis.
Yeah, so that's a great question. And it's true that now we're not fusing as much in situ, that they're really trying to restore sagittal balance. But that being said, the two problems I think we still will see are the patients who develop arthritis long term, and then they change their spinal pelvic balance as they age, and late dislocations. I think that will continue to be a problem. And the other thing is when patients tend to get, at least here, still L5S1 or lower level spinal fusions, they tend to still use in situ fusions. For many of those, they're not always correcting when it's really 1 or 2 levels. And those lower lumbar levels are where we get most of the movement in our spine or in our pelvis. And so if L4 or L5 or L5 or S1 are fused, even if it's not really changing the overall alignment, with those just lower level fusions, you still are at an elevated risk of dislocating. So I think those are the two problems we'll continue to see. It may not be anymore like the T12 to pelvis fusion. When that's restored with, good lumbar lordosis, that may not be as much of an issue going forward. But again, it's really those stuck sitting flat back patients, or the ones with just lower level fusions, or people who develop spinal abnormalities later in life.
Okay.
One question, sir. One question.
Yes.
The question to Jena. My question is, if in cases of unstable spondylolisthesis more than grade 3, would like to fix the spine first and go for THR, even the THR's hip is very painful, and what you do? What is your planning?
Yeah, so that's usually the goal, right? If if you know that they're going to have spine surgery and they're going to have hip replacement, we almost always try and coordinate with the spine surgeons to do the spine surgery first. And that's if someone's already kind of knows that they're going to have spine surgery. The difficult part is if you think someone would benefit, but they're not already in the mindset of having spine surgery, then usually for those patients are the ones that I'll use dual mobility in. And I try not to use dual mobility for a large number of primary patients because of the question for, backside metallosis and all the other issues, or interprosthetic dislocation. That being said, those patients are the exact ones that I do think benefit from either using a large head if you're able to get to that size, or from a dual mobility.
My question to Jena. So normally when we talk about the spino-pelvic relationship, we move from spine to pelvis. And then we think about the compensatory mechanisms at hip and the knee. But now the concept is changing that, the reverse is also true. So if there is a problem at the knee, it can also lead to changes in this thing. So do you think that now we should talk about the spine, hip and knee relationship rather than the only the spino-pelvic relationship? And my other question is that the about the pelvic tilt, you talked about the 25-degree value. So now a lot of literature is coming up that this 25-degree value is not universal for every person, because there's a wide range of pelvic incidence among the population, and we should be actually looking at the logarithmic tables to look at the actual pelvic tilt for a particular patient.
Yeah, so to answer your first question with regards to hip, spine, knee, Jonathan Dorkchik is writing a lot about this, and it's very complex when you start to talk about the full body alignment. And I think a lot of that, when they talk about the issue with the hip spine, is hip flexion contractures, because that does really change your sagittal balance if you have that. And that's the benefit of using the EOS if you have it, is that, yes, you can examine someone and check if they have what their balance is, but you're able to better see that and identify that problem when you're doing full length imaging. I don't personally look at the knee specifically at this point. I think that that's too much for me. I think that's why people kind of don't always think about hip spine relationship when they're actually thinking about clinically, not just speaking on the podium, is because when you start to add in all of these numbers, it becomes too much to clinically be relevant to the patient. And then we're talking about what, a 3-degree difference, a 5-degree difference. And then if you're not using technology, is anyone really good enough to dial that in? And so that's why, this algorithm that I talked about was really what I use clinically. So that takes kind of all of the data that I've seen out there, that I've seen, working at some institutions that talk a lot about hip spine, and really dumbing it down for myself, in a way that's clinically relevant, that I think is still having good outcomes for the patient, and that isn't leading you off some path where you're trying to calculate all these numbers and you're questioning what the relevancy is. This is kind of, how do I use this data that's out there, that I know this is an important issue, and yet it's not totally granular yet, how we should use it, and putting it in an algorithm that is somewhat clear, at least for me to be able to follow. Someone who's not, Jonathan Dorchek and is using 3D, augmented reality to put in joint replacements.
Yes, Dr.
Neil, I want to ask you, now it seems that everybody is moving away from the impaction bone grafting techniques for revision acetabular defects. What do you have to say about impaction bone grafting techniques and cemented hips, particularly for younger, acetabular defects?
I think it's still a very good technique. I think the data out there is good in the long term. I mean, I've seen some beautiful x-rays from India or from South America where they have very long-term results on patients with impaction bone grafting. And again, like we talked about before, that is a chance to restore some bone stock, assuming in a young patient they're going to need another revision done at some point in their lifetime. But this is, I think, is a technique that is very technically demanding. You have to do it all the time. You can't do it once a year or twice a year and say, yep, I can do impaction bone grafting well. I think it has to be something that's partly done, every month. You got to do a couple of these cases to be able to be good at it. I know that in India and other countries, their cost is an issue for patients, right? So patients may not be able to afford some of the technology of porous metal and modular augments. And as a result, the cemented cup with impaction bone grafting may be the best thing that you can do for the patient. But I think just as we look at some of the data on impaction bone grafting, we just worry about any type of allograft that you're using, that there's going to be resorption as you get out to above 10 years. So I think that's probably one of the biggest pushes. I was just on a call on Thursday, similar conversation or panel discussion, and talking to some guys from Argentina who have shown some beautiful x-rays over the years, but even they have moved completely away to going cementless on any of their defects, cementless constructs for their acetabular defects. So I think people have just moved away from it and thinking that they're going to get better results with bone ingrowth.
Thank you, Dr. Neil and Jenna, for the wonderful lectures and useful discussion. Thank you for staying late and participating in this program. Thank you very much.
Thank you. Bernstein, it's good to see you.
Yes, you too.
Thank you, sir. So as we know, we had planned 2 live surgeries for today. The first being navigated total knee arthroplasty and a total hip arthroplasty using dual mobility. And for the interest and the demand from the delegates, we have also added a third surgery, that is total hip arthroplasty by direct anterior approach. For the next session on revision total joint arthroplasty, I would like to call Dr. Yatindra Kharbanda and Dr. Krishna Kiran to moderate the session.
Good morning. Welcome back. We had a simulating session in the morning on spinopelvic relationship and hip instability and acetabular defect management. So moving on with the more complex topics, we'll now have a session on revision total total joint arthroplasty. So the first talk again is by Dr. Jenna Bernstein, options for antibiotic spacer placement in PJI in TKR.
my name is Jennifer Bernstein. I'm assistant professor of orthopedic surgery at Yale University. And today I'm going to talk about the different types of spacers for knee prosthetic joint infection and which ones are recommended. So as we all know, prosthetic joint infection is an ongoing problem in arthroplasty surgery, and currently two-stage exchange remains the gold standard for PJI. There is some current evidence to support doing an articulating spacer over a static spacer if possible, but as different types of articulating spacers have risen to popularity, it is important to continue to review current consensus. So having a PJI and a spacer is an ordeal for a patient that should not be underestimated. As we continue to consider what type of spacer to use, we should really think about the patient's overall psychological well-being when we decide what we're going to do. So of course, when we discuss spacer, we have to talk about the cement and the antibiotics. That's what gives efficacy to the spacer. The three important things to discuss are the evolution characteristics of antibiotics, the type of cement being used, and the mixing technique. All of these contribute to the efficacy of the spacer and also longevity. We do want to point out that the mixing technique recommended is always hand mixing antibiotic with cement without a vacuum, as this increases porosity and helps with the elution of the antibiotics. The other thing to always note is that mixing Tolbert and dilute will actually help increase the elucidation of both, as when they start to elucidate and form pores, it also promotes the elucidation of the other antibiotics. So this is one of the first studies to compare static versus articulating spacers. We found that static spacers were actually reinfected more, and there was additional bone loss from using the static spacer. This is a common theme of results seen when reviewing and comparing static and articulated spacers. This is a large meta-analysis that was done to compare static to articulating spacers, and again, the benefit is the function at the end, no difference in reinfection rates between the two. The benefit going towards using articulating spacers. In this review, they recommended static spacers for the following reasons. Severe uncontrolled infection, which we'll discuss in the next article, those with ligamentous instability, insufficient extensor mechanism, compromised soft tissue, severe bone loss. They really did reinforce the big benefit of static spacers that they cost less. This is another systematic review. They actually defined what complex patients were with regards to infection. So these were patients with culture positive for virulent organisms and AORI grade 2 or 3 bone loss, presence of draining sinus tract, and they actually found that there was a higher rate of reinfection of complex patients when they had a static spacer, and then the articulated spacer did better. They also found that with articulated spacer, they had less need for extensile measures for exposure or for any rotational collapse. So again, they recommended doing a articulated spacer whenever possible. So these are the main reasons when I use a static spacer. I really think that infection eradication is equal between static and articulating, and the question about whether to do an articulated spacer is it going to be well for the patient? Because that's the whole point. So this is the construct I use when I need to do a static spacer, which is usually a nail, either a small tibial or retrograde femoral nail, and antibiotics that load into the joint when someone holds gentle traction and holds the leg in alignment. And while using this nail is more expensive than some other constructs, the benefit is that the patient is allowed to weigh very greatly improves their tolerance of having the spacer in place. And I just want to reinforce that I'm not saying this product and static spacers are not effective or not good to use. We're just looking for a way to make surgery more tolerable for the patient and making the second stage surgery easier for the surgeon and less complex overall. So in summary, for static spacers, some studies did show they had a higher reinfection rate. That's probably not true, but there is definitely additional bone loss with static spacer. It restricts mobility of the knee joint. There's difficulty exposure at the time of the second reimplantation, and patient satisfaction is lower. The main pro is really that it provides rest for the soft tissues and it's cost saving. Whereas articulating spacer, there's concerns about subluxation and disabilities. The key is to make sure that you're spending enough time balancing the spacer the same as you're balancing your revision knee. And that's really the way to make this an effective surgical procedure for the patient. It definitely can be more costly, but the pros are no significant difference in reinfection rate, potentially lower reinfection rate, and I was shown actually to do better compared to static spacers for chronic infection. and really improve range of motion after the second stage. So recommendations is that an articulating spacer should be used most of the time unless the patient meets the requirement for static spacer. So now we know we're trying to use an articulating spacer if possible, but there are two main types of articulating spacers currently used: a all cement-based articulating spacer versus a real component spacer. And this retrospective review actually looks at three types. There are those two that I mentioned, and also an autoclave that the previously removed implants. This we are currently not allowed to do in our hospital, but they did find that all three had similar rates of reinfection. The autoclave one was obviously significantly less expensive than the other two types of articulating spacers. This is a multi-center retrospective review that I was involved in, where we reviewed articulating spacers, either real component versus all cement, and we found there were less overall operations when we did a real component articulating spacer. This is mostly due to a difference in mechanical stability, where the implant-based articulating spacers were much more stable and less likely to fracture and sublapse or dislocate. All component spacers were also associated with decreased length of stay and higher likelihood of discharge tone. And importantly, real component spacers again were shown to be equally as good at infection eradication, which is important to demonstrate to many surgeons who have not yet started using this technique, as they can be very concerned about the idea of putting real implants in effectively. And here's another systematic meta-analysis that showed a benefit of real component spacers with fewer reoperations again and no difference in reinfection. And here's an example of all of the different types of articulating spacers they talked about. So to the left here is the real component spacer, and they have different types of cement on cement articulating spacers. So in summary, a real component articulating spacer is a reliable construct. It can be lower cost if you're able to retain the original femoral component, lowest complication rate, and may have the best range of motion. And you may be able to extend the time frame of keeping the spacers in, which we'll discuss next. Summary of all cement articulating spacers, there's really not a lot of benefits to using this at this time. The long-term, the previous concern was that the real component spacers potentially allowed for new biofilm formations, and this really hasn't been shown in the literature. And the con is that it's not a long-term solution. There's concern for spacer fracture, dislocation, or subluxation, and concern for increased wear. So a question that has not been asked much, but I find kind of interesting, is what kind of femur to use for your real component articulating spacer, PS versus CR. And this study supports that the lower mechanical complications of PS and overall lower evaporation rates. So I think the key overall is just to have a well-balanced spacer, and if you can do that without taking more load and putting in a PS femur, then there may be some benefit for bone preservation. And then another question that comes up is whether or not to use dowels in the canal. So this study did not support the use of dowels with articulating spacers for infection eradication. It again did support articulating spacers chronically infected patients compared to static spacers. I will say that I lean towards using dowels. I don't use dowels if the canal had not previously been violated. Say if I did navigation or robotics where you're not going into the canal, but if the canal had been previously violated, then I would consider the use of a short dowel. And so there's an obvious segue between doing real component spacers that are long-lasting and doing a true single stage. And although this goes somewhat beyond this talk, I just want to recognize that multiple studies report doing this 1.5 stage, where many patients have their articulating spacer in place for extended periods of time and get out. And so this study compared doing a functional prosthetic spacer that was left in place versus a 2-stage with all cement articulating spacer. Again, found that infection eradication was similar, but the real component spacer allowed for just a single surgery to be done, less time in the hospital, and overall cost. Here's another study showing a similar thing, that retained real component spacers had good survivorship and be able to extend their life beyond the typical time frame of spacers. So recommendations: either option articulating spacer is appropriate. Real component spacer is more functional for patients, And if the patient is a poor surgical candidate and you want to try to knock down a real component spacer, may allow for a single viral surgery. Thank you, and thanks for having me.
Thank you. Jana, I think we'll take the questions once we have the next couple of talks done. The next talk is the place of hinge, TKA, and revision, Dr. Andre Ferreira.
Dear colleagues, so what is the place of hinge TKA in revision? That's really a question because we don't use it a lot, about 10% of our activity, but it's very important. So what are the objectives in case of revision? Of course, reconstruction of the joint. Why to reconstruct it? Because when we remove the primary components, we find a lot of loss of bone. And then we have to solve different problems, the bone defects, the stability, and if possible, to limit the risk of infection. So we can resume the indication in 3 parts. First, bone loss in case of infection or not, that's the same. But the real problem is about ligaments, because the real indication of hinge is instability or stiffness or patella bara. And of course, the other reasons are periprosthetic fracture and revision of constraint prosthesis. In case of bone loss, the question is where are the ligaments? If we have to cut the bone above the ligament insertion, then we have to use a hinge prosthesis. And most of the time, it is due to difficulties to extract implants, and then we have to reconstruct, of course, with many sleeves or so on. So the question is, where will we fix the revision TKA? It is in the metaphysis, because if we can fix it in the epiphysis, we can use a normal TKA or a CCK. But in the metaphysis, it's the best area of fixation. With a high fixation, no problem, no increase, no stress after surgery. But in case of low fixation, we have to bridge to use sleeve, cones, and graft to reconstruct the local bone, because we know that the survival of the hinge depends directly on the quality of fixation. So that's the reason why we can use 2 classifications about bone defect, the ROE classification, and you can see in red the real indication of hinge in case of metaphyseal lesion of the 2 condyles or destruction of only 1, but including ligament insertions. The second classification is the ENG1 in 3 types, and in the third one, that's exactly the same situation, significant metaphyseal substance loss that leads us to use constraint TKA, allograft, and most of the time hinge. So this example of a 45-year-old man who suffered from hemophilia with the ascending loosening of his first TKA, it seems to be not so bad, but when we consider exactly the bone loss before removing the implants, we can see that the tibial in medial plate is suffering like the condyle. So we will need a hinge in this case. Infections is exactly the same issue about bone loss. Instability is more interesting because we can have in sagittal or in coronal plane. In case of an isolated instability, most of the time we can use a normal TKA or a CCK. It depends on the joint line, of course, and the gap balance, but most of the time it's not so hard to reconstruct. But sometimes when there is a major instability, we have to use the hinge when there is a severe stiffness or imbalanced ligament balance. And most of the time, with a sagittal instability, we have to use a hinge. Patella bara and stiffness are almost the same problem, and they allow the joint line modification. So if we consider the literature about hinge, we can see that in case of revision, the survival is not so bad, about 90% at 5 years. But in case at the end of this literature, in case of first use in primary, you can see that the most important complication is infection, about 14% at 50 years old. So the French Society of Orthopedy had led a symposium in 2017, about 127 patients, more women, close to 70 years old, and with a follow-up of more than 5 years. We can see that this population has a very high rate of cardiovascular disease and comorbidities in general, and 1/3 of them are obese. Previous surgery were frequent. Only 1/2 of patients had only one intervention, and less than 10% have more than 3. The causes of revision are mechanical loosening most of the time, but sometimes perioperative laxity or mechanical fracture. The first prosthesis was most of the time a PS1, but you can see that 1/4 have had already a constrained implant. The surgical technique was very classical with a medial approach and osteotomy of the TTA. The bone defects were constructed with wedge, allograft, or autograft. And most of the time, the fixation was cemented. And you can consider that the polyethylene was frequently very large, the average of 15, but sometimes more than 20 millimeters. That leads to the creation of the joint line, of course. At more than 5 years of follow-up, we consider the Divan score. Why? Because the Divan score is important about the autonomy of the patients. And we can see that there is a loss of autonomy at more than 5 years of follow-up, probably because of the quality of this population with a lot of comorbidities, but not only. Even if the IKS score is good and the bending is about 100 degrees, and the average score in his old version is medial at 30. In case of aseptic revision, the complication was 1/3 or less, and about extensor mechanism most of the time, but sometimes with revision with, of course, a lot of reinfections. 12% disease, it's about 10%, but at the end, less than 80% implants were in place at more than 5 years old. So in conclusion, we can see that in this population, there is a overall decrease in autonomy, even if the average functional results are good, but not so good that with a normal TKA or a CCK, for example. 1/3 of the completion seems to be very high, but we have to take in consideration the population and the comorbidities before surgery. Half of the complications are not reported for the same reasons, because it's a very fragile population with a high death rate, but it's senior population. Remember that the average age was 70 years old. However, close to 80% of procedures are in place at more than 5 years. So to answer to the first question, what plus for hinge TKA in revision, first answer is instability. Instability not reversible, instability because there were previous constrained implants, because of the fragility bone, or because it's a rescue within surgery. And of course, we have to plan before. So it is precise, yes, prompt, I'm not sure, perfect, not at all. So what is the algorithm? In case of revision, without instability, most of the time, we don't need a hinge, except in case of a recurvatum, because the sagittal instability is very difficult to treat. In case of ligament failure, we have to consider the quality of the fixation, and it depends of the bone loss. With a very good metaphyseal bone fixation, we can use a CCK. In other cases, with a less good fixation, or in case of a very high bone loss, reconstruction with hinge is mandatory. I thank you for your attention.
Thank you. Can you take seat beside us for the questions after the?
Okay, so now we invite again Dr. Neil Sheikh for his lecture on challenges in total arthroplasty in the next 10 years.
Can you see these slides?
Yes, we can. Thank you.
Thank you again. And Andre, it's nice to see you. I'm surprised you didn't give your lecture in Hindi, since every time I've seen you, you've been able to speak 4 different languages and present in the native language of the country. So I'm going to talk about a topic, I think, of what I'm worried about in the next 10 years in joint replacement in the United States. And I think that the market in India, market in France, different parts of the world may be different, but I think this concept is going to come forward, I think, in every country in the world as we talk about joint replacement patients. We have known for a very long time in the United States that cost is a big issue for healthcare. We spend a tremendous amount of money every year on taking care of patients in the United States healthcare system. We have come up with this concept of bundled payments, where you get a payment value for what you provide. So if we do total knee replacement, for example, you get a single lump sum payment for that whole entire episode of care, which includes seeing the patient in the office, doing the preoperative workup, doing the actual surgery, all of the associated costs with the time of surgery, any type of length of stay in the hospital, plus their physical therapy, rehab, all comes out of one bundle. So whatever you can do to minimize the cost going out leaves you with a bigger lump sum payment for the hospital. As a result, there's been a huge push in outpatient total joints. You can see a majority of the literature for outpatient performance of joint replacements is coming from the United States. And if you look at this chart just over the next 5 years, you can see that we're going to be at a much bigger section of the population of being outpatient procedures. But I will tell you that that 51% in 2026 is an underestimated value, because right now in 2021, we're probably closer to 60% already of all joints being done as an outpatient. Right? Inpatient only list has been removed for total knees and total hip replacement in the last 3 years. So these are no longer considered strictly inpatient or in-hospital procedures. If we look at the average cost, look at the cost differential of an inpatient joint replacement versus an outpatient joint replacement. So clearly from the insurance companies, and specifically Medicare, which is the biggest insurer for most of our older patients, this is a huge benefit for them if they're decreasing the amount of spend. The interesting thing is, the reason that total knee replacements came off of the list first before total hip replacements was solely by the fact that Medicare's #1 and #2 spend is total knee replacement and total hip replacement. So they figured they'd make a bigger impact if they can get knee replacements to be done as an outpatient. Again, you can see the proposed reimbursement. This is as of 2018. Some of the data is still changing, but you can see that the outpatient rate is looking to go down significantly to less than $10,000 per joint replacement. And we're only doing more hips and knees every year in the United States. So how does this work, right? So if you are a surgeon in the United States and you work at a private practice, typically most private practices have an ambulatory surgery center. As a result, as a surgeon, you will have a share buy-in, which means you are a part owner of that surgery center. That surgery center is profit-based, based off of utilization. The more cases that are performed, the more profit it will make. And that's across all subspecialties. So even if it's ENT, if it's urology, whatever it is, it doesn't matter. It's not just orthopedics. The reimbursement per case is less. However, you get more money on the facility fee as a part owner of the ASC. Again, as a surgeon, it's a much better lifestyle. You have no turnover time between cases. You have no inpatients. There's no rounding. You can things run much more efficiently in a surgery center. So it's not so bad. If you look at the picture on the right, that's actually our rapid recovery unit inside the hospital at Pennsylvania Hospital where I work. And again, we get these patients rapidly recovered through there and out of the hospital either the same day or the next morning in 23 hours. So what's happened to patients? Now inpatients now require pre-certification from the insurance companies, which means insurance companies have a higher likelihood of denying a claim to say that the patient has to be inpatient. This requires sometimes for myself or someone from my team to do a peer-to-peer review with some physician at the insurance company. And if they even listen to your peer-to-peer, the typical average time in Philadelphia is 42 days for them to make a decision on whether a patient can basically be done as an inpatient. And this is really for specific insurance companies, but a lot of insurance companies have followed suit and are doing the same thing. The problem we have is that specifically for Medicare patients that are now all outpatient is they say that you need a 2 midnight stay in order to be considered an inpatient. Most of our uncomplicated, straightforward total joint replacements go home in 1 midnight, which means grandma had her hip replacement done on Monday and she goes home Tuesday. This is considered outpatient. And now patients complain because they get a bill for certain services that are not covered under the outpatient coverage, which is in-home physical therapy and in-home visiting nursing. This unfortunately does not take into account any of the patient's social situation on what kind of social support they have at home. And as a result, and also total joint replacements are not all the same. If I look at this patient, right, this patient has post-traumatic osteoarthritis of the knee with a significant amount of deformity, bone loss with plates and screws in place. We can do that knee replacement, but I would be concerned on this patient that they may have wound issues. I've had to potentially use a previous incision, but this person, if they're 50-year-olds and healthy, I will not be able to get the insurance company to cover them to stay in the hospital for 2 days. They would have to go home within a day or as be considered an outpatient. Okay, compared to a patient who may have the same diagnosis code who ends up with a partial knee replacement, there's no way for insurance companies to understand the difference in surgical complexity between those two cases. All right, so there's no orthopedic severity index. And what about revision? We're just talking about primary joint replacement. What happens when you get this individual comes in with a loose proximal femoral replacement? The guy's leg is clearly long. He's had multiple surgeries on this limb. He ends up getting a total femur replacement. Everything goes smoothly. But what happens? Where does this guy go? How are we going to pay for this guy? So the 3 challenges I'm going to talk about in the last few slides of this talk are basically what I think we're heading towards, and they're all basically on one principle. At this point in the United States, we are being forced at a very, very quick pace to start treating numbers and not patients. And what I mean by that is every quality metric we look at, these are dashboards that come out at Penn every single month. They look at length of stay, percent discharge to home, percent discharge to rehab, what was your readmission rate, reoperation rate for any of these patients. And again, I will be at meetings where they'll look at the primary joint replacement, they'll look at length of stay or discharge to home and say, wow, you know, last month your discharge to home percentage dropped a little bit. It's trending in the wrong direction. And the unfortunate thing is we can't predict exactly what's going to happen with length of stay, and we have no idea who's walking in the office tomorrow that still may need care. While doing all of this, they still want us to maintain top line growth, which means increasing the number of surgeries we're doing per year because that's how they make money. This has led to a significant amount of focus in the last few years, more so than I ever heard when I was in training, on being one of the best hospitals in the US and trying to make it into the top 10 list of US News and World Report. The unfortunate thing is those metrics are what are looked at in order to get your rankings. So the second challenge is a second component of this is that it's becoming harder and harder to do the right thing for patients. Okay, look at this gentleman, 53 years old, right total hip replacement is probably indicated based on this guy, even his left side, but his left side doesn't hurt him too much. And we do a total hip replacement through an anterior approach, fairly routine, nothing too crazy, other than the fact that this gentleman's 53 years old, lives by himself, and has cerebral palsy. But this guy is going to make my metrics look bad. It's going to make the hospital's metric look bad. He's not going to be the person who's going to help us get into that top 10 ranking. And again, that's what a lot of our administrators are focused on. And I think the biggest challenge, and this all results in one thing, and I'm very concerned in the United States that patients are going to lose access to care. And the reason that things are so expensive is, right, these cases are longer, ICU level of care may be needed. There's a whole number of different subspecialties that are needed to take care of these patients. And especially if you're talking about complex primaries and revisions, the complication rate, readmission rates are inherently higher. And those patients, especially the ones that are not weight-bearing as weight-bearing as tolerated, are going to have to go to rehab and may not be able to go home. I think you got to figure out, where does your dial fit in? How many primary joints are you going to do? How many complex primaries and revisions are you going to do? And you got to figure out where you fit onto this graph, right? Where are most of the patients you're taking care of? And if your primary patients that you see are on the left side of this graph, this is going to be difficult because the incentive is not there to take care of those patients anymore. The problem is, what if your practice looks like mine? I looked at my last 3,500 cases and I was at just a drop over 40% revisions. And even if you look at my primary joint replacements, a little more than a quarter of them are complex primaries, similar to the one that I showed you before. So if you have that type of a practice, how do you continue basically hitting those metrics and taking care of those patients and trying to do the right thing with the team that is the appropriate team to do so? If I look at the trends in revision total hips, you can see all these colors with these graphs over the last 15 years. There's more and more revisions being done, and the cost is going on. Revision knees are no different. There's a lot more color on the right bottom screen showing a lot of different states that are doing more and more revisions. And again, cost continues to go up, and we're publishing this data currently in both the hip and knee literature talking about cost. There's also a huge migration to academic centers of the types of revisions that are going to those centers and not going to the rural hospitals anymore. So how do you solve this? I think there has to be tiered bundled pricing, alternative payment models that actually look at these patients differently than your standard primary patients. I think we need to use our leverage in some of these bigger centers against insurance companies to have them understand that all these CPT codes for procedures are not all the same. And I think it's really critical that we designate revision centers to say patients who need revision should only go to a handful of centers in a region. And those are the places that should get paid at a different level to take care of some of these patients. Otherwise, these patients are going to lose access to care. In summary, it's very simple. We're being disincentivized to take care of these patients. I think over the next decade, it's going to continue to trend in this direction as it continues to become more and more difficult and more costly to take care of these patients. And I think the biggest concern that I have is that patients over time will lose access to care if this continues the way it goes. Thank you for your attention.
Thank you. Thank you, Neil. I think we probably need to reduce our service charges, and that's what is happening in India.
Yeah, I mean, you guys have already reduced your implant costs significantly, right? Back in 2018, making an implant cost the same regardless of what implant you used. I think that has probably increased access for some of the poorer patients who don't have access to that. But in the US, I mean, everything is insurance driven, right? Patients don't have to pay for implants. But even some of our services that we take care of, I mean, our reimbursement for joint replacement continues to go down every single year. And so I think it's just going to be challenging to figure out a good solution that works.
Yeah, good morning. Good evening, Neil. I think we should be looking at marketing India as a center for patients from US to come home and get surgery done. So it'll be much cheaper for them to travel, get operated, and go back. So that's something we should be looking at seriously. And Jen, a question to you. Are you seeing an increase in the gram-negative polymicrobial infections in PJI? Because that's what is a trend we see in India. A lot of multi-drug resistant polymicrobial gram-negative infections coming in from the community.
We were actually at, my institution and both where I did my fellowship. Since we've now been adding gentamicin into our antibiotic regimen for all patients for their perioperative antibiotics, that number has dropped a lot. In terms of polymicrobial resistant, we see some, as a tertiary care center. Most of them are not from our own community. I've seen a few come in from long distance, from far away, that come in with polymicrobial, but really think adding in gentamicin for our perioperative regimen has been shown to really decrease our overall gram-negative infections.
Yeah, I think, that's the, Neil, I thought you would probably also talk about the challenges, the medical challenges, and infection is one challenge that we face a lot. in India. And so I understand from Jenna, from your talk, that probably the difference between the articulating and the static spacer is basically the range of motion that the patient gets post-operatively and the ease of inserting the implant. We use a lot of static static spacers here because of the cost and the fact that we don't have a already made articulating spacer. Have you encountered dislocations of spacers, and thereby what difficulties would you encounter in doing a revision?
Yeah, dislocations of static or of articulating? Because I of which static? Yeah, because I've seen both, and a dislocated static spacer is tough, and those tend to be the ones I think that were left in for extended periods of time. Not usually the ones that were left in for 2 months, but the ones that a patient was for some reason unable to return to the OR. And obviously the big issue is extensor mechanism disruption with that. And I think that's one of the reasons that with my static spacer, I went towards using a nail, which you're right, is more expensive. But it does provide more stability across the joint. I think with regards to the removal of the spacer or doing the revision surgery, if you're a static spacer where it's dislocated, obviously taking a lot of care with the extensor mechanism, being prepared to do an extensor mechanism reconstruction. I always have mesh available for those cases because I know that they're going to be stiff, and I know that there's a chance of extensor mechanism disruption either from the spacer or from even the exposure sometimes. And then also the degree of bone loss. So always having a hinge available for those cases, frequently having a distal femoral replacement available for those cases, because I know that those are not going to be standard revisions from static spacers. I will say that I don't know if in your hospital you have the ability to reuse a femoral component that was removed, autoclave it, and use that as an articulating spacer, because that really is the most cost effective and was shown in multiple studies to be the same reinfection rate as an articulating spacer with novel components. We're just not allowed to do that. Our hospital won't allow it, despite us saying this is something we want to do to make the surgery cost effective. So that might be an option to try articulating spacers if it's something that you're not doing currently.
Yeah, that's a great point. So in our own practice, last 15 years, we've been doing this for patients where there is not significant bone loss and the collateral is competent. We would autoclave the implants and then put them back with a new polyethylene after debridement. Almost 85% of them do not come back for the second stage. So I've had patients at 10, 12 years who come for a revision, and we've almost 75 to 76 patients like that in the last 15 years. So that's the standard for us. So probably transitioning into a one-stage procedure for infection.
Yeah, I think that's the great thing about this 1.5 stage is that at this year's, even AOS meeting and at the upcoming AUKUS meeting, a lot of discussion about what we're calling 1.5 stage, which is really just a single stage where we're not saying that we have no intention of coming back, and we're using implants that, are new implants. And I think this is starting to bridge for us the ability to do single stage for sure. And overall, if your spacer only gets one surgery, it's for sure the most cost-effective surgery.
Jenna, I need clarification on 3 points. In one of the cases, when you use a static spacer and use a retrograde nail put in the femur and the tibia, my question is, when you do a final implant positioning, how do you remove this nail? The question number 2 is, you said you don't prefer to use a dowels. Any reason for this? And you said also in your presentation, the pre-mixed antibiotic semen is not good. I need clarification.
Yeah. So the first one for the nail. So I try and use the smallest size, either tibial or retrograde femoral nail. And that way, when I go back in, I can just break up the cement, slide it up the femur, flex up the knee, and then remove it. If that is not possible because the patient has very narrow canal, then I'll just use a metal cutting burr and cut it in half and then remove it out of the knee that way. The second question was about dowels. So I will try to not use dowels if the
if the canals have not been previously violated in surgery. So I do a lot of navigation and robotics for my total knees, and so do a lot of people in the area around me. So many of them have not already had their canals violated. So for those patients, I try and not put in dowels because I'm trying to not violate canals that already haven't been violated, and no reason to introduce infection into the canal when it hasn't been there before. And then with regards to antibiotic cement, it's not that it's bad, it's just that the concentration of antibiotics that come in those are very low, and lower than we would recommend for spacers in general. So there's not a big use in using those, and they're significantly more expensive. So it's more cost effective and more efficient to just use regular cement and then add your antibiotics. And that way you can have the full load that you want. They're, you know, nowhere near the concentration that we would want for spacers.
My question to both Neil and Jenna, what is the protocol for culture negative infection, and how good is NGS in these cases?
Yeah, you know, we use some NGS, not all the time. Usually the one that's actually the Carius, which is a blood-based protein sampling, and some of the other companies where we sample from the synovium, you know, it's not quite there yet in my mind with how we're going to interpret that data. Frequently you get multiple bugs, and you know, the infectious disease doctors don't necessarily want to treat 5 different bacteria, and it's challenging. So the patients that we typically send it in are those who have had multiple infections, who we know, so we're pretty sure that there is some sort of a infection. So these are complex people who were either leaning towards trying to retain hardware and want some sort of focused antibiotic regimen, or someone who has had multiple surgeries with no bugs ever growing, with, you know, repeat purulent infections, but not standard using it. Generally, if they don't grow bacteria, but we're pretty sure based on other data that they have an infection, they still get broad spectrum antibiotics for 6 weeks.
Neil, what is your protocol for?
Yeah, so we've had trouble getting next gen sequencing in our hospital, and it's for a lot of what Jenna said. Our infectious disease specialists are not convinced that the bacteria that we're finding may not be part of the natural microbiome of the knee for that patient. And so we don't know exactly what you're supposed to be treating. But that is a huge concern, because I just reviewed a paper recently that's now reporting over 40% culture negative infections. That rate has literally gone up 5-fold in the last decade in the United States. For patients that we know that are infected, cell count is high differential, but their cultures continue to come back negative. If we don't have next-gen sequencing, we don't have another bug to treat, we're still just using very broad-spectrum antibiotics in our spacers between vancomycin and tobramycin. And if their kidneys can tolerate it, we'll even put in some amphotericin B in that spacer. But other than that, we don't have any other, I don't think there's much else that we can do unless we have a bug to treat.
I think,
you know, there are a couple prospective studies going on that are multi-center right now, looking at a little bit better about how we use these NGS for periprosthetic infections. So I think there's going to be some more data coming out in the next few years.
So our experience is we also have a 40% culture negative infection. But I said there are two ends of the spectrum. On a simple total knee which is getting infected and coming, we are not able to grow the bug because very slow growing, less virulent organism. So we have a good results with them in spite of whatever antibiotic protocol we follow. And the other extreme, what you mentioned, as multiply operated patients, immunocompromised patients, they are really the problem. So I think we have to consider these two ends of the spectrum and manage accordingly.
The other thing to add is to make sure that you have your cultures grow out for 2 weeks and not just for 3 days or 5 days. I think we're going to lose most of that data coming out of the endo clinic has shown us that we lose almost 50% of the bacteria if we don't actually have the cultures go out to that second week.
I think that is the standard of practice across.
Yes. Andrew, a question to you. You're talking about hyperextension and hinge. So as far as I understand, hyperextension for a hinge is not a great idea. So fixed hinge or a rotating hinge in a hyperextended knee? So if there is a sagittal hyperextension, it's generally not a good idea for a hinge because the hinge tend to fail if there is hyperextension. But what solution do we have? And do you look at a fixed hinge or a rotating hinge in such situations?
Yes, you're right. That's the right question in this situation. Most of the time we use a rotating hinge first, about 90% of cases. It helps us to solve this problem. But the question is to fill the space and to maintain a very, very stiff space. So what we try to do is to have less bending, but more stability in extension, because it's so important. I just wish to send my greetings to Neil. How are you, Neil? And I wish that you are well, and I wish to congratulate you because your presentation is very sad and pessimistic, but I agree with you, and I'm afraid to think that we are following the same way in Europe and in France, and we forget how to do is to take care about our patients. You're right. Thank you very much, Neil.
Thank you, Andre. Great to see you.
Dr. Andre, what is the most common reason for failure of your hinged prosthesis?
The most common reason is really the loss of ligaments. That's the question?
No, the question is, after you've done a hinged knee,
yes,
how soon do you find the failure, and what is the most common cause of the failure?
First infection. So you have to treat with another hinge, with reconstruction, with cones and very high reconstruction. But it's very difficult, and sometimes we just do an arthrodesis of the knee when we fail. But remember that only 1/2 of complications are reoperated. That means that it's very difficult to treat in these cases.
So it was a fantastic session. One final question to Jenna, Neil, Andre. Any role of intra-articular injection of antibiotic? Because I find that giving systemic antibiotics for 6 weeks puts a lot of stress on the microbiome of the patient. And I personally feel one of the reasons for mortality after revision for infection is that we are destroying the natural microbiome with overzealous antibiotic. And in my practice, I always use local antibiotic delivery through intra-articular injections. I know Leo Whiteside has talked about it and published this. What is the trend in US and Europe on this?
Yeah, Krishna Kiran, I think Leo Whiteside's paper is very good. I have not seen that study recreated. I know we've tried to look at this at Penn, and we haven't been able to, I think, reproducibly do this the right way each time. So we have not been using intra-articular catheters other than just systemic IV antibiotics and doing a good debridement and putting the right antibiotics in the spacer. But I agree with you 100%. I think that we know that high local concentrations of antibiotics are really going to be critical to clear infection. I think if we can protect the patient's microbiome and their biology from systemic effects of antibiotics, I think would be critical. But we don't use it so far routinely.
Yeah, haven't seen that done. I actually think the future is going to be the phage therapy. I don't know if that's something you guys are doing at all yet. We have a phage lab here at Yale, and we're starting to work to develop some for our multiply infected patients. But I think a non-antibiotic solution is probably what we're going towards. And there's a lot of research being done in the US. It's currently extremely expensive, not something that's can be done for all patients, but I think that's kind of where a lot of the future seems to be heading.
Andre, do you give local injection of antibiotic instead of systemic? After infected revisions, do you give local injection or a systemic? How are your thoughts?
No, in France and in Europe, in France, we don't use local injection of antibiotics. I know that in Germany, they do use it, but generally in Europe, no, only systemic antibiotic.
So Krishna, are you mentioning about local repeated injections or continuous, irrigation and system that
We have
use?
stopped irrigation.
Again, it's a one-off in this country, probably 15 years now. All my patients of infection, whether it is PGI, trauma, whatever, will get a catheter in. They'll get a Swan-Ganz catheter inside the wound, and we do high local delivery of antibiotics for a week instead of giving systemic antibiotics. So I've switched off from systemic, and it's in conjunction with my own work on general health and fitness. So we tend to overlook the impact of systemic antibiotics on the microbiome, which is actually essential for longevity life. So we're killing too many good bacteria for the sake of that local infection. So it's something which we must look at. And I must recommend all of you to study the work of Leo Whiteside. It's published on this, and it's a standard of practice in my own practice.
Yeah, so I think logically what you say is that it's right that you give local rather than systemic. So how long do you give? For just for a week, or do you continuously?
So the original recommendation was for 6 weeks. And what happens if you give for more than 2 weeks is that they'll develop a sinus there because they're injecting into the thing. So you have to balance it out. We found that if you give local concentrations which are very high for the first week, 10 days, it's good enough. So they don't require further antibiotic use. So in my practice, I don't use any antibiotics after 2 weeks. And it's just a week of local and then a week of oral antibiotics. That's it. Yeah. Ready? We'll stop it. Thank you.
Thank you.
Okay, thank you everybody. And that was a wonderful session. And I think this infection will remain a biggest challenge, and it'll never, probably, I don't know when it'll be solved.
Thank you, Andre. Thank you, Neil. Thank you, Jenna, staying up late, and we'll leave you. And it has been fantastic to have you guys. Share your thoughts. Thank you very much.
Thank you.
Thank you, guys.
Thank you, sir. So now we'll move to the OR as our live surgery is ready. We are going to demonstrate live surgery on navigated total knee arthroplasty. And I would like to call upon Krishna Kiran sir and Dhansekara Raja sir to moderate the session.
Good morning, sir.
What system is using? I think it is orthopedic.
Good morning.
Good morning, sir. We can see you.
Yeah, so this is 59-year-old lady, and she's got the viral deformity. You can see the X-ray. The ACL from these X-rays. I was wondering whether it could be functional because there is lateral opening. Contact point. But you can see that she has got severe viral. We are going to go, and because she's young, we are going to do the bone knee. So we have just waiting for you. We just done the arthrotomy. Now we are going to put the pin for the tracker. And the only thing I would like to now tell her is that she has a BMI of about 33, and short females who are overweight. You should be very careful when you are raising the sleeve on the medial side, because you run the real risk of over releasing it. So there are certain patients where you should worry about not over releasing the medial sleeve. Patients who show you a medial fracture or an osteophyte which is just attached to the tibia. And there you will find that the ligament is attached to that bony piece. And you run the risk of damaging the MCL when you are removing that bone. Similarly, like I said, short, fat females, you should be very, very careful. And so we are actually putting the femoral tracker to the tibial tracker, and we'll start the registration in a few seconds. So, and while the pin is being put in, I'll just lean away the patella so that we just keep on utilizing the time which we have.
So coming to BMI,
So we can actually do the arthroplasty in the meantime. And then we take the nibbler and do the superior post segment. Not much here. So we are actually ready for registration. We put the tibial pin and the femoral pin. So let's get on to the job.
so I have a question regarding the BMI, sir. So you're able to hear us?
So pointer. So we start by registering. We have to tell the computer what are landmarks. So we start with the medial posterior condyle, lateral posterior condyle.
So you should, the guy who is telecasting, you should show the wound and have a picture-in-picture for the registration landmarks. Yeah, so the smaller screen should be bigger and the bigger screen should be smaller.
Medial epicondyle. Lateral epicondyle. Medial tibial plateau. Lateral tibial plateau. Intercondylar eminence. Medial malleolus. Lateral malleolus. Central triangle.
Single bone, it gives graph.
And now we kinematically register the hip followed by the knee. So we are going to do the circumduction. And all of you who play video games or have played video games in the childhood, they get very good at it.
It's unfortunate that Ascolab has, stopped operations on Arthroplasty in India, but the latest navigation is even better with a multi-tool, and the hip center registration is much more sleeker. And you also get graphs on how the kinematic patterns look.
We are going to register the knee center. So now the computer is going to tell us the deformity. So this patient has 17 degrees of varus, 7 degree of flexion. So with flexion varus, again, like I said, you should be very careful, and we'll need to do, because this is the kinematic alignment, we'll need to do the.
Can you show the deformity through the range of motion? We can't see that. Yeah. So I think at 15-degree intervals, you can show the deformity. What is the correctability of the deformity?
Yes. So the deformity you can see throughout the range of motion.
We are unable to see the screen. So they need to do a PNP for the screen.
So you can see we start with
yeah,
which is about, it is somewhere around very depending on whether if this is the corrective force he is applying. From 17, it has gone to 11. Alright?
Yeah.
So that's all that we can correct here. And through the range of motion, you see with every flex, it remains, it never goes below 10 or 11, which we have seen. So partly it is the tibial bowing, which is contributing to it. And we'll see later on, as you know, we'll look at the distal femoral to see the plane of the femur. But it is varying anyway between 11 or 12 to 17 degrees, even in spite of putting the corrective force. So we are just going to put in the tibial joint. So we give the recommendation is not to give any posterior flow. We give two degree posterior flow because sometimes there is a tendency for the blade to sky, but ideally 0 or 1. So this is what we do. So we are quite good with this except for, yeah. So you will see as we increase the flexion, the depth of the cut increases. So it should not be anterior flow. That's what has to be kept in mind. Because that will tighten your flexion space. So your assistant has to be, his hands have to be rock steady. So we can live with that. We just got about 0 degree variance here and no anterior flow. So we'll just cover the femoral records. So we get the tibia forward. Okay.
So I see that you are doing a tibia first with gap management approach.
Yes.
Yeah.
Unless it's a special situation, see the only time I do femur first is when I'm doing the ortho aligned or the external based surgery. There we do femur first, and the other time I do it is bony ankylosis, particularly if it is stiff in extension. Other time I personally think that a good tibial cut gives me a reference against which I can build up everything.
Yeah.
Even yesterday in the uni, I said, if you do your tibial cut well, you know, in a uni, most of your surgery is done. And here also, you know, a good tibial cut will actually help you walk very fast and keep on struggling if the tibial cut is not proper. You can adjust your femoral rotation in a mechanical alignment by keeping it parallel to the tibial cut.
So coming from you, it's very significant because nowadays with these robotics and all the various functional kinematic, restricted kinematic alignments, the focus is on the femur. So everybody wants to resurface the femur and adjust the tibial cut to compensate the deformity. So
yeah, even in kinematic alignment. So we had a thesis. We are still collating the results, not submitted yet, where we had done kinematic alignment on one side and the mechanical alignment on other side, and the patient is blinded. So we intend to know which side the patient prefers. But what I'm saying is the kinematic alignment also, like you said, we do the tibia first. So you see, although it was showing ACL, I had cut the ACL, but you see, this is not classically the anterior medial. There is a lot of wear on the lateral cartilage also. So the ACL was not bad at all. I had to cut it, and still there is a just a minute. Okay. So it's showing something very interesting. So it's about 0 degree valgus as we planned. It's showing 3 degree anterior slope. I suspect there might be a little bit of bone left there. I'll not worry much about it. My cut is fine. I'll accept it and go ahead. We do make it a point to put a proper rod also, just in order to make sure that I mean, we got this very untrusting nature, so we continue to cross check. At this point, it's my habit to just extend and see that my cut is enough. It's definitely enough. I think it should be enough to get us 10 millimeter inside. So let's go back.
What we have found with severe deformities and tibia first is that unless you balance the knee to within 3 degrees of neutral, there will be a tendency to compensate the deformity with bone cut on the femur.
Bone cutter. So we have this, these osteophytes on the medial side, and they sometimes don't allow you to seat it properly. Remove this osteophyte, give me that. So now we are going to assess what is the orientation of the distal femur, right? So this rests on the tibia, contact with the. So you see that the amount of varus in the distal femur is only about 4 degrees. All right. So you saw there's some back calculation here. So I think the correctable, the uncorrected varus was about 11 degrees or 10 degrees. Only 4 is being contributed by the distal femur. Now we size the femur from the anterior cortex. The computer knows the posterior condyle reference and the anterolateral cortex. It is telling me that the size is 4. That decided, will now cut the distal femur.
So are you not doing gap tensioning in extension and flexion?
We don't have the tensioner, so we have to go by our field and the conventional. So it's navigation assisted. And,
Okay.
we are actually.
So you're essentially doing measured resection using the cast. That's
yes,
all. Okay.
doing measured resection. We are using computer most of the time not to open the canal, to not violate the canal. And okay, going. And get the overall alignment right. The balancing and all we do by the feel and selective soft tissue tension adjustment, if you like.
Yeah, makes sense.
Okay, lock it.
This particular case, if you had done gap balancing, it would ask you to compensate the deformity with bone cut. So the computer cannot make one a surgeon. So please remember that.
So one of the key advantages of using computer is, it teaches you so many things. It's a great teaching tool. And so we never realized when we were cutting the distal femur as to how frequently we would cut it in extension. When the blade goes down, it will skive here. It's only when we started checking our cuts, we realized the saw blade goes in and usually it gets deflected here. So you will find the cut is in extension.
So that has got to do with the surgeon. So there are certain draggers, certain lifters. So the draggers will drag the saw blade back and they will cut it in extension, and the lifters will cut it in flexion. So both type of errors are there.
So you have to, you learn to cheat the computer. So if I know that my saw blade will give me couple of degrees of extension and the recommendation is to cut it in neutral, I'll adjust the degree in 2 degree flexion, and most of the time we find that it's good. And then it also shows you how it is, so you can adjust, get the tracker in. See, this is what I meant. If you look here, if you got a perfect tibial cut, if you got a perfect tibial cut and your jig is resting on that, automatically it shows you the perfect rotation. Marking pen. This jig has got this slot here, and that is the perfect adjustment if you see rotation as per the right side slide. So a good tibia will give you a great. So this is what it is. We have still managed to keep 2-degree flexion. I'm not too worried about it. Yeah, you see the now the extreme right. It is showing a time in 2 degrees of flexion. So I can just adjust it, flex the knee a little. It's not, it's absolutely flat, so it's okay. Done. So now it is showing me, I think I'm pretty good with this. This is the perfect rotation. I'm getting 2 millimeter in front for the, to avoid the notching, and I've got perfect rotation. So we'll put the pins in for a size 4 jig. So we put the size 4 jig, and now we do everything as we normally do, which means that I'm going to put the angel's wing to see. I'll see that we are parallel to the tibia. I'll see that we are cutting more of posterior medial condyle. This looks a little anteriorized, but I'm not cutting too much. So the size is actually a little under 4. So it's possibly a 3.5. Give me the other pin.
If you had, you could use 4 narrow.
No, that is for medial lateral. Here the problem is that it is anterior-posteriorly 3.5.
Okay.
So I am a little anteriorized, but if I posteriorize it, my posterior cuts will become very small. You understand what I'm saying?
Yeah. So you'll overstuff your flexion gap.
Yes. So it's always make the anterior chamfer first before going in for the anterior cut. And this is not all that anterior. It's just maybe fraction of a millimeter, and I think I'm okay with that. That's fine. So, as you all know, it's very important to restore the anterior-posterior dimension of the femoral component. That's what decides the kinematics. So, that's what matters to me. Everything else is secondary. So, it's not too bad, but I could not have sort of taken out 1 millimeter less by posteriorly. And it's not actually 1 millimeter also. It's just about half a millimeter or so. So, now at this point of time, we'll do some cleaning business. So that will include the taking out the meniscus. The other thing is, whenever you have a bowing in the tibia and you make a cut which is perpendicular to the long axis of the tibia, the cut will be in somewhat valgus. It will look like thin valgus, and that is automatically going to tension the PCL. So in most of these cases, you will need PCL release or balancing. And for removing these meniscus, we find towel clips to be very good instruments. They don't slip, and provided the sister gives you a proper towel clip, then it's a very good instrument. We remove the posterior horn, we'll take the bone cutter. Remove these osteophytes. Okay. Right, this one comes out, and see, this is what I told you. See this? Let me show you that. So I'll tell you why I was not worried about the anterior slope. I thought, give me the anterior company alone. So now, if you see this, you would remember that it was showing anterior sloping. That's the cause for the anterior sloping.
Yeah.
Like I told you, when I put my tibia there, it was resting on something on the top. So I'm going to take care of this anterior sloping now. Right, Nibbler?
Yes.
So this was the thing which was causing the problem. And then we have part of the lateral meniscus left there. We have had some very, very severe varus deformities with very severe bone. And what I have done in those cases, we have a series. So we have to start putting our results together. What we do is we cut the tibia in a little varus, almost like a kinematic alignment. We put in a stem because we are uncomfortable about just leaving tibia, in a little varus. So we put in a stem and then we use a UC insert. Because in a real bad going, it's very difficult to balance the PCL because your cut becomes very valgus. So what we do is, and this has been working very well for us. We have patients who have gone on for more than 10 years with this thing. So sacrifice the PCL, put in the tibia, stem, and there's a little bone left here also. Give me the saw. So forceps. And so we are actually quite ready to now go on to the next step. So we have done all this cleaning. Arthroplasty has already been done. So we will and as you know, the size of the tibial base plate is decided by the anterior-posterior dimension of the lateral condyle. We are ready to take a look at it. So give it to me. And we can take this out. It's not doing anything. Maybe a good point, good idea at this point of time to do a little bit more of posterior-medial release because the flexion deformity which we saw there. The other reason is when I do the reduction osteotomy, it will become easier for me to remove this bony fragment. You see? So if I make it devoid of soft tissue attachment, it does both the things. That should be good. So we'll revisit it if required. So now, let me feel for the osteophyte posteriorly, Nibbler. Lift up. Give me curved osteotome. Keep it flat. So, removing the posterior osteophyte. Give me the curate. Okay, now we can see the fat female. Sometimes when we feel that there is a torsion problem, we just do a free floating trial one. So yeah, let's see the size of it. One should be good just for the time. Put an insert. Yeah, so we'll just assess our spaces. This looks quite good. At this point of time, usually the only issue I want to address and see this point of time is the PCL type, the tension in the PCL. This goes in. This is a little tight in flexion. Maybe I'll do a little wee bit release balancing of the PCL. So like you said, it's a little too wide medial actually. So we'll use a narrow. So this one comes out and let's see the tracking. By the way, we got the tourniquet on because she's only 59. So I'm not much worried about how the tracking will look. My component rotation is very good, but I just want to see. Okay. So can't see the tibia. Give me the mop. So we'll just assess what we have done. So we have about 0 to 1 degree varus. We had seen that our tibia was a little bit of varus. I'm pretty happy with it for the time being. Flex. So it stays at around 3 degrees throughout the range of motion. It's about 1 in full extension, sometimes going on to 2. So what I'm going to do is actually do a little bit of posterior-medial release so that the extension becomes a little more easy, and that will take care of the 1 degree varus also. So we are actually quite good. The patellate tracking is not bad at all, considering that we have got the tourniquet on. इधर से दिखा सकते हो? We got a good patellate tracking, and we have got a slight varus. Now I want you to see something. I still am feeling that this contact point is a little posterior, you know, and I think, like I told you, she has bowing in the tibia, and I am not happy with this. So I need to release it a little more. So I'll do a little bit of balancing of the PCL, and that will make the femur come and sit right on top of the tibia where it should. Okay. Forceps.
Posterior, I think that's okay. In the CR, it has to be in the middle third. It is too posterior when it is tight. But that changes when the patellate.
So we are not in a hurry. We'll just release it a little bit and see. Look at this now. For those of you who saw it earlier, this is the right contact point. So there was a little bit of tightness of the PCL. I just did a wee bit release, and it has taken care of that. And from 3 degrees in flexion, it has gone to 2 degrees. You see that?
Yeah.
And the extension is consistently at 1 degree. I think I'm quite happy about it. It just needs a little bit of posterior-medial release because it's not going as readily in extension as it should. So this is what we'll do. We are actually ready for tibial preparation, cementing a little bit of adjustment of the, and second thing, of course, we have not done the reduction of chutney. So there will be some amount of tibia which will come out. So so we'll reassess whether we really need to do something posterior-medially or not. And this is the rotation as on free floating. It looks pretty acceptable to me. I'll mark it here. The best thing is when you are free floating and your anatomical, they just match. I'm quite happy with the tracking. It is good. So we mark the tibial rotation. So we'll now prepare the tibia. At this point of time, make the peg hole, implant खुलवाओ, mix करवाने की पहले. Flex. Okay. Now give me the handle. Give me the posterior human. So this one goes in here. Out. It doesn't bother. I don't really bother if I can't, reverse the petal all the time in a heavy lady, because we can actually just get it out of the way without any problem. So there's no need to just go with hammer and tongs behind it. Okay, we are ready for tibia. Give me size 1 tibia, please. So some people would just mark the boundary of the boundary of the lateral condyle in order to make sure that they don't underhang or overhang. So it may be a good idea to mark the outline of the tibia. And then this is the correct size. This is size 1. I'm quite happy with that. And where is that mark? This is the mark. This is the mark. So what we'll typically do is we'll put in 1 pin. drop the rod, and it's going to the second toe, right? And put the other pin. This is a correct place. Stand up. So she is young, she is overweight. We'll routinely put a stem in such patient, and she has severe virus. So there has been literature which has shown that the stem reduces risk of failure in severe deformity, in overweight patients, and in any case in young patients. Again, we have a policy to put in the stem, and it has served us well all these years. So this one comes out, the pins come out, the saw should be ready, and then we one last final check, and then we cement. Nibbler, we are good here. Got a good. Okay, now we are ready. Give me the insert. Another thing which we always do is, suppose you have a flexion deformity, right? And you have very poor bone. We never extend the knee without putting in a tibial trial or base plate with stem, because that protects your tibia. Otherwise, the tibia can easily get compressed. Fracture. Tracker. So let's see how it feels. Feels a little better than before. It's actually quite straight. Implantable bone mixed. 3.2%. See that? 4 left narrow. T1. Okay. Okay. Right. Okay. Solid. Yeah. This comes out. Flick. Remove the trial component. Tracking quite well. Quite stable. Show the stability in the range. It's actually pretty stable throughout the range of motion. It's quite good. Quite happy. Chalo. Woman, handle, another one. There, handle, ये वाला 3.2 drill, top Dr. Tom and sponge ready. Lift up. I'll just do some posterior clearance with this sponge hammer. Just sweeping the posterior capsule of the posterior cortex. Yeah, better. This one I'm not too much worried about because the flexion virus. I don't think that there's much to do here. Okay, wash, injection. Next. Injection ready? Next. Lift up. Nibbler. Right here, nothing. Okay. Injection. Gloves for me. X-ray मंगवा लेना इसके बाद. So we inject in the posterior capsule, in the fat pads, and median and lateral epicondyles, periosteum overlying that, and then into the cordyceps. So patients do very well on first day, the day of surgery. They lift up the leg. It's only when you go there next morning that you find that now they are not able to do straight leg raising because of pain. That is one thing which has actually been a challenge for Nibbler. Daycare, arthroplasty, knee. UKR, there's no problem. We have had patients, at the end of the day, they are saying they are happy to go. They won't even, the knee replace, the total knee is the ones who are reluctant also. UKR, the patients are very, very comfortable. The patient we did from yesterday, we went to see in the evening, he's doing very well. How many? You all know? Shabash. Well done. You have to be an assistant with many hands. पानी चेंज कर दो. Actually. So we do put, if the patient is affording, we put the gold knee for young patients. कितना मिनट हुआ? पानी 2 minutes काम है जी. लग How many minutes now? No, पानी दो, cement दो. So most of the implants don't have any metal coming here. So we put the suction here and it keeps on drawing blood into it and the rest of the tibia remains white. बहुत ठंडा है क्या? अभी भी 3 minutes पे. Let's hospital. No, tibia. A good fitting should actually cut the cement out. The implant should cut out the cement if the fitting is really good. And okay. Wash. Impactor को दोबारा. Dry mouth. Suction. Insert. Okay. Should carefully slide the tibia under the femur so that don't damage the bone in an osteoporotic patient. Dry mouth. It's very interesting. Different patients, particularly short, fat patients, the extensor mechanism is sometimes so tight that you take it to the one side, it will make the whole thing so tight because it's tangentially short, particularly patients who don't have good range of motion. So it's very misleading. So you should check everything which you do only with the patella reposition to its normal place. Otherwise, it can look terrible. Okay, we'll have the femur now. It's a small femur, so not too much of cement is needed here. Inspector. Now, great. Wash, impactor. Impactor. इधर पुश करके. Okay, trackers in. Okay. Nice. So the other advantage with navigation is that, we are able to check what we have put in. So if you think that there is a little bit of virus and you impact the lateral side and you realize that it was not seated completely. So every step actually becomes a way to cross it. Tracker. So that's why you see, I never worried about that upsloping thing or this is actually just lying free in his hand. 0 degree, 1 degree flexion. And, this is, that's because we know that some things will be taken care of as and you see even in the flexion now, it's just between 2 to 3 degrees. It's stable throughout the range of motion. So we have done perfectly what we set out to do, a mechanical axis alignment of 0 degree, and we'll just close it now.
Thank you, sir. That was fantastic demonstration. It was a surgeon who who made the technology look good. Thank you.
So I've always believed that if you are not one of those who is not very happy about kinematic alignment, the 3-degree varus thing or things not going well and afraid of leaving more than 3-degree varus, you can do that with PSI or the navigation. Then you can ensure that your cuts and everything, the amount of resection and the so if you are a purist, then you can do that.
Yeah, that's perfect. The technology allows you to do whatever you think is right because we don't have a defined goal.
I had said something to Sean yesterday, but and that's the idea of robot is that the the dopamine which is released when you see that robot has done exactly what you wanted it to do. That feeling is actually the one which drives the surgeon into doing all these things. And
Yeah.
to have those figures there on the screen, 0, 0 or 0, 1, 1 degree, 2 degree hyperextension, 0 mechanical alignment, gives you a feeling of having done your job well without knowing whether it will translate into something useful in the long term or not.
Yeah, that's true.
Prem?
We will move on with the next session. Thank you very much, sir. Big round of applause
so
for you.
much. Thank you. Thank you.
Thank you, sir. So for the next session on dual mobility cup in total hip arthroplasty, I would like to call upon CS Yadav sir and Simon Thomas sir for moderating. And I would like to call upon Dr. Andre Ferreira for his lectures.
Thank you. Okay.
I think this is very interesting session and the title is very interesting. Should everyone get one? Very interesting. Let us see. But dual mobility has really changed the total hip arthroplasty, especially in regard of instability.
So thank you to invite me to talk about dual mobility cups. It's my proud privilege to talk about this topic I like particularly. So we know what are dual mobility cups, but should we get it for every patient? That's the question, the first question. So we have to remember that it doesn't work. That is not important. That total hip arthroplasty is, sorry, always a compromise between the mobility, the stability, and longevity. And now we have to treat more and more young patients, young and active patients. And they wish to do sports and they need more amplitude of activity and more amplitude of range of motion. And now dislocation is no longer accepted. And the rate is between 1 to 5% according to the literature, but it is not accepted. And in the same time, these patients need and wish long longevity for their implants. Dislocation is the main problem. In the Swedish hip register, in the British one, it is the first reason of revision during the first 2 years. You can see in the Swedish register, it's about 1/4 of revision are due to dislocation, more than infection, of course. But what are the dislocation mechanisms? First of them, impingement. It's a conflict between the neck and the acetabulum, or the bone on soft tissues, and particularly in case of obesity. Why? Because sometimes the physiologic range of motion is more important than the implant's one, or it is due to an implant's position or a bad ratio and neck. We will talk about it later. The second mechanism is the translation. Translation due most of the time of a muscular decapitation due to the weakness of muscles. It is particularly important for elderly population or when raising from a sitting position. And in this case, most of the time, it is a mixed mechanism between impingement and translation. So that's the advantage of dual mobility cup, because, and thanks to the two articulations, the small one between the head and the insert, and the big one between the insert and the metal back, the impingement is delayed. You can see the picture of Gilles Bousquet, who was the inventor of dual mobility. This phenomenon of delay impingement introduced the notion of prosthetic impingement theorem of nerve loss. And he has published a study about the geometry of the cups, dual mobility and standard ones, and this range of motion. And we can see that in rotation, there is no deal. With the dual mobility cup, rotation is more important. For abduction or abduction, we can see that there is a slight advantage for dual mobility cup, and we have the same comparison with dual mobility, but we can see that it depends on the geometry of the cup. With the sub-hemispheric one, of course, because it is they are very small. In these smaller cups, of course, the impingement is delayed, and we can have a more flexion. And we can see that the most interesting dormitory cup is the sub-hemispheric one, but it's not the ideal, because, of course, the range of motion is the most important than every cups. But of course, the retentivity of the insert into the metal back is less good, and we can have a dislocation. But this range of motion is very important for very young people, or according to the culture, and in the Islam, for the Muslims, or for some Asiatic population, of course, people wish to have more range of motion. Dual mobility is not a constrained cup. Constrained cup is completely different. It is constrained, of course, and the goal is to face the translation mechanism of dislocation, but with the risk, of course, of a lack of fixation into the bone. And dual mobility is not a tripolar concept. It's very important to remind that because there is a constrained system with a locking rim. It seems to be a dual mobility cup, but it's not one. There is no freedom between the femur and the cup. And what are the results? In the treatment of recurrent dislocation, we can see that with a very long follow-up for the 24 years for Ayler, for example. So with a good follow-up, we have less revision for dislocation with dual mobility than with constraint or tripolar. And we can see that with the most constraint, we have more revision. With the less constraint, with the tripolar, less revision. And with freedom, with dual mobility, of course, we have the best results. So we can say that indications are that for anti-impingement, dual mobility is better than constraint. For an anti-translation, dual mobility is less good than constraint cup. So now, what are the classic indications of dual mobility? And I know that in most of the countries, like in India, it is considered like a salvage procedure. So you use dual mobility for instability, for high-risk instability in case of muscle weakness, neurologic disease, in case of oncology, traumatology, when you use THA better than arthroplasty, of course, and for elderly patients, we have to define them. In 2009, the French Society of Orthopedy made a very important symposium about close to 2,500 cases, and with one definition of failure, revision of the curve for ascetic loosening or intraprosthetic dislocation. And the survivorship was about 95% at 10 years. So then the indications have evolved in France. At first, as we say, it was a salvage procedure, or for two centers in Saint-Étienne, where Bousquet worked at this period, and Caen in the northwest of France. They used it in first intention for all patients and sometimes elsewhere with some surgeons. But in the other centers in France, it was used only like a salvage procedure. After the symposium of the French Society of Orthopedy, the indications were done according to the age. More than 70 years, no doubt about using dual mobility. Between 55 to 70 years, according to life expectancy and instability risk. So not for all patients. And for young patients, less than 50 years old, hesitation about its use. But now, today, in France, we can say that we use in primary is close to half of patients. In revision, 2/3 of patients, and in case of neck fracture, when we use THA in half of the cases, it is close to 80%. And in the same time, we have seen a decrease of dislocation rate for all THA, primary, revision, neck fracture. And during these 10 years, we have seen a decrease of 3% from 9 to 6% of global dislocation rate in France, because it's the numbers, the official numbers of the national health. So you can say, that, okay, it's good for dislocation, but what about survivorship and wear? So we have the first results available from Saint-Étienne with the initial series. And at 22 years, Boyer showed that the survivorship was about 90%. Neri has the same results with the exclusion of neck fracture cases. And of course, they had more failure before 50 years old. But in average, we can consider that the survivorship is about 90% at 12 to 15 years. So we are not disappointed about these results. And with the second and the third generation, we have the same results, about 95, 97 or more at 5 years or 10 years. And the better results are due to a fixation improvement, because the first generation has a lack of fixation, but we have to remember that it was in the 70s and the 80 years, of course. So at 10 years, 95% of survivorship, it is not disappointing, it is not worrying. In the same period, if we study the Swedish register in 2014, for example, the survival at 10 years, first there was no difference for all implants implanted before 2005 or after. And if we consider according to the age, we can see that, of course, for all patients, elderly patients, the survivorship is good, about 90% at 10 years, but with young people, younger and younger, you can see that there is a decrease of survivorship, of course, because there is a wear for all patients in this case. Maybe ceramic and ceramic seems to be a little bit better, with a rate of 95% at 14 years. So we can say that the results of the mobility are comparable to the standard implants. The only parameter who affects the survival is thus the age. Why? Because there is a third articulation, and this third articulation in annual mobility is between the neck and the insert. And when we use the global amplitude, the extreme amplitude, then we can have a contact between these two elements. And then they lead to a wear of polyethylene and an intraprosthetic dislocation. But first, it depends on the diameter of the neck. So that means that we have to take care of the stem we use with that mobility. We have to use a thin neck. With a large neck, of course, there is a risk of contact, and the ratio and neck is very important. I hope that it will work. Yes, and you can see that with a dual mobility, there is this impingement, and the design of the insert is very important. If you have a point contact, it's not good, of course. So that's the reason why chamfers are better with this retentive liner to avoid an impact and to have a plate contact. So young patients are special. What are the definition of young patient? I don't know for you, but for me, older and older, year after year, I consider that the limit is not the same, of course. But we can consider that less than 50 years could be a good border. So frequently, these patients have special disease, osteonecrosis, dysplasia, epiphysiolysis, or sequela or fracture. We have more men than women, and maybe cross-link or ceramic are the good solution. Maybe, because if the survivorship is good, there is a risk of fracture of ceramic, for example, due to impact activity. Because these patients have a lot of cause of wear and failure because they do impact sports and they do hard work. And the most important, that they have activity more or less dangerous. When you do trekking alone in the Nepal, if you dislocate, you are dead. If you dislocate on a boat alone, you are dead. So dislocation is the main concern for this population. And in the same way, they have a case of extreme amplitudes leading to arthritis or wear of ceramic fracture, as I said before. And at the same time, of course, they have a long life expectancy. So I think that dual mobility is clearly adapted for this population because the most important problem to face is dislocation. And if we consider the result for these patients, only young patients, according to the literature, the border is 50, 45, or 55 years, but we can consider that the results are so good for mobility that in registers, maybe only ceramic abattoir could be better. So dual mobility is really comparable for young patients than standard cup. So is this reasonable for all or almost all? Yes. Yes, if stability is the main objective. If these people have an activity with high risk of dislocation, like impact sports, and if they decide a maximum amplitude. So it is reasonable to use it, and age is no longer the main criterion of choice. But of course, it is only a choice. DM is an option. It's not a salvage procedure. It is like ceramics and ceramic, resurfacing, highly costly, and so on. And remember that we can have a risk of polyethylene wear or more a ceramic fracture for this population. And it is less difficult to treat a polyethylene wear than a ceramic fracture, for example. So dual mobility can be used for everyone. It's not mandatory, but reasonable. What to retain, the age criterion is not the most relevant. But if you are afraid against wear, do not operate the patient because wear is mandatory with the use of a total hip arthroplasty. And if we have to face The wear of polyethylene is not so difficult to treat. So we have to analyze the demands and the needs of the patients. Very old, very weak, constrained cups. Demand for optimal longevity ceramic. In my activity for people between 60 to 65 years old who ask for a very long longevity total hip arthroplasty, I use our ceramic on ceramic, but with a risk of dislocation, with an activity with high risk of dislocation. When the patient requests a safe activity, I use the mobility. And in case of high impact or large amplitude, of course, durability. So it's not really a request of the patient, of course, because it is your choice and you influence the patient in his choice, of course. So you have to analyze his demands and then to choose for him. And we have to remember always the consequence of our choice. So durability is precise, yes, of course. It's prompt, of course, and it's perfect, yes, of course. I don't know if I can show this video, but it's not really important. Thank you for your attention about this first lecture. Thank you very much.
Thank you very much, Dr. Andre. I think you should continue with the talk on revision, dual mobility in revision total hip arthroplasty.
Thank you. So now we have seen the interest of the mobility cup in primary and now in revision hip arthroplasty. In the same way of what I said before, if we compare the results of revision for total hip arthroplasty in France, comparison with the New Zealand register, the UK one and the Swedish one, we can see that dislocation is less important in France, thanks to the use of durability in primary. Now it is only the fourth reason of revision equal to infection, periprosthetic fracture, and pain. What are dislocations in this case of revision? We have two different types, of course. The early dislocation during the first 2 years, most of the time they are due to technical error, and we have to exchange the implant, to exchange the cup, or sometimes the stem if the intervention is not so good. And the late dislocation due to an aging process, the wear of the implant, or the weakness of muscles. In the same way, what are the complications of revision THA? First, dislocation, and then the medium-term fixation, that is only the second concern. And both complications occur more frequently during the 2 first years. The literature shows with the Saint-Étienne series, of course, because they are the pioneers of dual mobility, that the survival rate of dual mobility cup in revision, it's about 85% at 15 years, with only 3% of dislocation. Remember that it's revision for instability of THA. In literature, usually the rate is about 15%. And there is the same results for Leiber-Wackenheim and Mertel in 2011 with only one early dislocation. During the symposium of the French Society of Orthopedy, I mentioned before, when they studied the revision for recurrent dislocation, about less than 200 cases with a follow-up of 6 years, we can see that the BMI is a little bit high. The results are the same, with only 4% of redislocation and 4 cases of breakage of material, but the cup fixation is good, sure, close to 96%. the eye diameter, the cup inclination, the cup diameter, and so on have no influence on the survivorship. The only parameters who are important are the etiology before the first THA, and we can see that in case of dysplasia and congenital luxation, the risk is more important to have a redislocation. But what is very important is the numbers of previous THA when it's a revision of the third or the fourth times. Of course, the risk of dislocation is higher, and the truncator status is equally important, and we understand why. So you remember this table about the result of durability phase 2 tripolar and constrained. So in summary of this topic, durability is more effective than all other techniques facing to revision for dislocation, instability, whatever the reasons. But of course, in case of muscle weakness and for very elderly patients, probably constant cup are a little bit better than durability. If we consider now revision for any reason, and of course, failure and of implants, we have conducted a study, a prospective study with 80 THA revised between 2010 and 2012. All patients were included, and it was a revision in one stage for all patients, a half or less than a half only the cup, or more than a half a cup and stem. We used two types of implants. One, it was close to a primary dual mobility cup and cemented, of course, with no additional fixation, and 11 cases with a special incemented cup with a very large peg, long peg, introduced into the iliac column. We can see that the characteristics of the cohort is that we have wear-free dislocation or dislocation with wear. So you remember early and late dislocation. Of course, osteolysis or aseptic loosening, it's very important in this series, and the other cases like aseptic loosening or technical error or implant fracture are very rare. And the results show that we have only one case of luxation, of new dislocation, so it's 1.3%, no revision for dislocation, only reduction under anesthesia, and of course some infection, mortality, it's a very old population, and 2 fixation of failure. So we can imagine that the revision with durability for any reason is depending of the bone loss, and you can use a standard cup or a cup with flange, with hook, with screws. And when the bone loss is very important, we can use some device like cable cross or Schneider device, and then we can cement a dual mobility into these devices. And what is very important is to remind that the reconstruction device must be adapted to bone and to the reconstruction, but then you have to place correctly the dual mobility cup in the safe zone to avoid dislocation. And that's the reason why the fixed cup, the monoblock dual mobility cup is not very useful in case of hard revision, because the fixation is sometimes not ideally due to the bone loss, and then we are not in the safe zone. So the results provided by this revision shown in blue with a dual mobility cup, in white without a dual mobility cup, that first, the reasons for this revision are most of the time assessment 3 or 4 in classification of the American Academy of Orthopedics, and with a short or a long follow-up, the aseptic losing with a dual mobility cup is equal or inferior of this with non-dual mobility cup. So, to end, we have the prospective study in the French Society of Orthopedy, and we can consider that the dislocation rate is less important with a dual mobility cup than with a standard cup in case of revision for any reason. So, in conclusion, in revision in France, we use dual mobility cup in almost all the cases, more than 80%. Why? Because the recurrent dislocation is or either the reason of revision or the risk of this revision. Of course, to ensure stability, we have to use dual mobility cup, but the bone reconstruction is very important. And in case of THA, for any reason, revision for any reason, sorry, we have to reconstruct the bone first and then to use the mobility to ensure the stability. And we can reconstruct with a graft or cable rings or Bosch Schneider. And now we have some uncemented cups with the ability to place the cup, the mobility cup correctly. In case of failure, because I imagine that you will ask me this question, of course, the only solution are constrained cup with the risk of a less important survivorship at midterm, of course. So the mobility cup is precise and perfect. I think in case of revision, maybe less prompt than other devices, but I think that it earns to be used. I thank you for your attention, and I just wish to thank everybody for the welcome, because it's very, very nice to be there, and I feel a very high hospitality, not only polite, but delicate and warmful, and it is in my heart now. Thank you very much.
Thank you, Dr. Andre. Any question from the floor? Yeah.
Well, my question is that dual mobility can provide stability, but it cannot replace the imbalanced hip. What I mean, if the abductor labrum is weak or a not proper horizontal and vertical offset is not there, in this situation, do you think that dual mobility will be stable after the surgery? Soft tissue balancing, I mean to say.
I don't understand what it means.
So exactly, in short, what is your question?
My question is, if there is no proper soft tissue balancing around the hip, whether that, suppose the GT is broken and you put the dual mobility cup, it is going to be stable in that scenario also?
Okay, you're right. Dual mobility is not enough in this case. And we join the same problem of the muscle weakness. So if you have a GT concern, you have to treat first the GT and then to use the mobility cup, of course. But if you use alone the mobility cup, most of the time it won't be relevant. You're completely right. We have to treat first the reason. But the mobility cup is very helpful in this case because it helps the patients during the rehabilitation to ensure its stability, of course.
Any other question? Dr. Kharwanda.
So, many times in here, and I'm sure you also must be operating on a lot of failed trochanteric fractures. That is what Dr. Khare was also pointing to. So if you are, doing a total hip in a failed trochanteric fracture where the abductor mechanism is not right, you obviously first take care of that. Now, do you think that in such cases you have to use dual mobility, or you can get away with normal hip? Because it's ultimately a primary hip, but for a failed trochanteric.
This is a very important question because most of the time for trochanteric fracture, we use osteosynthesis. But that's true that for very, very difficult cases, it's not enough, and we have to use total hip arthroplasty. In this case, of course, we use the mobility cup, but as the previous question, the problem is about the GT and the balance of the muscles. So what is important in this case is to use a good approach. We don't use a posterior or an anterior approach, but we use a transtrochanteric approach. A transtrochanteric because we use the fracture. With the fracture, we can open the joint. Then we can cut the neck, put the implants, stem and cups, and then we repair the GT, a synthesis with cables or screws, depending on your experience, of course. And then we have very good results. And we have conducted a study about that. It's difficult because the trend in France is to do an osteosynthesis in primary in these cases. But I completely agree with you. Sometimes it's better to do immediately the prosthesis. But when you have a failure of the synthesis, most of the time it's very difficult for these patients, and the mortality rate is very high. I agree.
I think. One more than a short comment.
So it is taught to us that when the GT is gone from the mother bone, whatever you do, it never unites. I don't know your comments.
It's only a concern of surgery, of course, but most of the time I use cables. I use elastic wires, metallic wires, but with an elastic system of fixation. Yes.
Even though it doesn't unite, there is some fibrous union that helps, that gives some strength to the muscle. So overall, what I feel, dual mobility is excellent tool for the instability. There is a laboratory study. If you use 48 millimeter conventional head like delta motion, it gives jump distance around 9 millimeter. If you use same diameter dual mobility cup, jump distance will be increased almost double. So increasing height, increasing diameter beyond 36 is not good. If you think there is a problem of instability, then go for dual mobility. Do not increase beyond 36 because it doesn't enhance the stability. And overall wear is less because there are two surfaces, small head interface, then large head interface. Most of the movements takes place in small head interface. So less like a Charlie's hip. So less wear, and large head interface, it comes in the later stage in terminal degree of range of motion. So hardly it is used. So it is excellent, wear is very less, and it gives really excellent stability to the hip.
Thank you very much.
In the Indian scenario, if you do a primary hip, a lot of times if you have a 36 head, it starts from 15 majority of systems. Sometimes we do in old patients, we do a fracture neck or femur, you start a head size. If you do THR, you get a head size of 42, 44. In these heads, in these cups, the head size that usually goes is sometimes 22. And there the chance of dislocation really very high. These are those cases in which in Indian scenario, you can actually go for a dual mobility where the articulation is bigger, and it is a big, big lifesaver. But having said that, let me play the devil's advocate also. So now in conventional total hip replacements, we are having three articulations. One is between the established shell and the bone. The second thing is between the head and the established shell. And the third is the trunnion. With this dual mobility, we have added two more articulations to this. What do you think in your practice? Because two more articulations, that means the ball and the mobile spacer and the poly. So what do you think is the prediction in long term, maybe 10 years from now, 15 years from now? May this go the metal on metal way, or we will be winning? What is your take on that?
So articulation is the main problem. You're completely right, and probably for these young patients, as I mentioned. So I think that probably the future is the cross-link. But cross-link cannot be the same that with a standard cup because the wear is not exactly the same. In a standard cup, you have only the slide of the cup of the head into the cup. And in the dual mobility, there is a rotative rim, and we have to have a very elastic polyethylene when we impact the head, because most of the problem came from this time when you impact the head. The risk is the breakage of the chains of poly at this moment. So with a very high cross-link, the risk is to have too much hard cross-link and then to have breakage of the polyethylene. That's the reason why you can see only one or two manufacturers with cross-link in dual mobility. The goal is not exactly the same that with the standard cups. But if we find the good cross-link more elastic than the useful one, then we can hope a very, very less weight of polyethylene and then a very good survivorship.
So thank you. This session is over. Now we will switch on to live demonstration surgery. Yeah. Thank you. See you. Thank you. Yeah. Can you show the already done surgery X-ray? Yeah. So whenever you think there may be problem of instability, use dual mobility. Do not increase head diameter more than 36 millimeter. It doesn't enhance the jump distance or stability. Simple message. And wear is less because most of the movement they are taking place in the small diameter head interface. So it also take care of wear, especially with the cross-linked poly. Now new company have very, very good cross-linked polys, all companies. Yeah. So
this is the case for live surgery that we're taking up. So these are the details. It's a 66-year-old female. She had complaints in her right hip for the past 4 months and had a fall from standing height 4 months back. She couldn't consult with us due to COVID lockdown. She has had no history of any constitutional symptoms, no history of fever, weight loss, and she has had no comorbidities. So her examination is as given. So this is the X-ray.
yeah. What is the age?
68.
66-year-old.
66. I think while we are there setting up this session, Dr. Yadav, what do you think are you going to be using a dual mobility in this? What makes you plan? Let's talk about the pre-operative planning at this stage. She's an old fracture. You'll have that.
Probably I can come out with the conventional total hip arthroplasty in this case.
What approach are you
because age is 66. So you may keep as a alternate dual mobility on the table. So if you think you are not satisfied with the stability, then you can go ahead with the dual mobility. Otherwise, because here abductor mechanism looks fine, just fracture neck of femur, and overall this is old one. So here what happens in the elderly fresh fracture of femur? What is problem? Main problem is looseness, slackness. Our patient, they have slack muscle, loose muscles. So that instability gives you instability. If you overstep the joint, then you will lengthen the limb. So here it is a old fracture is blessing in disguise because tissue will be little tight. So that will provide stability. So I can come out in this case with the conventional total hip arthroplasty, either 32 or 36 millimeter head.
Have you done a templating for this? Is there a templating here? Okay.
And another important point for the fractured neck of femur. It is taught release maximus tendon, never ever release, do minimum release because they tend to get loose. So do where minimum release, just that is required to do surgery. And especially maximus tendon, if you do lot of release, joint will relax and patient will feel, you will feel the instability. Then you overstuff, lengthening. So I never, in most of the, even in the primary, irrespective of elderly age group, I do not release maximus tendon. That is unconventional of teaching because it is sometimes it really lacks the hip joint. So when it is required, I release maximum, even in the young patient.
I think as I told earlier, I would be actually in my planning phase, I would, in a lot of these ladies, and you do a THR, you start to get a size of around 44, 46 some. And I'm a little skeptical to use a 32 head in a lax fracture neck or femur. And these are those cases in which I'll keep a dual mobility actually as backup. It gives me a bigger size head, even with a 44 cup size. So this can be very well done, but I think having it as a backup is a good bailout tool. Anybody else from the audience?
Yeah, Simon, about this comment on release of gluteus maximus tendon, which Dr. Yadav just said. So once I was in Wrightington, and there they were releasing gluteus maximus tendon in all the cases, and the explanation was to prevent sciatic nerve pulse.
That is a useless statement. I never release and I never get sciatic nerve pulse.
Yeah,
it is useless.
I've never released. That
just
is what
theoretical. More of it is theoretical thing we were previously doing, and if I stopped it doing for last 10 years, I do not have faced incidents of sciatic nerve pulse. It's simple.
Yeah.
It is more of theoretical and just for the sake of literature.
I think this is what Dr. Kharbanda also wanted to say. I think he's on the same side as us.
Yeah, so I'm not, I was just saying that there are some people who say this, but I don't think I've never released. I release only
that
cases.
is good strategy, not to release. If it is needed to distract the femur anteriorly in posterior approach, then release it.
That's right.
If you need it, then release it.
Totally agreed. So gluteus maximus release is not the first stage. I think that's what the message Dr. Yadav wants to say, and that is a very valid point. Which approach would you choose, sir, here? I think you and I are only...
Always, I die for posterior approach. Always, any hip, always posterior. And I always say, in posterior approach, dislocation rate is as less as any approach. Just take care of two things. Just two things. Never ever reduce your combined anteversion. That is most important in the posterior approach. Second, you should know how to repair that extended myocapsular repair from the trochanteric fossa up to the trochanteric border. If you do proper myocapsular repair, do not reduce your combined anteversion, dislocation rate is 0. And even at AIMS, you can find out from the register in many years how many dislocations we had at AIMS. We were doing for the same technique, posterior approach, good repair. So it is more of once again theoretical. Posterior approach, if increase the dislocation. If you do not do properly, then there may be dislocation.
And I think that is the reason why we have never used a dual mobility in such cases. There is no need to use a dual mobility. If you do a good combined anteversion is very important. More than even a the vertical and the horizontal offset, the combined anteversion is very important.
And good repair. We have published paper over it. Extended myocapsular repair.
Hello. Hello everyone. Can you hear me?
So we are about to start the surgery. So Dr. Andre, you dual mobility you do from the posterior approach or any approach, anterior approach? What is your conventional approach for the total lift and what is your approach for the dual mobility? Two questions.
My conventional approach is like you posterior approach. You can use dual mobility cups in all approach, of course. And I completely agree with you. If you repair correctly the capsula with a posterior approach, you have not so much dislocation, maybe a little bit more than a direct anterior approach, but with less morbidities about muscles. So I used posterior approach and of course the mobility. In this case, I agree that we are not, it's not mandatory to use dual mobility, but we have to remember.
Hello, good morning, Dr. Yadav.
Yeah, good morning.
This is the patient which we are going to just start. Show the X-ray. So
Thank you, Dr. Rajesh. Thank you for invitation. I am really enjoying my old institute.
I know this is home turf for you. This is, this is a lady who is 70 years old, and she has fallen and sustained a fractured neck of femur, the subcapital fracture you can see. So the bone is quite osteoporotic. So the plan is to do cemented dual mobility. So that is, of course, we are a public hospital, so we are not treating rich patients like Dr. Yadav. So this patient is poorly affording. Otherwise, we do prefer the cementless dual mobility also if the patient is affording. And there's always a debate about whether one should put cemented or cementless stem in fractured neck of femur. And you will find that in entire most of the Europe and the people prefer to do a cemented hip, whereas we are able to do a cementless bipolar in less than 15 minutes. So I personally think that the surgical duration, particularly in a patient with comorbidities, is very high and it's an important factor. But I think why people advise cemented bipolar or total hip in fractured neck femur is, one, the cost. Two, they are always worried about causing a femoral fracture by using a cementless stem. So that is why you will find if you say that you want to do cementless total hip, you will not find many supporters for fractured neck of femur. On the other hand, there are stem designs available which work very well for osteoporotic bone. And I remember that when we were doing the short stem, the Proxima stem by DePuy, which was a very short stem, and even in that time there were reports from Korea and Japan about the use of Proxima in very, very osteoporotic bone. So similarly, we have a stem, for example, taper lock by Zimmer. So there are published literature of very good results of the taper lock in osteoporotic bone. We have very deep stem bicontact, which is a European stem from Germany, and again that can be used very successfully in the osteoporotic bone without much risk of fracturing. But I think the whole problem is about money and about this. But personally, I think that cementing itself will add 15 minutes to the procedure. There are reports that the cemented hips have a slightly higher dislocation rate. And third is, of course, the modularity which we have in the cementless hip is not there in the cemented hip. So I have, except for an odd case like this where the patient is very protic or not affording at all, we prefer the cementless bipolar and come out modular bipolar if patient is affording. And if need be, later on, you can always take out the bipolar head and instead convert it into a total hip replacement. Dr. Andre, what is your choice for fractured neck femur, please?
Dr. Malhotra, it's very great to see you operated with a dual mobility cup. I have one commentary about what you said before about uncemented or cemented dual mobility cups. In France, we use the cemented dual multi-cups in less than 2% of case. I mean in primary, not in revision, of course. And why don't you use the uncemented cup? I think that you are not so much confident in your fixation, but in fact the fixation is really good, even for osteoporotic bones.
Bone, yeah, I agree.
And I use it for all patients. Maybe the status of the patients in France is a little bit different. India, maybe, I don't know. But the question is about the confidence we have about press fit. And that's the main difference we have with the United States, because in United States, they are not confident about press fit and this primary fixation. So that's the reason why they want to use screws. And that explains why Stryker, for example, sells a dermotic cup, the MDM, which is a modular one. And when you use a modular one, I think it's not a real dermotic cup. First, because you have the risk of the modularity and the wear of metal, of course.
Yeah.
And then you place this dual mobility without the design of a dual mobility. And we are not the time to explain it correctly, but the design dual mobility is very important, because you have to face the risk of dislocation with a retentive roof, for example, and it's why that's the reason why we have subhemispheric mobility cup or anatomic cup and so on, because the design is very important.
Yeah.
So,
So, Dr. Andre,
yes.
Dr. Andre, those are some great points. We continue this discussion. In the meantime, we are ready to start the surgery.
Yeah, great.
Just a small comment. This patient is getting cemented, not because the surgeon is not confident of putting a cementless cup, but because the affordability issue. The patient, that's much more expensive. So let's start the surgery.
Yes, but
Yeah. Thank you, Dr. Rajesh. Yeah. एम्स में तो अफोर्ड कर लेते हैं और पैसा नहीं लगता सर. हेलो डॉक्टर राजेश. अच्छा सारे कोई भी ज्वाइंट और पैसा नहीं लगता है, बाकी पैसा लगते हैं. Which staff nurse is scrubbing with you? Many. Vinci, Martina, Maya, Ruth, then few more.
Dr. Yadav, Krishna here. Can you hear me now?
Yeah.
Yeah, so it's indeed overwhelming to be in the alma mater after 15 years. So this is a patient with neglected fracture neck femur, as already mentioned, osteoporotic. The knee is a little bit stiff, and these are the cases which can, look simple, but can end up with an intraoperative periprosthetic fracture if you're not careful. So we're doing the posterior approach. I hope you can see the incision. This is the head end of the patient. This is the foot end of the patient for orientation. This is the tip of the trochanter. The incision is 2-3 finger breadths below the level of the trochanter, going from the direction of PSIS more anteriorly. So this is a small incision surgery. And since it's a thin patient, we'll show you a mini posterior approach. If you have any visibility issues, let us know, because we are not able to see the what is being telecast.
It is fine. Krishna, it is fine.
The incision is a little bit oblique to allow us to prepare the acetabulum and cement it well through a smaller axis.
Yeah.
It's just the skin incision. Inside dissection is similar to what we normally do.
Yeah.
So just for the sake of younger surgeons, I will take us through the steps of the posterior approach. Okay.
Yeah. That is because many young surgeons, they are sitting over here, definitely.
Correct.
Yeah. We should teach them basic first, then later on advancement and
Correct. For
higher technology.
For hip, it's all about exposing the acetabulum properly and doing the proper soft tissue release. So now you can see that this is a facial later exposed.
Yeah.
The incision always begins inferiorly and then it goes superiorly up because it's easy to identify the vastus lateralis once you cut the fascia there, and that's the vastus lateralis we can see nicely.
Yeah.
And then he will do a mobile window technique where the assistant, I'm lucky to have Deepak with me, a good surgeon himself. So he is moving the retractor up. So that now I am able to identify and split the gluteus magnus. You can see that?
Yeah. We can see you are splitting that.
So I heard
even we can see the bursa.
Right.
That is most likely. That is
so normally in a neck femur, we would not do any soft tissue releases as you rightly pointed out.
Yeah. That is most important. That is my experience. Yeah.
Right. So I think
Do
that's
minimum
a very,
release. Yeah.
knowledgeable point you pointed out. But in this patient, because it's a long-standing thing,
Yeah.
start off with a partial release of the Gmax. You can see that I'm just doing a partial release.
Yeah.
And if you go further down and are not careful, you will have the first perforator there. So you should be careful when you're.
Yeah. Doing that. Yeah.
So now we'll put our Charlie retractor in. We'll abduct the hip in order to go underneath the gluteus there. And posteriorly, we should be careful not to impale the sciatic nerve.
Yeah, exactly. You have to be very close to the trochanteric border, not in the tissues.
Yes. So now we'll extend the hip. Nice. The incision seems little too small, but we will just extend it a little bit in order to see better for the live audience.
Yeah.
So now the assistant is extending the hips in order to keep the sciatic nerve away from the field of view. We identify the posterior border of the tip of the trochanter and stay close to the posterior border, identifying the posterior border of the gluteus medius muscle. So this is a constant landmark. The posterior border of the GT is the landmark beyond which the gluteus medius does not go.
Yeah.
And staying close to the posterior border of the greater trochanter again allows us to go inside the short external rotator capsule flap. So what I'm doing here is I'm making a pouch underneath the medius. And I will put an anterior retractor to expose the short.
Yeah. Just to So you will also release this quadratus partially.
Yes, sir. I will do a complete release of the quadratus.
Quadratus because it is old fracture, old so tissue might
You can see the piriformis nicely there.
Yeah.
And if you notice, the piriformis inserts more anteriorly, doesn't insert into the piriformis fossa.
Yeah.
It inserts more anteriorly, and if you cut close to its insertion, you'll be able to repair it back properly.
Yeah.
So this is a small tip for the younger surgeons.
Just detach from the bone, edge close to the bone. So
this is the gluteus medius, which we have to separate from the capsule if you will do. And we are staying close to the posterior border of the GT, and we are not rotating the hip because this is when the fracture will happen. In older patients, the soft tissues are hard and the hard tissues are soft.
Yeah.
So that's what you have to remember all the time. Assistants sometimes want to help the surgeon, but end up causing more damage. So that's the capsule there. But we will do a single layer release of the capsule and the short external rotators, and I will show how we put them back at the end of the surgery. So whatever be the case, whether it's a simple case, complicated case, these are the steps which you have to follow. Then the risk of sciatic nerve injury diminishes significantly. So, talkers, and I need a Steinman pin. Okay, Steinman pin. Small cellular. So now I'm grasping the whole posterior flap, and you can see that as long as we stay inside this edge of this flap, we are not violating the edge, you will not damage the sciatic nerve.
Yeah.
So this is a key point, especially in acetabular fractures and revision surgeries. So there's the acetabulum. So now what I will do is I will give a small radial incision here You can see I'm getting a radial incision into the capsule.
Capsule, yeah, just to take out the head, yeah.
To expose the operator externus muscle.
Yeah.
So this is the operator externus muscle, as
Externus.
you can see. You can see nicely the operator externus. And now I am able to access the ischium. And I'll put a Steinman pin into the ischium, okay? So it will retract my entire posterior flap out of the way during the surgery.
Yeah.
So normally I use a Charlie pin in the ischium to retract the posterior flap, so you can see the direction and you can listen to the noise. So it's nicely in the ischium, it will not move, okay?
Yeah.
So this has done our posterior job for us. Now what we will do is we will do anterior capsular job. So now I am repositioning the spike underneath the gluteus minimus muscle and I will release the anterior capsule under vision. So you can see, I'm not sure if you are able to see, but we can see nicely the anterior capsule being released under vision.
Yeah, we can see that.
Yeah. Right. So we're not in a hurry to do anything, dislocate or anything like that, but it's still moving the hip.
Yeah.
Now I will release further part of the gluteus maximus under vision. You can see that the first perforator is just there underneath that muscle.
Mm-hmm. Yeah.
And if you're careful, you don't need to, ligate it or anything like that. Right. So the key to acetabular exposure in complex cases is femoral mobilization. So you have to do more release on the femoral side, especially in patients with long-standing high-riding hips. So they look all right on the X-ray, but may be difficult to access. So now since the knee is stiff, we are gently trying to internally rotate it. There is still no internal rotation. So we'll complete the capsule work. We are in no hurry to internally rotate it. So I'm releasing the inferior capsule from the scalpel area.
Yeah.
Now we get a little bit better internal rotation. Okay, so you can see that there is some internal rotation that we have been able to achieve.
Yeah.
And the challenge with this case is that we do not have knee flexion. So it's a challenge to identify the femoral version.
Yeah.
So at this stage, I have not still released the iliopsoas, but I have a feeling we will have to do it at some point in time to get more internal rotation for acetabular exposure.
Or if you can do some osteotomy of neck, so you will get a good acetabular exposure. Sometime.
I will do that. The first step is to do the neck osteotomy.
Yeah. So
we have templated that the coronal stem will sit very close to the calcar.
Yeah.
So if it has to reduce, okay. So we are okay to do the thing. And can you zoom out and show the leg position? So if you're not able to flex the knee, then you will have to internally rotate till the condyles are parallel to the table, and that is what gives us an idea.
थोड़ा उसको upside down कर दोगे? I think वो cameraman.
मेरे को दिख नहीं रहा. You can manage them because I am.
थोड़ा zoom out करके दिखाओ. Zoom out जिससे पता लगे exactly limb की position. Yeah.
Leg position zoom out करो.
Yeah, no, it is fine now.
Okay.
So इसको उल्टा कर सकते हो? Hip just 180 degree or 90 degree. If it is possible, not otherwise it is fine.
नहीं हो रहा sir.
Yeah.
So I'm taking a more neck cut than I would normally do because I've templated that it is sitting. नहीं कम करो.
Yeah.
Okay. We've templated that it will sit very flush with the lesser trochanter.
Yeah, yeah. And when you are doing neck osteotomy, try to avoid damage to the greater trochanter.
Yeah, that's a very valid point. So that is why I have not done the osteotomy all the way laterally.
Yeah, yeah, I saw that. I noticed that. Yeah.
It's a very soft bone.
Krishna is excellent surgeon, and we पूत के पाँव पालने में दिख जाते हैं. जब ये सीनियर रेजिडेंट था तब हमने देख लिया था. कृष्णा,
Thank you sir, thank you for the kind words.
जब ही पता लग गया था हमारे को.
So we are removing that neck dismal, and that gives us access to the anterior capsule. So you can see that now there is an access to the anterior capsule.
between the scissors again. ऐसा chicken scissors. Some portions do. So this is the psoas, and that is the anterior capsule. So
Yeah,
we will
yeah.
release the anterior capsule under vision, okay? And that will give us some more rotation.
Yeah.
So you can listen to the sound of the anterior capsule being released. Yes. And you can see that we are able to rotate it more. So now we bring the leg back into neutral position. Now I'll take a hook. Take a hook, please. Release cursor. So the leg is flexed to around 40 degrees.
Yeah.
It is internally rotated around 35 degrees.
Yeah.
And the assistant takes a hook onto the greater trochanter or the calcar and pulls the thing forward. So in osteoporotic bone, it takes, sense to be careful.
You have to be careful, yeah.
Yes. So this is the excess anterior capsule fibrous tissue which has formed in the fracture site, which are now excising.
Yeah.
Very good straight spike like this.
Or you can take long cautery tips sometime if we are going deep inside. We have in theater 2 tips, standard and long, little long, like medium size.
So I've done a little bit of capsule work. So now the anterior retractor goes in place. Straight push to the So you palpate the anterior superior iliac spine. The anterior superior iliac spine is the guide to the anterior column. So you put your anterior retractor into the anterior column, not into the anterior wall, mallet.
Yes.
And the position of the leg is 40 degrees of flexion and 35 degrees of internal rotation. And then we gently take this because it's osteoporotic, but I'm able to go into the anterior column there.
Yeah.
The assistant holds it with one hand. Now you gently flex and externally rotate the hip out of the way.
Yeah.
दोबारा कितने बड़ा वाला है ये वाला careful will break the trochanter. So this bone is really osteoporotic, so we are being more careful.
Yeah, exactly.
I will do just a little bit more of capsule work. Okay. Just pull it a little bit. And we will extend the incision really because I am finding it difficult to, expose the acetabulum. Nice.
Yeah.
And we'll do more femoral release because I'm not happy with the way the acetabulum is
Exposure properly. Yeah.
So I'll now do a 300-degree release of the femur.
Yeah.
Till I'm able to internally rotate it completely, and that is when I will be able to expose the acetabulum in a better way.
Yeah, exactly.
And that will also help us with reduction of the hip. Yeah. So the further G-mats again we are releasing from the femur. You can see here.
Yeah.
The vastus lateralis, the gluteus maximus insertion, and as the first perforator you can see.
Yeah. Visuals are very clear. It is good audio and visual both.
You can nicely see the first
Nicely. Visuals are quite clear. Yeah.
Cauterizing that to avoid any inadvertent. Now you can keep internally rotating the hip. So now I'm mobilizing the thing. At some point we'll have to look at adductor tenotomy as well. Probably at the time of trial reduction we will look at adductor tenotomy here.
Yeah.
So but now I'm doing what we call as a 300-degree release of the femur. So
Yeah.
I will release the psoas. I will release the anterior capsule, everything because it's a high riding hip technically speaking because it's around 2 or 2.5 centimeters short.
Yeah.
And it's stuck in that position for a while now. So that's the psoas I'm releasing, and then I will release the anterior capsule. So I have low threshold for doing this in complex cases because otherwise the hip exposure becomes difficult.
Yes.
So now the hip is more mobile than we think it is. Yeah. Hook be carefully लगाना है तो टूट जाएगा.
Right.
So now I'm doing further a bit of capsule work on the anterior-inferior side. You know, I don't think you'll be able to see this, but it's mandatory for us to expose the acetabulum. So now the head is coming into view and Deepak is a little bit happier. He was unhappy with me so far, so it's not my fault. The case is not as easy as he thought. Towel clip ले लो. So all these chronic cases, a lot of fibrous tissue which is formed, which we have to carefully remove. Now we can see the femoral head.
Yeah, we can see that. Yeah,
Yes.
White, smooth cartilage. Yeah. Exactly. Yeah.
So there is some movement in the femoral head.
It is moving. Yeah.
Yes. And I'll remove a little bit more of inferior capsule. Please bear with me.
Yeah, it is old case. So a lot of fibrosis, tissue tight.
Yeah. Dr. Andrew, would you see similar cases in your country or it's not common?
Second.
Focus. अब देखो आ जाएगा अभी लग रहा है ऐसे लगाएंगे एंटी रिट्रैक्टर दे दो स्ट्रेट वाला दे दो मुझे जो आदत है वो लगाते हैं. So now we have access to the, so why the ASIS is important? Yeah. So now you externally rotate and flex the hip.
Yeah.
And then you have access to the anteroinferior capsule, which you give a radial incision on. So then you will get more exposure. Right. So again, you have to expose the operator externus. Okay. Inferior retractor दे दो. ये लगाते हो आप लोग? अच्छा ये लगाते हो. So that's the inferior retractor going in now. And you can see the acetabulum. Can you focus from this side? ऐसे करो. हाँ इसको लगाओ. हाँ निकलता. So the key to difficult acetabular exposure is femoral mobilization. This is a key step. And, there is no shortcut to success in this.
Yeah. थोड़ा सा जूम आउट करके दिखाओ, बहुत ज्यादा मैग्नीफाइड है. हाँ. Yes.
स्टेम कर लें सर. ठीक है सर कर देते. नहीं हम यहाँ पे जैसा होता वैसे कर देंगे. टूटेगा वो. I know, no, but it's also a good idea in osteoporotic bone. In osteoporotic bone, it's a good idea. Otherwise, femur पूरा हो जाएगा, दब जाएगा. Yes, we'll remove the head and prepare the stent. So you can see the head nicely here.
Yeah. We
and
get it.
you know,
It is
pull
coming
it out. This is the ligamentum teres. It's attached.
Yeah.
Scissor दे दो. Can you measure the head, please? Size card.
Yeah.
So we
yeah.
always measure our femoral. You can see now.
Yeah.
Nicely, you can see the tal. You can see. थोड़ा इधर से आना. वो वाला कैमरा दिखाओ. Acetabulum का व्यू दिखाओ. कर ही देते हैं.
हाँ बढ़िया दिख रहा है.
अभी इसको फिर चेंज ना करें. हो जाएगा. नहीं इसको कर देते हैं. हो जाता काम. 5-10 मिनट में हो जाएगा. फिर वो कर ही देंगे. हाँ. Hold ही कर रहे हो. You can see the acetabulum well now.
Yeah, exactly. We can see that.
To 40. So the head size is around 40. So the cup will be 40, between 42 and 45, 46. So we should be around 3 millimeter larger and not more than 5 millimeter larger than the head size. Okay.
Yeah.
So it's a very small acetabulum. It's a good option for dual mobility, because otherwise with a 42 cup you will end up with a 22 head.
Yeah, 22 head. Yeah.
Which is okay in a chronically contracted situation, but as you rightly pointed out, acute neck femur may not be a good idea. So maybe 32 or 36 will be a better option if you can. So anyhow, we are planning for a cemented cup in this case, which is probably a good idea. The reamer this one. So is the acetabulum properly seen?
You are planning for cemented cup, huh?
We are planning for a cemented cup. Yeah.
So because of financial things, huh?
That's right. Yeah, that's right. And also micro cups without screw is not a great idea.
Yeah.
So when you have micro cups and you want to put it without screws, may not be a great idea. So we are happy doing a cemented cup in this. Elderly, low demand patient, and I think it's fine. But your point is well taken. Now the standard of care nowadays is uncemented on the acetabular side. So I'm removing the pulvinar. You can see that.
Yeah.
And you can see that we've exposed the tile nicely. So we'll align our cup along the inner margin of the tile. So I'm marking the inner margin of the tile. Can you see? Can you show this marking?
थोड़ा सा zoom out करके दिखाओ.
Zoom out करो, zoom out करो.
थोड़ा सा head and foot. ये इतना ही magnified दिखाओ ज्यादातर time. जितना भी दिख रहा है बहुत ज्यादा magnified से भी थोड़ा सा confusion होता है.
ये ठीक है सर अभी?
हाँ नहीं हाँ थोड़ा सा.
और कम करें?
हाँ zoom out थोड़ा.
Zoom out करो, zoom out
थोड़ा सा.
मेरे व्यू से दिखाना, ऐसे दिखाना, ऐसे मेरे शोल्डर से आ रहा है. अच्छा. Okay. So you can see we have exposed acetabulum reasonably well for the situation. So can I have the reamer, please? So you can see the cartilage there. We have removed the pulvinar and the corticoid fossa, which you can palpate is exposed.
Yeah.
So the first reamer goes inferiorly down till we match the corticoid fossa to the residual cartilage. And now I will go in the definitive direction. So this is 90 degrees for the sake of audience. Zoom out. And we are bringing the hand down. And this is the direction of the arm, that is 0 degree of version. And we are going around 15-20 degrees of anti-version.
Yeah.
Okay. Since the bone is soft, I am also careful. I am not being overzealous with reaming.
We can see the bone is bleeding.
It is already bleeding. So if we are not careful with the reaming, you will go into the pelvis.
Pelvis, yeah.
So for the sake of younger audience, we will demonstrate how to choose the size of a uncemented socket in a situation. A lot of the people have confusion as to what will be the correct size of the acetabulum. If you notice when I am reaming, there is no capture between the anterosuperior and posterior columns. If there is capture, there will be resistance. Okay. So the moment you achieve that resistance, you have AP capture. When you put in the cup in that situation, the cup will not rotate. So I will show you with a trial cup. 44. So this is the size which we will do. So this now you can see it as a AP capture. Okay.
Yeah.
And this is probably the size based on our templating on the head size. Curate this. So give me a 44 trial, please. So I'm just taking out the remaining cartilage because very soft. We don't want to keep on reaming. So I'm happy with this thing. It's adequately medialized.
Basically, acetabular reaming is art. You learn it with the experience. It is not like take a reamer and do. So we are to push little hand down, we are up and so it should be proper ream, and sometimes you tend to ream more posterior wall. So it opens up. Sometimes you may take away anterior wall.
You can see here, when I put in a trial cup and rotate it, it's not rotating. That means now I have AP capture. But there is a superior inferior toggle little bit, That's because of osteoporosis. But if you have 3-point fixation, you will not have rotation and you will have a stability perpendicular to the direction. When I'm trying to move it, the
pelvis is moving.
Yeah, so
pelvis is moving.
so that's how you determine the size of the uncemented acetabular socket. Every single case, you should have at least AP capture, whether it's a primary revision, whatever is the situation. If you don't have AP capture and just put a cup hanging in with some screws, it will pull out. Get the point?
If there is no financial problem, it is always better to do uncimented cup. Even with the osteoporotic bone, if you are intelligent enough, you can come out with the uncemented cup. Stem may be cemented or uncemented, doesn't matter. But cup, what I feel should be always uncemented.
45 cup है. Normal cemented cup डालने के.
And failure of cemented cup is much higher. Stem side, it is not a big issue, but cup side, it should be cementless.
44 47 करना पड़ता ना उसके लिए.
And if you also saw the when he was taking a trial, there was a little bit of exposed trial outside the shell. That means that his inclination is perfect. Never try to match it with the acetabulum. That will make you more vertical.
42 चाहिए minimum. 42 या 44 भी चलेगा. Nibbler. So we are just waiting for the real component to come in. In the meantime, I will make some drill holes in the acetabulum for cement anchorage.
Krishna, yaar, ye nahi bataya ko which staff nurse is scrubbed with you?
No, Maya is junior Maya, na?
I still remember them. They were greatest I have seen in my life. They are our AIMS staff. They are wonderful, really uncomparable to anybody.
That is true, sir. I would agree with that. Also, the residents are like, not this one, bigger.
Resident, they improve, but they are really wonderful. That's my experience of last 22 years at AIMS.
Cemented. Yeah.
But our Primus OT nurse, they are comparable to the AIMS nurse. I'm extremely happy with them. Not like Gangaram. Gangaram nursing male and they are very...
Sir, but Primus surgeon is also from AIMS.
They are very smart, our nurse, very quick.
So we are making anchor screws for the cement into the dome there. You can see again, the line joining the ASIS to the PSI, the ischium is the line which is a money line for a hip, whether for inclination, version, whether for making the screw holes or anchorage holes.
Yeah.
45.
So how many hole you are making? Multiple?
I will make multiple holes.
Multiple hole, yeah. And what is the diameter of that drill?
This is 5 millimeter drill which I am using.
5 millimeter.
Yes.
Yeah.
So I made anchorage holes.
Yeah.
The cup, minimum size cup they have is 45. So I have to ream a little bit more, which I am uncomfortable. But we want to do it. There is no choice now. 45 reamer laga do. Cup open karo. So ideally you should ream a couple of millimeter more, but I will not ream till 47. I will ream only till 45 and I will stop there. And it's a metal back cup, very osteoporotic bone, so it's okay. So we are okay with that. So 46 level. Cement mix kar lo. And now we will time the cement mixing and we will use it at around 4 minutes after mixing. Cement mix kar lo aap.
Yeah. Which cement you are using?
We are using Palacos, I think.
Palacos, yeah. With antibiotic?
With antibiotic. Drill फिर से लगा लो. So now the key step is to ensure bloodless field in the acetabulum. So this is what I don't like. So you may be a good surgeon, but it's very difficult to ensure a bloodless field in the acetabulum.
Which cup you are using, Krishna?
उधर नहीं करूँ. So we are using the Evolutus dual mobility cup, sir.
Evolutus, good.
It's really soft, this bone. Wash दे दो, pulse vac ले लो.
Yeah.
है pulse vac? नहीं, pulse vac है. Pulse vac ले लो. अच्छा wash कर दे. Give me the head, please. Give me some graft from the head. हाँ ये दे दो मेरे को बस ये ठीक. बाद में दे देना है. सीमेंट मिक्स कर लो, ग्लव चेंज करा दो मेरा। 45 ओपन करो। हाइड्रोजन पेरोक्साइड गॉस पीस ఇది ఇది ఇక్కడే అక్కడే.
Which pressure lavage is this, Krishna?
This is pulsatile lavage from, I think, is it Striker one? It's Indian company? ये कुछ इंडियन कंपनी है सर, इसका नाम EMT है।
हाँ, स्ट्राइकर या जिमर में से नहीं लग रहा मेरे को, that's why sir.
स्ट्राइकर जिमर नहीं है। तभी पूरा मेड इन इंडिया है ना सर?
हाँ, पहुंच जाएंगे वहां, तो उस लेवल तक टाइम लगेगा थोड़ा।
कप दे दो ना, हाइड्रोजन पेरोक्साइड दे दो, कप दे दो यार। हाँ, ओपन ओपन एक बार चेक करना हमको। या ओपन ओपन 45 ओपन ओपन दिखा दिया इधर इधर दिखा देंगे, ओपन करके दिखा देंगे। सो वी आर डूइंग, सो दिस इज ए मेटल बैक सॉकेट, it's a cemented dual mobility. I think Evolutus is the only company which has this option.
Yeah.
So it is our go-to option for revision cases. You know, whenever we are using a cage or something like that, or a team or shell, so we would cement this into that, and then you're safer because they are high risk for instability.
Yeah.
But neck femur, I would agree with you. I would do a standard hip replacement if possible.
So do you use hydrogen peroxide for the?
Yes, sir. We are waiting for the hydrogen peroxide. We will wash it with hydrogen peroxide.
Okay.
दे दो ना, हाइड्रोजन पेरोक्साइड ले लो यार। हाँ, तो ये ले लेंगे थोड़ा।
This is Evol.
बस उसको वो करके। So now we're taking a hydrogen peroxide mop, and then we will use a little bit of bone graft medially, the remix, just to make sure everything is fine. And I'm using the hydrogen peroxide mop inside.
Yeah.
To make sure that it is dry and bloodless. सीमेंट मिक्स कर लो। हाँ, मेरे को हाथ में दे देना ये, मेरे को इसका जरूरत नहीं है, फिर पुश करने के लिए पुशर लगा देना। So this is the cup, and these people have got a very good handle for introducing the monoblock cup. So you can just put it inside, tighten it. So for the uncemented cup also, it's a fantastic handle. It's not as cumbersome as Delta Motion or the BHR cup.
Yeah.
So it's one of the very sleek type of handles I have seen in the market. And this is the highly polished surface inside, metal back cup with lot of ridges for cementation.
Yeah.
So just give us a couple of minutes. We are getting the cement ready, and then we will cement. हो गया, लग गया। Cement pressurizer है क्या? Can you make a cement pressurizer?
Krishna, you might be having nostalgia of your old days over here.
Yes, sir, absolutely. 44 लगाओ और glove लगा दो इसके ऊपर, इसको लगा दो।
Dr. Rashes, what is very interesting when you cement are the holes you have done. It is like Charnley's technique about cemented fixation. And we have to remember that the first uncemented cup of Bousquet, the first dual mobility cup, has 2 pegs.
Yes.
Because he wanted a tripod fixation, exactly the same with the cementation with holes. At the beginning, it was exactly the same philosophy.
That's right. Yeah, that's a very valid point you have brought out. ये लगा ना, ये लगेगा नहीं, वो किसी हैंडल में लगता है ना, उसमें लगेगा, देख लो। इसका हैंडल लगेगा नहीं, यही लगेगा। सीमेंट प्रेशराइज करना है मुझे। वो वाला जो है ना बाइपोलर, हाँ वो लगा दो। हाँ, वो सबसे छोटा कप को लगा दे, ग्लव लगा दे उसके ऊपर, ब्लैक वाला सबसे छोटा 44 या जो भी है। सीमेंट दिखाओ जरा, सीमेंट दिखाओ सिस्टर, सीमेंट दिखाओ। पानी दे दो मुझे। या कितना है वो? या So it's around 4 minutes from the mixing of cement. So now we are happy to go. And we'll use a little bit of cement pressurization and see, hopefully it will work. थोड़ा time है अभी, 1 minute time है, वो दे दो ना. Suction ready है. 41. छोटा है. बस लगा लो. निकाल दो. Yeah, take it out slowly. Wow, suction रख लो. We are okay, reasonably okay with the thing. Yeah. And I am putting the cement in. Yeah. And then we will, for 30 seconds, pressurize the cement using this device. Yeah. So use the timer, please, to pressurize the cement.
You use a trial head with covered with glove.
That's right. So we use a bipolar head with a powdered glove, which is wet. Just for, we don't have the silicon pressurizer here at this point in time, but we do have it here in our country.
This works quite well, actually.
Yeah, it's fine. It will take long time. इसमें गड़बड़ करने की जरूरत नहीं, आराम से कर सकते हैं.
And for the new guys, actually, this is one step where you should be careful and you should be patient also, because you're worried. You don't want to wait too much.
So you can see that the cement is nicely pressurized.
Yes.
By the glove, and nothing has been attached to the glove. Now we are ready to use the cup. So I prefer to, see the tile alignment which we have marked, and then we will go with hand from inferior to superior. Okay, that is how we do our cementation, and it is pretty straightforward. And इसको रिट्रैक्ट करना, स्ट्रेट वाला पुशर दे दो ना, स्ट्रेट वाला. नहीं कुछ मत करो. हाँ बस वो निकाल दे सीमेंट inferiorly. So this is slightly oversized as compared to the patient socket. We do not have a 42 or a 44, 43 acetabulum with us, but that's what we have to make do. That's fine. And pusher दे दो. हाँ वो आ गया. So now we are holding the cup pressurized in the correct direction, and a little bit of overhang is there because it is, oversized. थोड़ा अंदर पुश कर देते हैं इसको. नहीं वो निकाल देना सीमेंट. बॉटम आउट नहीं हुआ तो प्रॉब्लम हो जाए. ओके राइट. वो थोड़ा कवर कर दे उसको सीमेंट से. सीमेंट दे दो. बड़ा साइज लगाने से ना डिफेक्ट हो जाता. कुछ नहीं कर सकते, निकलना तो पड़ेगा. ओके ये थोड़ा रिट्रैक्शन ठीक से करना. बस बैलेट दो.
Even if the hermetic cup is very forgiving about dislocation, it's very important, like you do, to place correctly the cup. And there are so many surgeons that think that it's not important to place correctly the cup, and then they have chase with the dual mobility cups. You not to the dual mobility cup, but to the technique.
Whatever you use, technique always matters, simply. So it is not. Dr. Andre cleared that technique should be good, whether it is conventional or dual mobility.
डायरेक्शन ठीक है ना? हाँ, ये ठीक है. So now we are waiting for the cement to set. So that's a little bit of a challenge with cemented implants. That's okay.
But Ross Crawford will be very happy if he come to know Krishna has done cemented cup in Brisbane, Australia. He will be very happy with you.
He himself is not doing cemented nowadays, I heard.
Cup side, he is both cemented and uncemented, but this time is always Exeter cemented.
That's right, yeah. So in my practice, I use a bit of cemented. It's not that it's not un. ठीक है ना? ठीक लग रहा है? हाँ? पूरा कवर्ड ही तो है.
परफेक्ट लग रहा है.
बड़ा है.
परफेक्ट.
कप बड़ा है. So this cup is a little bigger than what I would have wanted to put in. Yeah, so that's the only regret I have. Otherwise, it looks okay.
Are you having an overhang in the anterior aspect also?
There is no.
Why are you saying it is over?
There is not overhang in the anterior aspect.
Okay.
But for a cemented cup, I would want it to seat completely in. It's not like uncemented where we are accepting a little bit of posterior superior overhang. You want it to be completely seated in. And second thing is that we have to ream till around 47, 48 for putting in a 45 cup for the cement mantle. So this is reamed only till 46 because beyond that we will ream out the column. So,
Krishna, this is Kharbanda. So how much did you ream and what size of the cup have you put?
So that is what so the question is like. We ream till 46 because that is probably the last I would go with this particular patient. And the cup we have is only 45. We would have wanted to put a 43 cup.
Oh, okay. So you
ideally.
have that, yeah.
So it's a sort of a compromise because of the inventory we have here. Andre, do you have sizes starting from 40 in France?
Andre, what is the minimum size of cup that you get there, cemented?
Of course, we have to use one size less than usually.
We do not have anything less than 45 here. Do you have lesser than that there in France? The smallest possible cup size.
नहीं वर्टिकल हो ही नहीं सकता. वो तो
cemented
क्लोज होता है. मेरे हमारे हाथ हम लोग डॉक्टर बान के स्टूडेंट ऐसे आते.
So Krishna, can you also tell us, for the sake of everybody, that how do you prevent bottoming?
How to prevent?
How do you prevent the bottoming of the cup?
Yeah,
you know,
so
in a plastic cup, there are nowadays, in Exeter at least, there are pegs, you know, at the back.
Yeah,
in this cup, there are no pegs, I suppose.
That's very valid point. So what we have done, as you have seen, is we have put the cement after 4 minutes when it is pretty doughy and almost beginning to wrinkle, and then we have pressurized the cement for 30 seconds into the host bone. So I am not using the cup to pressurize the cement into the host bone. I am just putting the cup where it is meant to be. The problem happens when you are trying to use the cup to pressurize the cement into the host bone. So it is an independent process. You put the cement into the host bone, pressurize it for 30 seconds. Once it is nice and stuck there, then you introduce your cup. And there is a little bit of additional cement which is always present, so which will prevent bottoming out of the metal cup onto the floor. And you do this every single time in your practice. You don't, keep changing the way you do it so that the team gets familiarized. So I asked them to time the cement mixing. So it's around 4 minutes. They will give the cement to me. For 30 to 40 seconds, I'll pressurize it. 5th minute, I will introduce the cup, and it will take around 7-8 minutes for the cement to set. So that is what is the protocol. हो गया set. इधर हो गया. हाँ नहीं नहीं इसमें ये क्या होगा ना, हमको कोई जल्दी नहीं है। तो डॉक्टर मल्होत्रा का स्टूडेंट है, वो भी बोल रहे थे एयरपोर्ट में, तो उधर वन लेडी वाज देयर, सो शी वाज ट्राइंग टू पुट हिज टिकट इन एंड इट्स नॉट कमिंग। तो उसने बढ़ा क्या, तो हो गया वो। तो आई आस्क्ड हिम सर उसने क्या एनलार्ज किया क्या बारकोड, इसे नहीं नहीं उसने हाथ लगाया वो ऑटोमेटिक बड़ा हो गया। मैं पूछूं Andre. Dr. Andre, what proportion of your hips do you do dual mobility? All young patients also get dual mobility, or only the high risk ones?
Overall,
Do you do all hips as dual mobility?
No, not all explained, but for about 80% of my patients.
Okay, so I am sure you have been operating for a long time now. So, have you seen any intraprosthetic dislocations with your dual mobility young patients?
You didn't have dislocations with dual mobility.
intraprosthetic dissociation.
Intraprosthetic dislocation, no. Nowadays, we don't have it anymore. Maybe with very old implants sometimes, but with the new implants, no. We have no intraprosthetic dislocation since 10 years.
Yeah, I have also same experience.
Dr. Yadav, are you using the Striker MDM cup or the Evolutis one?
Striker MDM.
Yeah, so can you just tell the younger audience what is the difference between the two dual mobilities for their knowledge?
Yeah. Basically, this acetabular component in a striker, it is two-part. So it gives little easiness to the surgeon. But you have to be in striker that metallic shell may come out if you do not do properly lock it. And when you put a screw, sometimes a screw doesn't allow you to properly lock in of metallic shell. So here it is not a problem. It is a single block acetabular component. That is the advantage.
So this is a final picture. We are slightly out of the towel because it's oversized, but the inclination seems okay to me and it is reasonably stable. So we will go with the femur now.
Yeah.
So I'm removing the Steinman pin on the ischium and the retractor from the anterior column. And now we will see if we are able to pull the hip down. So with all the releases we have done, it is, reasonably easy to pull it down.
Yeah.
Right. Yeah. Okay. So now can you zoom out and show them how to handle a stiff knee? Right. So because the knee is stiff, the assistant is holding the leg internally rotated. I'm not able to bend the knee at all. So you can understand the complexity of the case.
Complex, yeah. It is difficult when you are not able to flex the knee.
Yes. So, so now we'll gently prepare the femur. So I'm not going to remove any bones. I'll just enter posterolaterally and make sure I'm as far lateral as possible because we're planning for a cemented stem. So now you can see here that this trochanter is tending to give up. See?
Yeah.
So that's okay. That's fine. We'll wire it at some point in time. It's very osteoporotic. So we will plan for a cemented stem. Yes. बस rasp दे दो.
Which stem is this?
So this is coral, but we'll put a cemented stem.
Coral cemented, yeah.
And so the direction is along the posterior neck plane, and we are. So I will accept a little bit of wiggle, but this is not the size, so we'll go a little bit up.
Yes.
But normally you should have axial, rotational, and stability, and no interface mobility. So this is okay, reasonably stable. So all that is wiggling, I'm okay. I'll just do a trial and then we will wire डाल देंगे ना एक prophylactic एक wire ले लो. We will just put a wire around the proximal femur because we feel that there is a small crack which has happened here due to the retractor, and we don't want it to propagate down.
Yeah.
As you can see, the bone is almost papery thin. So, passer नहीं है, दे दो, इधर से ले लेंगे. So before we do the trial, we'll just put in another prophylactic wire inferiorly to prevent further spread of that whatever is the crack.
Yeah, trochanter. Yeah.
Yes. The end we will, get it together.
Krishna, do you use bisphosphonate for these patients post-operatively?
Yes, sir. I put them on teriparatide and then later on switch to bisphosphonates. So that's a interesting point.
So I always use bisphosphonate in these patients, whether it is knee and hip, because.
कर दें? हाँ, बस ऐसे कर दें. Right. So you have seen, sir, that we have been very careful and all that, but still it is the osteoporosis we are fighting. It's not related to any forcible retraction or something like that.
Yeah.
And you should always be aware that this can happen and avoid, propagation of this sort of thing. So prophylactic wiring is a better option than dealing with a fracture. Okay. So there is no harm in putting a wire. Cementless करें? Cementless करें? It's very osteoporotic. Very osteoporotic. वो दे दो. Not because of the crack. हो जाएगा, but very osteoporotic. जैसे ऐसे करने से जा रहा है. वो दे दो. Trial दे दो. Cemented ही better है. Cemented ही better है. कुछ नहीं करना. हाँ. बस. क्या करेंगे? तो क्या? खींचो. और कौन सा है? कोरेली है सीमेंटेड. सिंक कर दे सकते हैं. सिंक कर दे. उसको अंदर सिंक कर देंगे ना. We will sink it inside the real stem. We have no choice because सिस्टम है अपने पास. तो वो इसके लिए आइडियल नहीं है.
It is too tight, what you feel, huh?
It is too tight, sir, but it's a cemented stem, so we will sink it a little bit inside.
Yeah,
so I'll take this stem out and take a smaller sized stem, because then we'll be able to sink it in a little bit more.
Yeah.
Okay, you can see it's loose only, it's not very tight. 8 days.
Because it is old fracture, so it happens.
It's quite an old fracture.
Yeah, yeah.
And bone is pretty osteoporotic, so we don't want to take chances.
Yeah, yes.
So that's the benefit of a cemented. You can adjust the craniocaudal length of the limb as well. -3 का head ले लो और उसका trial बना लो.
Do they have that coral neck shaft angle 125 as well? They have two angles now in this stem. 135. It looks like a 135.
So this is a, you can see this is a 22 mm head which has gone inside a.
So it is better to use 125 if they have an OT, if hip is tight.
I don't think they have that. Rotation कम करो.
For last many years, they are giving in two neck angles.
Right. So now we are able to reduce it.
And 125. Yeah.
You can see that we have been able to reduce it very gently.
135.
We've done all our soft tissue releases before, and the adductors are not very tight, so we don't need to release the adductors. And you can see that it's very stable. Can you see that?
Yeah.
So there's a dual mobility concept is head moves inside first, and when it starts impinging, then the outer polyethylene head will move inside the cup. So this is extremely stable, and we will just quickly go ahead and cement the stem.
Zoom out पूरे limb को दिखाओ जरा, पूरे पैर को दिखाओ.
So you can see full extension, and this is full flexion, full adduction, internal rotation, extension, external rotation. So it's pretty good. Yeah.
Limb length, how would you check limb length?
Yeah, limb length we will check with the comparison with the opposite leg, and it looks pretty restored.
Yeah.
And in these cases, leg length takes lesser priority as compared to the
exactly.
ability to get out of the situation.
In few circumstances, you have to compromise one point.
Yes.
One aspect
No,
of the
rotate
surgery.
mat karo, rotate mat karo. No, don't do anything. Just हाँ भी करो. जो करने नहीं. External rotate, internal rotate करो.
Because knee is not flexed, so it is difficult to reduce, even dislocate in this situation.
Yeah, we are being extra cautious, you know.
Yeah.
Because it is a. So we will measure the neck length, and then we will put our real implant similarly. Okay. Scale. So since we have chosen a cemented option, we have the ability to restore the craniocaudal position, adjust it. If it were a uncemented corail, we would not have been able to reduce this.
Yes.
इसका एक बार निबल कर देंगे. छोटा निबलर दे दो. Elevator लगा दो. So we'll just take out the excess bone there, whatever is the excess bone, and it will give us a better idea as to how much to sink the implant.
Yeah.
So when we were templating also, we found that we had to push it in more distal to the lesser trochanter in order to reduce this hip. So a standard exeter type cemented would have been a better option. Exactly. Same stem open करो. गन से करेंगे. इसका handle ले लो. Cement restrictor दे दो और इसको निकालने का दे दो. Roach handle. So the problem with these tapered wedge stems is as they go down, they can cause subtrochanteric fractures. So we cannot put an uncemented stem in this situation and undersize it.
Yes.
So that's a important take home. Yeah. Give me this thing. नहीं सीमेंट गन कर देंगे. तुम्हारी मर्जी है जैसा. सीमेंट रिस्ट्रिक्टर दे दो ना. तो स्टेम दिखा दो. rasp, last rasp.
It is a Harding type restrictor?
Yes, sir. This is a Harding restrictor. We'll leave it around a centimeter below the size. So it's
tip
around,
of the stem, yeah.
Yes, sir. So it's around 140. Yeah.
Even I use these in the revision total knee arthroplasty when we are using stem. So it can be used in the knee as well, these restrictors.
Mallet de. Femur na thoda. Mallet. वो कट ही जाता अंदर. So that's fine. So we are okay with that. Now we will do some. Do you have a? इन्फ्रंट फिटिंग के वॉश दे दो. पल्सा वैक दे दो. ब्रश टिप है आपके पास? ब्रश टिप नहीं है तो नॉर्मल दे दो. हाइड्रोजन पेरोक्साइड गॉज दे दो. नॉर्मल वॉश दे दो. ये ले ले. वॉश ले ले. वो रख लो. रोलर गॉज चाहिए. मिक्स करो. या गो अहेड. So we don't have a brush tip here today, but normally we would wash it with a brush tip.
Yes.
8. So, more wash, please. There's a lot of cancellous bone, so no problem anyway.
Yeah, good. You will get good locking,
Yes, good interdigitation.
interdigitation
More
of
saline, please.
cement. Yeah.
अच्छा अच्छा काम है ना, नहीं तो पूरा ऐसा हो जाता। हम लोगों ने कुछ किए नहीं, उसको रिट्रैक्टर लगाने से हो गया। हाँ, पहले ही ऑप्शन अच्छा था। दे दो, वो दे दो, वॉश दे दो। लग गया क्या? चेंज कर दो यार इसको।
GT will also become a little much more stable after your cement is set.
Yes, that's right.
We can see some mobility now, but once you do the cementing, it will be rock solid.
You can see that despite taking all precautions, because of the quality of bone, this has happened. So getting a crack is not a problem. You have to recognize and address it.
Absolutely. And I really appreciate your threshold to increase the incision size, get a little more visibility was very low. That helped a lot in getting better exposure.
Yeah.
And there was no struggle during surgery at all.
So there is a lot more surgeons can take home, because this is a sort of a case which a lot of people can see in their own practices. This should not be undertaken lightly, because it can, end up with a major issue. Slightly difficult exposure, upriding, necessity to do a lot of soft tissue release, osteoporosis. So you can look at all sorts of issues with this particular case, which must be addressed through preoperative planning and also careful surgery. So now we are ready with the cemented stem. Can you show the implant, please? इधर दिखा दो. दिखा दे. Cement दे दो. So this is the implant. So we are undersizing the implant a little bit because it's cemented. I can push it in a little bit more for adjusting the leg length, and the cement mantle will compensate for that. This is a Corel cemented stem. It's a tapered wedge stem, Muller type design. So these have done pretty well, as have the exeter type stems. So there's no issue for using this sort of a stem. वो दे दो ना, नहीं infant feeding tube ले दो. So now I'm removing the thing. You can see we have a nice dry canal. Better to put. लगा दो ना, दो ना जल्दी. Cement ready है. So the cement has been mixed on the back table just for the sake of time. And again, 4 minutes, we are ready to cement. We are using an infant feeding tube to pull the cement into the thing, and using this cement gun distally down. Oh shit! And this has come off. वो दे दो ना इसका pusher. Right. So you're doing a retrograde filling of the medullary canal. You can see that. ये निकाल के दो और थोड़ा सीमेंट चाहिए. निकाल के दो. So we do not have a proximal pressurizer today, but we must make sure that there is adequate cement mantle all around the stem and distal to the tip of the prosthesis. So this all 40 grams has gone in. No wonder, because it's an osteoporotic bone. Right. So now I can use a mop to proximally pressurize this, but you have a device to do proximal pressurization normally. Right. दे दो, stem दे दो. मार्क कर दिया उसको कहाँ है? So now we'll use the scale to make sure where we are putting it. I am trying to position the implant parallel to the posterior neck plane. Curate दे दो. Yeah, I know. Curate दे दो. छोटा curate दे दो. अभी देखो.
More 3 millimeters more. Yeah.
So we have measured where we want to go and trying to maintain the version of the implant. And now I'll hold this in position till. So there is nice cement mantle all around and we are happy with it. And once this cement sets, that small micro motion at that fracture also will disappear. So we'll be okay with it. और क्या? फिर कहाँ से करेंगे? क्या क्या था वो ओपन करा ले. Size.
Any tips you want to give about the preventing varus malalignment of the stem?
Sorry?
Any tips regarding preventing varus malalignment of the stem?
Yeah, that's this thing. More of a problem with a collarless polished taper. These sort of stems are more canal filling, the Muller type. So, but when we are introducing into the center of the mantle, but with my hand I am pulling it laterally. So I am making sure that it is in the center of the canal as far lateral. And also when you make your entry, it has to be posterolateral and in the dead center of the canal. So that is an important thing to do. इसको ऐसे बॉन्ड लगा छोड़ देंगे. लिंक ठीक है और थोड़ा जाओ चेक कर ले एक बार. If you were to put a cementless stem in this way, it will cause subtrochanteric fracture because it will because a tapered wedge it will break. So because it is cemented, we are able to undersize it and sink it a little bit to allow us to reduce this high riding hip. And one important tip on the preoperative X-ray is if the lesser trochanter is at or above the level of the teardrop, then you must anticipate a little bit of extra soft tissue release as compared to normal situations.
Yes.
So you can watch the X-ray, you can see that the lesser trochanter is just below the level of the teardrop, so we can get away without a shortening procedure. But if it is above and the traction film remains like that, then it indicates that you will probably need to do something more. टाइम लग गया ना थोड़ा, क्या कर सकते हैं.
So Krishna, if you had to do a shortening procedure,
yes,
then what implant would you use?
Yeah, that's a brilliant question. So this particular patient, I would use a Wagner stem. I would not use an SROM, but normally I would use a SROM where I will put a sleeve inside and then I will make an osteotomy about 1.5 centimeters distal to the sleeve and then do the shortening based on the amount of upriding that is there.
So you'll put a distal fixation stem.
In this particular patient, I will put a distal fixing stem because it's the SROM probably would be too difficult to do in this case because there are cases with proximal distal mismatch. So you'll not get stability with SROM. So I will do a Wagner in this case.
Yeah, so distal fixation, even the restoration stem of striker is quite good because you can do individually, filling of distal as well as the proximal. So there is a lot of modularity in that.
Yeah, that's a good option, but I don't prefer the mid-stem modularity devices in my practice because of concerns about fracture of the device. So I would rather use a monoblock device wherever it is possible. So that is my personal preference. Having said that, if your results with that is good, then you can stick to that. वो नहीं कर सकते तो आपको आना पड़ता, आपको स्क्रब होना पड़ता, आपको स्क्रब होना पड़ता। फॉरेन फैकल्टी को दिए तो आपको स्क्रब होना पड़ता। सर तो आधा घंटे में कर देंगे डायरेक्ट। हो गया लग रहा है। So cement is now set. Okay, so we will do the final reduction. है ये निकाल देंगे ना, नहीं तो बाद में नहीं निकलेगा।
अभी वो एनेस्थीसिया दे रहे हैं। अच्छा रेडी कर लिया पेशेंट, जस्ट क्लोज शुरू क्या नहीं। अच्छा तो वो अभी शुरू कर रहे हैं, मतलब 10 मिनट में शुरू होगा वो।
Yeah. So just give us a minute. So वो दिखा देते उस टाइम तक, उधर फोकस करो ना, show me that one. So this particular assembly requires a special device. So you have to use this device to pop the head into the thing and get it locked. So it will go with a pop sound. So keep on rotating till the head goes inside. And till I think 47 we have 22 millimeter head. Beyond that you can use a 28 when you can use a ceramic head. So that is a game changer, because ceramic head with a cross-linked poly will reduce the rates of intraprosthetic dislocation, because intraprosthetic dislocation happens at 7-8 years because of polyethylene wear. And if you use a conventional poly with a metal head, the risk of wear will be higher. Using a cross-linked poly with a ceramic head will reduce the risk of intraprosthetic dislocation. So this is assembly, and gently now the assistant will repeat his thing, hopefully. नहीं जरूरत नहीं,
बंद कर रहे।
And it has gone in nicely. You can see that. Can you? I will focus it for you. Yeah, you can see it's nice. The combined version is around 25 degrees, so that's pretty good. Yeah. So we're happy with this. Looks a stable construct, and the trochanter looks stable. It's all stabilized with the cement. Yeah. And we'll just close this down so you can,
So Dr. Krishna,
Sir.
Can you hear me in the auditorium? Hello?
Hello?
Can you hear me?
Yeah, yes, sir.
So we have given the status of foreign faculty to Dr. Krishna, because normally these kinds of patients we give to foreign faculty. And then there is that perverse streak when you see them struggling with the case. But it has happened to me. I presented one difficult case. It was childhood septic arthritis, wind-swept deformity. It was stiff hip on both sides. So I said, will you do it? I asked the foreign faculty. He says, you do it, send me the x-rays. So those smart ones will just wriggle out.
ठीक एक बार कम से देखेंगे कहाँ तक आता है, extend करो.
Actually, we then did do it and sent in the x-rays. That's a different thing.
So you can see that since we have lengthened this limb by almost 2 centimeters.
Yeah.
So this is the posterior flap we have raised. You can see this, but it will still come back when we externally rotate the hip. It will come back. You can see that.
Yeah.
Yeah, you can see. See, give me a bond. You can see that's the capsule, that's the piriformis, and it will all fall back nicely, despite lengthening the leg. The key is to cut it close to the
external rotation, abduction, extension.
Yes, that's
joined
right.
together, all three movements.
So this is a good option to do intra-osseous repair, because you don't need to make any drill holes specifically.
Yeah.
The needle is going in.
It is very, can be pierced with ethicon number 5 needle. Very
बहुत
easy.
दिन हो गए अच्छा needle holder में वाला. So that's the piriformis tendon. You can see that.
Yeah.
So I can pull it into the trochanter abduct करके external rotate करना.
At its original place. Yeah.
Yes.
That is very important to prevent the dislocation. This step.
So just because we have done a dual mobility, we cannot get away by putting the component in wrong position, not doing the augmented repair and all that. So it will not.
Technique is good, should be good at any implant. Technique first, then comes the implant and technology. First technique, surgical skills.
So now we are able to repair the whole thing back, and then you can see that it falls back nicely.
Yeah, it is.
Because that is the money stitch, the stitch into the piriformis and the.
All dead space has gone, yeah.
Yes.
Closed, yeah. So this is ethimon number 5?
Yes, sir. So you can see that nicely.
Yeah.
It has fallen back.
Yeah.
This we will repair back to the greater trochanter, and then that's it. Yeah. Thank you very much, sir. Thank you for sharing.
Thank you, Krishna. Enjoyed your surgery. Everybody enjoyed. Visuals were quite clear. Thank you.
Thank you. Thank you.
Thank you. Any question from the floor? All good? Yeah. Thank you.
Thank you, sir. Next, we have, sir, live surgery, left THA by direct anterior approach. And I'd like to invite Professor Vivek Trikha, sir, Biraj Gogoi, sir, and Sir Ashish Pandey, sir, on the stage for the as a moderator for the next live surgery.
Thank you, sir. अभी रहेंगे
Sir, our next patient is a 32-year-old male with a BMI of 21.2 with complaint of left hip pain from last 6 months. He had taken some supplements for bodybuilding 5 years back. There is no history of constitutional symptom or comorbidities. On examination, sir, skin around the hip is normal. There's tenderness at the base of the Scarpa's triangle, and the flexion is restricted up to 0 to 30 degree only, and abduction is up to 0 to 20. Rest of movements are jog. This is the X-ray of the patient with pelvis with bilateral hips. Over to the moderator, sir.
So now we come to the concluding part of our conference, and I don't think there could have been a befitting finale than this. It started off all with a cadaveric workshop on direct anterior, and probably we couldn't have had a better finish than seeing a live surgery by the master himself. So as you can see, this is probably a case of avascular necrosis of the left hip and grade 4 osteoarthritis there. And Professor Malhotra, can you hear me from here? Am I audible in the operating room? Is there anybody there? So I guess the case is being prepared. Okay, so the case is being prepared there. The draping, etc., is being going on. So, like we all know that this case probably, if it's an antalgic gait and the patient is disabled, would require a total hip arthroplasty. I would just like to request, ask from the audience, is there anybody in the audience? I'm sure most of you would be doing a total hip arthroplasty, or I mean, must be in the process of learning it. So how many of you are conversant with the direct anterior approach? Is there anybody here who routinely does it, or in your own institutes, is there anybody? Okay, so even if you're not, I'm sure you'll be seeing an excellent demonstration of it. Okay, okay, so that's nice to know that it's picking up now. And so now here, I think I'm sure Dr. Malhotra would be showing us the direct anterior approach on a conventional table. It is normally done with a special table where the leg can be extended, the hip can be extended, and it needs a certain amount of adduction. But here he would be probably doing it on a conventional table. Yeah, so that makes life easier because most of the hospitals would not be having those.
हेलो चेक। हाँ तो बस तो ये ऐसी होता है, ओटी शिफ्ट कराओगे एकदम। अब बार-बार फोन मत करो यार, हम केबल शिफ्ट कर रहे हैं इधर से उधर।
Yeah, so now probably we are there in the theater. Am I audible there in the operating room?
Yes, sir. Yes.
Okay. So in case you can just give us an overview of the situation there in the OT, the table, etc., would be of some benefit to the audience. Okay. Anyways, so now we can we go back to the X-ray? Yeah. So as in this case, it's very clear. Even though it's grade 4, arthritis doesn't look to be a very severely deformed hip. The problems here are there is certain amount of shortening, and so that I'm sure would be corrected once we get the hip, the acetabulum in its place, and so. So has it been templated? No? Are the templates available? Okay.
सर बात कर लेंगे, नीचे से कोई बात कर रहा है।
So this is avascular necrosis patient, sir. So we had a cadaveric workshop to start this conference, and because of the interest the delegates has shown in a direct India, wanted to end this conference.
No, that's actually very thoughtful of the organizers, and that's what I said. It couldn't have been a befitting finale than this.
Yeah, since this is the flavor of the day, direct anterior approach, so it's very befitting. Easily, it was required. Public demand was also in that line. So that's good.
We will be getting live feed in another 2-3 minutes, maybe
Okay, no
probably
problem.
5 minutes. So we have 5 minutes to discuss this thing, that how we changed our journey from posterior approach to direct anterior approach, and what were the reasons why we changed that. So many high volume, when you're a high volume surgeon or you're in a center which has a high volume for a total hip arthroplasty, usually the cases of total hip arthroplasty are the last one. You post the primary TK in a first or second slot, and then there are revision cases in which anesthesia people don't want to take it on a later half your afternoon, and then there are direct cases which are more predictable,
THA patients with the posterior approach, right? This is the thing which always happen. But because of the high volume surgeon, and we are trying to improve on our timings, trying to improve on the things, how we can get better. When we are doing a posterior approach in a bilateral patient, it sometimes become difficult. So you have to shift your patient. You have to do one, you have to redrape, and then you have to shift your patient to the other side to do a total hip replacement. You might lose another 20 minutes, 30 minutes, maybe 15 minutes in that process. And other thing is, because when you are doing posterior approach for both the patients, the restrictions and the post-operative protocol totally change.
Yeah.
So because of all these things, considering patient perspective, considering the questions of the patient which he had during in the pre-operative counseling and a pre-operative talk, you always want when I will start walking, when I will stand, when I will go back to my work, and what were the protocols or what will the precaution do I have to take, and how long do I have to take. And these are the questions which are very relevant to him. Maybe for us, these are not very relevant because we are thinking about it 20 years down the line.
Yeah.
We are thinking like, you have to stay with this hip for the last 20 years. Why to think about for the first 2 months or 3 months, what is going to change? But for him, for these 2-3 months are very important. This early post-operative period is very important.
Yes, so that's a very important point about patient satisfaction, which Dr. Vikrant has brought out. So coming back to this, that very important point which you have brought out, that the position, that itself is a big advantage, particularly in a high volume center like AIIMS, where we are routinely doing a bilateral total hip. So it saves quite a lot of time. And I'm sure you people are working. I'm sure very soon you're going to start 2 team simultaneous bilateral hips also, maybe someday. So that's one advantage with this approach. And the another thing which I wanted to ask since you are a part of the team which all started this DAA, were there any separate or special anesthesia requirements which you had predicted to the anesthesia team? Like maybe because of the prolonged time, did you ever have to use a epidural or a general anesthesia or something like that?
No, actually anesthesia is not changed. It is simple spinal or combined spinal anesthesia. But anesthesia people are more happy with us now because we are doing it in a supine position. It is not a lateral position.
Yeah, so even if they have to change and if their anesthesia fails, they can easily convert it to
there
a
is
G.
no effect of spinal anesthesia. They can very easily change to general anesthesia. And
Vikrant,
first things,
regarding the table, I believe you people are using the regular OT table or fracture table, isn't it?
So
for DA cases.
Yes.
At what stage you need to bend the table for delivering the proximal femur, and how much you do? Can you throw some light on that?
Yes. This was the thing why we had Cadbury workshop, just to fine tune that things. It is a soft tissue surgery. Let me think very clear with you. It's a soft tissue surgery. It is the soft tissue handling during the surgery, which let you to go inside the acetabulum and to deliver the femur outside the wound to prepare the wound, to prepare the femur. So it is a soft tissue surgery. Everything, these points will be sorted out during the live surgery by Professor Malhotra. We'll go through all the points, each point where has to break the table, will show that, and how to do the releases to deliver that femur into the wound, how to do the releases of the acetabulum to reach inside the acetabulum. Everything will be discussed here. So coming back to the anesthesia and the positioning perspective, we are on a supine patient on a normal table, and we are able to break one side if we are operating on the left side, we can break a left side. We can keep a right side of the limb straight on the table, on the normal table, because it has 2 limbs. One limb can break on the left side, the right limb can stay there. And there are tables which don't have this function. Maybe in your setup that this function may not be there because of the normal table you have. So the easy way out is to put a Mayo trolley in front of your patient. So you can break whole of the table, and which limb you not operate, you can put that limb onto that Mayo trolley. So it is as simple as it is. There is not much change in anesthesia perspective. There is no much change in the table perspective. The only thing which has changed is maybe the instrumentation for the direct entry approach, because there are very few companies which provide instrumentation for that, and instrumentations are very necessary in the early part of a learning curve, because that is the offset handles and the offset femurs is the only way you can go inside the acetabulum and go inside the femur in a more predictable manner. Over the time, you may switch to the normal conventional instrumentation, but in the early part, it is necessary.
Again, selection of patient is also, I think, a crucial point, isn't it? Factor need to be considered while someone is starting DA. Selection of the patient. What tips you would like to give on that?
I'll leave this question to Professor Malhotra when we talk about this X-ray. But definitely, patient selection in early part of a learning curve is very important. The learning curve is somehow defined between 50 and 100 cases, and this learning curve also have a very different description in the literature. So what the people say is, if you have done a cadaveric workshops, if you have seen well a mentor doing direct entry approach in front of you, the learning curve is reduced to the duration of surgery. So you have seen everything how to do releases, and the complications will definitely reduce because you have done well on the cadavers and you have seen well. So the only thing which is left with you during the learning curve is the duration of surgery. You may take much time than your mentor, but over the time, you can reduce your time, and complication will definitely reduce because you have learned well and you have seen well. So this is the perspective what we were trying to give during the cadaveric workshop, that it is not necessary to do the surgery very early or get into the hip. It is more important to understand what are the releases and what step, and it is a sequence of the steps which is more important rather than jumping into the acetabulum, inside the femur.
Yes, so that's again a very important point. You should not be chasing the clock, particularly in your first few cases. You should take it easy, and you may be doing a posterior approach hip in maybe 30-40 minutes. Don't try to do it in your first few cases. I have a question for Dr. Andre.
Dr. Andre Ferreira.
Dr. Andre.
There is a question for you.
Dr. Andre, I just wanted to know how often are you doing hips by DA by any chance, or?
No, I do practice the posterior approach.
Okay,
But sometimes I don't do any more fracture. But in case I have to treat a fracture, I use a DA.
Okay, the approach for a fracture case you use, but not for arthroplasty.
Yes, exactly.
And how popular is it in France or maybe in Europe?
It is more and more popular.
Okay.
We can say that 60% of surgeons use posterior approach, but 40% the anterior one. Uter or DEA or Ardinge, it depends. But we can consider that they are all anterior approach. And it was increasing, and now I think it's stable. And in Europe, it's exactly the same.
So the popularity of the anterior approach is going up, you mean to say?
Yes, it's going up due to some companies like Medacta, for example. But that's the reason why I think that there is now a stability of the rate.
All right.
Thank you.
It is a very good question you have asked, Dr. Pandey. I mean, this was the literature review what we did when we first wanted to start direct entry approach. So the literature review is like this. And there are three subset of people around us who are willing to go for a direct entry approach. The first subset is the postgraduate students who are not committed to any approach or any field. And the second subset is senior residents who are doing their residency. They want to commit to certain field or certain approach who have not yet started their learning curve. And then there are the high professionals, surgeons like you people sitting upstairs, who have already committed to that approach and it's been many years doing that approach, right? So it is difficult for you people to go through that learning curve again and to manage that complication again, because you people are now high volume surgeons. You don't want to change that thing. And then there are residents and the senior residents who are yet to discover both the approaches, and that these people will might very easy to go into a direct entry approach, right? Because they have yet to commit to the posterior approach or the anterior approach. If they see well and the mentor is there, they can follow. So it will be very easy to go to the direct entry approach. That's why this proportion is of 60 and 40. Because 60% people are yet high volume surgeons who don't want to commit or change to the different approach, because It's been years doing that approach. There is an inertia, there is a resistance that you don't want to change.
Okay, so I think to summarize, it's basically changing the approach from posterior to anterior is basically like changing your religion. Those who are fanatics of posterior would be very, very skeptical to change to anterior because everything changes. The visualization changes, everything becomes topsy-turvy. So they are a little skeptical. However, I think then there are a few adventurous ones who want to add something to their armamentarium and they want that I should be able to do both a posterior and anterior. They are definitely trying their hand. And like you said, the postgraduates and the senior residents and the ones who are growing up, it's something like how you groom a child or how you teach a child. You teach him something from the childhood, it becomes very easy for him. So that is how the that is how I see the direct anterior approach as of now. Certainly, it has got many advantages, but again, probably I'll wait for some more time let it prove itself for me to switch from a posterior to anterior. I am basically a posterior approach surgeon, but having seen this workshop, the cadaveric workshop, and a lot of surgeons perform, I am definitely tempted to do it someday, but probably I'll have to wait for some more time.
One more thing, like it's the general perception is that in the learning curve while doing DA, the rate of complications get a bit high compared to other approaches. What's your point on that?
So this is the definition of a learning curve. I mean, some
compared to
complications.
other approaches, the rate of complication in this DA is supposed to be a little higher. I mean, is there any difference actually?
Yes, sir. This is what I wanted to make you understand during our previous conversation, that you can limit your learning curve to the duration of surgery. How we can limit that learning curve to the duration of surgery is by doing sufficient cadaveric workshops and by visiting and revisiting a surgeon who is doing direct anterior approach.
Yes, so
Right.
the take home message should always be, yeah, I'm sure a lot of people would be impressed after they see this surgery and they are already impressed after the cadaveric workshop. But before you try your hand, always have a backup plan. Have a surgeon who has performed a lot of surgeries by your side when you're doing it first. To never try this surgery alone in an isolated center where you don't have a expert person to bail you out. So what's the status in the operating room? Are we anywhere close?
I'm part of this institute for the last 35 years. I've never seen any other hospital in Australia. So, right from first and ICO, I did my training on medical.
Okay.
Any trauma is here.
Is one area actually, it's many people like I personally feel myself, there are a lot of things to see and below that cases in all
Good afternoon.
Good afternoon, sir.
How are you, sir? Hello.
Hello. Yes.
We can hear you, sir.
So it just occurred to me that this time's program started with direct anterior. Then why not to end it with direct anterior with a whole lot of discussion in between? Because Earlier, we had thought we'll show a direct anterior, and then we thought people may not have overdose of direct anterior. But then we thought that we were finishing too early. We have never finished at 12 or 12:30 ever. We said we'll just show you one more case, and I think it will be another revision for everybody who has been hearing about the direct anterior. So this, I hope you can see the X-rays. So this is a 28-year-old male who has got bilateral avascular necrosis of the hip because of the steroids. He has some ill-differentiated collagen vascular disease kind of thing. So he's got skin rashes also, and he was put on steroids. And as you can see, there's advanced avascular necrosis of the femoral head with fracture and fragmentation of the femoral head. आवाज नहीं जा रही?
So Professor Malhotra, I have one.
This is so, and what we otherwise do is, I can't see it here. Where are the spine X-rays? So we don't have, we don't do any hip replacement without looking at the spine X-rays, without looking at the sacral slope and pelvic tilt and mobility of the spine, and accordingly we do this. This is the kind of patient which you should choose for your early days, So it's a thin, lean patient, avascular necrosis, mobile joint. So, if you go for a very muscular person right in the beginning, you may have some struggle. So, I think it is also a reasonably good case for demonstration. So as you will all agree, he is only 28 and he needs a hip replacement. So we can have that endless debate about cemented or cementless, but I don't think that many people would do unless you're in Europe, will do a cemented hip for a 28-year-old, and definitely not the cemented acetabulum. The cemented femoral component may still work, but not the acetabulum. So we are going to put in a cementless hip, and I'm going to use a short stem here. So, we have now more than 12 years of experience with short stems. And when you classically discuss the indications or advantages of short stem, it's always said that they are very good for, minimally invasive approach, or for, so whenever you want to do an MIS, it is good. On the other hand, for direct anterior approach, we have been able to get away with not very extensive releases, but we have done stems like Corel, bicontact. We can put in a standard length stem, we can do cementing, we can do everything. But the amount of release required is a little more than what you need with a short stem. So short stems are very very convenient and very useful for direct anterior approach. But like I said, you can do cemented, you can do. We had a talk by Lee, Dr. Lee from Yale. And he had given you tips yesterday about doing the direct anterior for a fractured neck femur for a bipolar. Like today's patient, if she was not so osteoporotic, we could have shown you the direct anterior in that only. But in such an osteoporotic patient with an old fracture where the tissues are scarred and contracted, the rotation may create problems. So we are not that much converted to direct anterior as to tell you to do it in every case, although we could have done it. But I think that's, if you are not an experienced surgeon, it's best not to try direct anterior approach in a case like this. So otherwise, we have done dual mobility cementless with cementless stem in patients with fractured neck femur, and one of our male patients who was about 60 has sent us videos where he is running in the park with his dog and doing all the extreme physical activities. So we are almost ready here to show you the total hip replacement using the direct anterior approach. The patient has been positioned on an ordinary table. We are not going to use and by the way, I do have the special table. And so I can tell you about the advantages and disadvantages of doing it with table, without table, figure of 4. Each thing, everything has got its advantages and disadvantages. But the biggest deterrent to the direct anterior approach in India has been the thought of having to buy a table, which is absolutely unfounded. You don't need a special table. You can do it very well. So we have bought a new table in OT1. This is for Dr. Yadav. We have bought a Mackay latest state-of-the-art table. So I can do it on the table. We have done it on the table. The biggest advantage of table is, just like doing a surgery on fracture table, that the patient has the legs have been tied. So you can do it with one assistant. But assistant have never been in short supply in teaching institutions. So that's not reason enough. So we have done it on special table, done it on ordinary, and then we decided that we are happier doing it on ordinary table because we can assess anterior stability, posterior stability. We can have limb length, measured well. When the foot is tied in a table like a fracture table, then you don't get the exact estimate. And those people are able to do it because they are doing digital templating or they are using robot with direct anterior. So they are able to sort of let the robot find the limb length otherwise the foot is tied in a support. So you are not able to palpate the medial malleolus very well. So to me, it works very well on an ordinary table. Don't need a special table for that. So if your reason for not doing it is because it involves buying a table, you don't need to buy a table. So all of you are experts now. You all know incision is 2 centimeter distal and 2 centimeter lateral to the anterior superior iliac spine. Line, imaginary line going to the fibular head. Skin incision.
Can we have the camera focused on the operative?
Second knife, forceps.
Thank you.
So, give me the corpse retractor. So we are looking for, first is that we have to put in a finger. You should be able to go to the ESIS. And I'm already seeing something purplish corpse. So I have my assistants who have been doing a lot of these cases with me. So it makes it very easy. So if you want to start it, take some of my assistants with you for a few days. Deep knife, forceps. So we discussed the injury to the common peroneal nerve, lateral cutaneous nerve of the thigh. And it was made very clear that if you incise the fascia, this is the TFL, right?
Can we have the camera focused on the operative field, please? You're not able to see.
Bhai, kahan gaya camera? He's coming. Artery. So we have, we discussed that the iliotibial band, the tensor fascia lata is lateral to the ASIS. Its color is, purplish here or pinkish. The sartorius is white and the direction of the fibers. So we are going to open the fascia. If you open the fascia a little laterally, you don't risk so you don't risk going into the wrong plane and you don't risk injuring the lateral cutaneous nerve of the thigh. So I have now divided the fascia and now Ellis. And if you want to peel it easily, just like you say, go in this direction because the direction of the fibers is laterally and inferiorly. So I enter from the angle. So whenever you want to erase a muscle, go into the acute angle and you will be able to separate it. Idhar dikho, dikha rahi hai? Head ko kaat do yaar. So we are in the plane, that's the plane. So we are on the medial side of the iliotibial band, the tensor fascia lata. So much used to saying iliotibial band. And now we are going to divide this fascia and look for what?
The leash of vessels now.
Yes, exactly. I just wanted to make sure that people are not sleeping. So the leash of vessels is here. Can you see? Dikhao, focus karo andar. So we have found the leash of vessels and we are going to coagulate. This is a few minutes well spent here. Otherwise, this will keep on teasing you throughout the surgery.
So what's the normal location of the leash, sir? It's in the superior part of the incision?
Yes. No, they actually a small bundle a little distally. Otherwise, it is in the upper half. And sometimes, if you are lucky, you will find a branch going up, which is which also bleeds. So if you coagulate that, there is a superior branch which runs up, the superior branch of the lateral femoral circumflex artery. If you are lucky, sometimes you can find it. So I'm already onto the superior neck. Give me a retractor.
That's the key point which sir has brought out after you give the incision and the facial incision.
So we put one superiorly here. I'm feeling, I'll divide this fascia. Just a minute. I'll divide this fascia. We are not done with the vessels. We might come across a couple of them still. Now, dusra do. So I've got a retractor on the superior neck. I've got a retractor on the inferior neck. See that? It's so beautiful. This is the capsule. Look how beautiful it is.
Yes, absolutely clear.
Okay. We have to remove the fat. That we'll do duly. There's some fat here. Kuch khas hai nahi hai fat. Just a minute. We have to go underneath the rectus femoris to put our anterior retractor. Right? This is a plane. Give me the anterior retractor. So I've got one retractor superiorly, one inferiorly, and one.
So as you can see, you first use your finger to do blunt dissection before putting the anterior retractor. So is it always done that way only? I mean, does it tip?
Like the that there will be a facial adhesions between the capsule and the muscle. No, the more I release it now, the easier it will be for me to get into the plane and excise the capsule. You know, I don't want to keep on hitting the muscle when I reach there. So I want to make sure that I've got my capsule exposed all around. This is vastus lateralis on the lateral side. So there will be adhesions between the minimus and the capsule here superiorly, between the iliocapsularis here and the capsule.
Professor Malhotra, sir.
Yeah.
Regarding placement of the anterior retractor.
Yeah.
What direction to be followed? Can you?
Towards the opposite kidney or the opposite shoulder. Not much different from what he was doing, except that he was putting it posteriorly in the previous surgery. Basically, you have to put it on the anterior column, not on the anterior wall. But what happens is, this is okay. Now we are ready. What's it? Really? We'll see. We'll see. He's a thin and lean person. My assistant is insisting that there is still a little. So give me the corpse now, please.
Yes.
So that is the plane. We are. Isko nikalo.
Yeah.
Ecstatic. My assistant is ecstatic. Sister, वो दे दो जरा sharp वाला. हमारा वाला जो anterior retractor. So see, you are not going to cut any muscle. I have not cut any muscle except for that leash of vessels. There's been nothing which can bleed from here, right? So you have, if you do your hemostasis properly, let's keep it here for a minute. I'll make it easier for you, but don't lose it. Dissecting all the muscles away from the capsule here. Corpse ready, please. Right here.
Here,
So you can see the capsule now nicely. There's
we
the
are clearly
capsule.
on the capsule.
Yeah.
We can remove a part of this. So my assistant, no, he is a purist, will not let me do anything without unless I remove this pad, because the book says you have to remove the pad, and I am quite sure it's not going to bleed much. I hope I'm not proven wrong. But this fat is removed with coagulation because otherwise it bleeds. So the classical textbook step is that you must remove this precapsular fat.
Can you readjust the camera, please? The surgeon's head is coming in. Yeah, that's fine.
Sir, you can't separate surgeon's head from surgeon.
Take it up from that side. Okay.
So we have actually removed the fat, precapsular fat, right? So we are ready. I've been told to mark the capsular incision. I have decided to give it a go. I mean, capsule now.
So, sir, do you excise a portion of the capsule or keep
I
it
will
for...
do it later on. I will do it later. I'm often asked this question, why do I not excise it at this point of time? These are the structures. This capsule, thick capsule will protect the muscles around when I prepare a ream. So I will excise it once the reaming and acetabulum preparation is done.
So that's one important...
So this is the superior flap, stay suture, suction. So we take a stay suture in the superior flap of the capsule. You can see the beautiful head now. Artery. Hold it. Cut. So it's actually the shortest way to the hip. Hold it. You know, see how quickly you can get into the hip. Right. So we are already in the hip. I need some suction. So now, can I have the neck cutting guide, please? Right. So this is the direction, and this is the napkin ring which I'm going to make. So let's have the saw. First, make the proximal cut, like I told you. Very porotic. It is the base for backbone. Towel clip. I've taken out a napkin ring which is not so, because the bone is missing from there. It's not a very good quality bone. एक मोटा वाला bone लीवर दो. अरे भाई. So we'll just see another woman. और डॉक्टर साहब को टॉवल क्लिप दे दो. So take this, cautery. Dr. Deepak will always go through all the steps. It is said that you should rotate it so that all adhesions are broken except the pull it, force it, suction. So we can't apply that formula for measuring the femoral head because this is all misshapen and destroyed femoral head. Okay. So you can see how bad the disease is.
Yeah,
Can you
it
see
looks
that?
really very soft.
Yeah. Keep this. Nibbler. The
Yeah.
cartilage has come off from the head. There is really no support for the cartilage. Keep this here. Mop.
Suction. Okay, give nibbler to sir. Give nibbler to sir. Okay.
retractor. Forceps. So at this point of time, I'll first do 2 releases. Retractor. Langenbeck. Suction at the tip, please. Okay. Now the neck cut is done. Head is out. Now I have to prepare acetabulum. So I have to do a couple of releases. The first release is the superior capsule release, which is at the 1 o'clock here, which is done between the labrum and the capsule. So going between the labrum and the capsule here.
The camera needs to be repositioned, sir. We are not able to see the release.
Deepak, आपका सर आ रहा है.
That's better.
So this is a release which goes up between the labrum and the capsule from inside out. So that's the release done here.
So you're doing it radial release, is it?
Yeah. The second release is the pubofemoral ligament release, which will help me take the limb away. So just a minute, just relax for a minute. We'll remove this bone. So the best thing to do is nibbler. You can do this release before the neck cut also. The problem is that very often it bleeds. And if it bleeds now, I've got more area to visualize. So I just go along the neck and my assistant is gently rotating the limb. And I'll just go on till I reach the lesser trochanter. Little more. We should be able to palpate the lesser trochanter. More. Externally rotate. So I've reached the lesser trochanter. Right? So, okay. Now we'll put one retractor at the just keep it here. Tumal wala uman do. We can do it later. So we'll put the inferior human. Can you show inside, please? Keep it here.
Light.
Suction, light inside. We have to show them. So, forceps. Cautery, nibbler. We have got this part of the ligament and everything. Light अंदर दिखाओ. Focus अंदर करो.
Light.
Okay, done. Now I need to remove the labrum. Unlike the fracture neck femur where like Lee said, don't remove the labrum. Here we are going to remove the labrum. Knife, light अंदर नहीं दिख रही है बिल्कुल. Knife. ungli हटाओ.
Yeah, some more light inside the acetabulum will be better. We need some more light.
Better.
Better. Yeah.
Nibbler. It was still left inside. And give me that pichella retractor. Internally rotate. Okay. Look inside now.
Yeah, that's a
Happy?
good visualization of the
Are you happy?
Yes.
Are you happy?
Yeah, we can see it
Can
nicely.
you see the acetabulum?
Yes.
Yeah.
Yeah, okay, we are ready to prepare acetabulum. Give me the remus.
So I would request the camera to be zoomed out a little, and then we would like to see the position of the retractors in relationship to the patient. It's a little bit too zoomed in. So can it be done? Just focus out and show us the position of the
So my
retractor.
inferior retractor is along the tail. I've got the anterior retractor here. You can also call it medial retractor. This
Zoom
is the
out,
superior
please.
retractor
Zoom
and this is
out.
the posterior retractor, and I am ready for reaming. Suction, please. इसको रखो उधर. Love. इसको वहाँ रखो. देखो. निकालो. Give me some room. So we are ready for the reaming. You see, getting in and out is no threat. Give me 44. I still have some labrum there, which could create some problem for me. Just give me, yeah. लाइए.
So now can you
So
tell
if
us,
you, अरे यार,
tell us the
Oh, bhai,
position of
nahi chala.
your reaming handle in relationship to the floor for getting the right
so we'll keep
inclination
it
and
parallel to the
extrusion.
floor. We'll keep it parallel to the floor, and the angle between my ream.
So we can see 4 retractors in use. Can you please tell the positions of all the 4 of them?
So this is anterior superior, the anterior retractor towards the opposite kidney. This is at the tail. This is at the posterior. This is the posterior, and this is posterior superior, just to keep tissues away. See, and if your releases are good, see the exposure, there will be no difficulty, particularly if you are using the offset reamer. Next, we are about to get ready for the cup. Ask him to get the cup. क्या है ये? 46 दो. 48 का cup ले आओ. 48, 50. Come on. सियाम पे रेडी हो जाओ. $50 लग जाएगा. लाइए नेक्स्ट दीजिए. 48 दीजिए. We'll take a shot with 48 reamer inside, and then we'll take a 50 cup. After doing a 49, open the mouth thing. So if you have released well, these are the points where you can struggle, right? If you have done the good releases, I have no difficulty getting in and out of the acetabulum. Oh, X-ray, X-ray. पहले फोटो तो खींच ले, रुक जाए एक मिनट. So you see, if you have a good patient, it's actually, it's not called direct for nothing. It's really direct. You just get inside. It looks very intimidating because we are trained like that. I have converted from posterior to this. ऊपर करो सिर की तरफ थोड़ा, थोड़ा सिर की तरफ करो. शूट करो. Rotate. Rotate. You are happy about the position, sir?
We can't see the image. Shoot.
Can't see. वो दिखाओ सामने image. वो दिखा रहे हो?
Picture in picture. We need the picture in picture.
Can you see?
Not yet.
No, not
If you can't see, I'll show you the cup straight away then. दिख रहा है?
Yeah.
Yes. Yes, that looks fine. Nicely medialized, and the
49 cup.
inclination looks nice.
Reamer ready.
Yes, yes, it is visible.
Yeah.
So that's my reamer. Are you happy?
Yes, that's
Okay.
a 48 reamer, and you plan to take a 50 cup, is it?
Yes, sir.
Okay.
Are you delighted?
Yes, it looks fantastic.
Okay. Give me the anterior retractor. एक मिनट के लिए पीछे कर, सिर की तरफ कर लो मशीन. Anterior retractor. 49 का रीमा. वैसे ऑस्टियोपोरोटिक बोन है, बहुत ज्यादा है. Okay. कर ही देते थोड़ा सा, हल्का सा.
Only one thing which was on the X-ray, Malhotra sir.
Yes, sir.
Only on the X-ray,
Yeah.
what we could see was the inferior margin of the cup
Yeah.
Reamer was
Yeah.
little higher than the teardrop. Is it because
That is
of the
because
angle
of the view, I think.
View
That's
maybe.
because
Yeah.
of the view.
Yeah. Most
But
probably.
you see if you see a clear picture, you'll see it's not a high hip center, it's perfect center. I think it's just the best machine which
Yeah,
we
machine.
have here for X-ray is being used for an IT fracture right now to do at PFM. So, Kholo?
In a case like
Mop.
this, sir, where you're planning to use a 50 cup and
Yeah.
he's a relatively young man, you've got sufficient bone stock, would you be tempted to go to a 52 and put in a 36?
No, I will not. Definitely not in direct anterior. Because here it's not, one thing is that in this system, the 50 gives you 32, number one. And number two is, even if I'm going for 28 in direct anterior, I will not eat more bone or sacrifice more bone because the dislocation is not an issue. Wash. अरे भाई जल्दी कर ले. Wash. ठीक से लगाया. So what you have to make sure is that the screws are the most medial screw should be, anterior screw should be in line with handle, and rest should be behind, so that if I have to put the screws, they will go to the best part of the bone without risking anything. So we are ready for the cup.
That looks like a Asculap plasma fit.
That's plasma fit, sir. Absolutely. Full marks. Okay. Hammer. Show me. X-ray. Nikalo anterior retractor.
It sounded very good. I'm sure it felt very good, and the X-ray definitely would look good.
Yes. Shoot. Happy?
This is the old X-ray. That's the reamer, I think.
Yeah, that's a reamer. Yeah, this is a new one.
Perfect.
Looks great.
Yeah, so this one, so that X-ray. Okay.
Looks perfect.
Okay.
Yes.
Hello. So we'll check that it's bottomed out. Anterior retractor, show me. Hold it there. Artery. It's bottom out. Give me the real liner. Wash.
Can we have a look at?
Give me the real liner.
The image looks perfect. We can go back here.
So as you can see, the feet is very solid there. Would you like to put some screw or no screw required?
Sorry?
Would you like to put some screw also or no screws required?
I'm not putting any screw in this case.
Okay,
I'm quite happy with the fit.
very good fit.
So I'm just going ahead with the real liner insertion.
That's a ceramic liner, and we can see a portion of the tile also inferiorly. So the placement of the top looks perfect.
Okay. So we are done here. So we'll now do the femur. Right? So that will start. No, first we'll remove the inferior capsule. We have left that. So put something here. Yeah. So we'll remove those capsular flaps. What we? This is anterior capsule flap. What it is soft करना पड़ेगा. आर्टरी रिट्रैक्टर ठीक से करो. लो यहाँ पे होगा ना, ये है ना, ये वो दिख रहा. अरे यार तुम कुछ छोड़ के मत ढीला करो. आर्टरी दो, बॉडी टिप ऑफ करो. सक्शन. See, this patient is not bleeding like AVN. He is bleeding like inflammatory arthritis. So he may be having underlying synovitis as happens in some SLE and all, and then got AVN because of the steroid.
Yes, definitely. Looking at the cartilage also, the way it had peeled off the head, probably some inflammatory process is going on, and that's the reason he's bleeding.
Are you using hypotensive anesthesia also here in this case?
No, we are not.
Okay.
So काट के देखना.
And tranexamic acid? Do you use tranexamic acid in all hip cases, sir?
We do use. आती दो. आती. Suction. Suction. So it's just to prove that point which I was making earlier, that if I had done this capsulectomy earlier with the neck and head in place, it would not have been very easy to catch hold of these bleeders. So I just wait. It doesn't stop me from doing my work. Right. इसको छोड़ो. Okay, छोड़ो. Right. Now we start working. So इसको यही रखो, इसको छोड़ दो. So we had made this superior capsular flap, and we will start by excising this flap, and this will take me to the trochanteric fossa. Suction. See, now see the benefit of separating the muscle from the capsule, which I was doing earlier in the very early stages of the operation, so that I just cut the capsule and nothing else. थोड़ा ऊपर की तरफ लो. ऊपर.
So this step will help in femoral preparation, is it? This excising this portion of the capsule.
Change हुआ है. हुआ change. देखो. Give me the impactor. No.
But better use that.
Okay. Okay. Now we will show you the femoral releases, how to deliver the femoral out, femur out. Give me a bone hook. So I have sufficiently released so that my greater trochanter has come from out behind the acetabulum, and then in this position only I lost my system to externally rotate. So I am just doing this capsular release from this is the right left hip, so it is from 9 o'clock to 12 o'clock.
You're doing the capsular release from the acetabular side, is it?
No, I am right onto the posterior neck.
Neck. Okay.
Right, medial human lagao. There's a lot of bleeding from the bone, which is very unusual because we are talking about avascular necrosis here.
Don't have a blunt one.
No. वो लाओ कुछ उठाने के लिए.
Right? नीचे जाना है, उधर ले जाना. Just give sir wash and something to release.
There's a lot of bleeding here.
Let's go down. Let's go down.
Suction करो, suction करो.
Let's go down. नहीं उधर देखो. मेरे कुछ bleeding कम है.
मुझे वो दो, bone hook. Give a traction distally and laterally. Bone is very soft. I don't want to do too much. Suction यहाँ करो, ऊपर जा मैं काम कर रहा हूँ. यहाँ पे suction हो. Suction. This is the release, and this should bring it up. Suction there where I am working, not everywhere.
So while you are doing,
Chalo, let's try to lift it up.
So while you're doing these releases, has there been any change in the position of the limb, sir? Has it been
Position of the? Yeah, we'll show you the position of the limb. The position of the limb to begin to start the releases is external rotation in extension. And then gradually as we kept on releasing, the limb is going down. Important thing is that you should not try to lift it up while the trochanteric flange may still be behind the acetabular component, because then you will fracture the femur. So that's what I did. This is a trochanteric flange. I can feel it all along. You see, and that's the fossa. And the piriformis I can feel right here. That is intact, right? So we are actually going to just deliver it out. दूसरा ले लो, ये चीज़ नहीं करना. Actually, the advantage of a short stem is actually I can right now do it from here only without doing any more releases.
Yes.
But my assistant wants everything to be done all the way. There is a branch of the medial circumflex femoral here which can cause troublesome bleeding. Lift up. Now there is a potential space behind the trochanter. We put a retractor there, and while he gradually lifts it up, my assistant will take the femur down gently. Yes, at that external rotate. Great, great. So suction. Give me the rat tail. So you know, just like you prepare in the posterior approach, you always, because of the bowing, you start the posterior lateral corner. So this is the direction I'm going to follow for the canal. So this is the canal, right? Now rest do. Very poor quality bone. Like I said, today is the day for poor quality bones. Gone. You see, that's how they demonstrated. The opening is like this. Now it becomes parallel to the table or parallel to the limb. We are in good direction. We have not caused any. So this is 0. Give me next. Give me next. बड़ी poor quality है. Next. 6 तक तो नहीं पहुंचेगा, but it is very, very soft bone. Next. Next. Next.
We can see the proximal femur is very nicely exposed. So we can also see you are using
cut some of the neck now. Give me the saw.
Yeah. You're using offset broach handle, and if someone can get this kind of nice exposure, probably you can do without offset handle also.
Yes. Eventually, yes. But initially, it helps to have those instruments. ये blunt चाहिए, बहुत sharp है. I'm sorry about this bleeding. You know already. Okay. अंदर चला जाएगा नहीं तो लो ये very very soft and very poor quality. Accelerate. This seems to be our size. We may take a 5, but for trial right now, give me the neck and the short head. Neck, short head. Nikalo, everything comes out. Head pusher. Head pusher. Okay, it's reduced. Now we will just put two limbs side by side. A luxury which is not available with anything else. We are looking at the limb length show here. We can just directly compare the X-ray layout. We can directly compare the limb length on the two sides. बस थोड़ा और अंदर करो हमारी तरफ. Okay, so that's our trial. We can just rotate the limb like this. Shoot. So it's inside only. It's a full external rotation. It's inside only, and we'll look at the shuck. Shuck. It's a little loose. We can think of what's the limb length. इतना बांध दिया उसको. ठीक. You are nearly equal. Yeah. Okay. हटाओ उसको. हाँ. We can actually check the stability now. So we'll take it in extension. इसको तो उधर करो. It's 20-degree extension. This is full external rotation. See that?
Yeah, we can see that.
Extension, 20-degree, full external rotation. It's in. I can do the flexion, this which you can't do with the table. So they'll say it's never unstable posteriorly, so you don't need it. So, right?
Looks very stable there.
Yeah. So we have moved it to the range of motion. वापस ले. क्या हो? लो. ध्यान से. अपने क्या? हाँ ठीक है. देखते कब पकड़ के रखो. Okay, now it comes out. नीचे जाने दो. Rotate externally. Needle यार वो कुछ शार्प लगाना नहीं चाहते मैं. ब्लंट भी नहीं है इतना. चलो पकड़ो. लो. रैश पेंडल. यही लगाना नेक्स्ट लगाना. हाँ एक नजर दिखाओ. पकड़ो इसको निकालो. दिखाओ. हाँ. थोड़ा सा हल्का सा अंदर सिंक तो किया है ये. दिखाओ इसको जरा. हैंडल दिखाओ. हैंडल लगा. हैंडल दो.
डबल फ्रंट एसपीएल डबल फ्रंट.
गिव मी द वॉश. Suction. Rash spindle. Okay. Okay. Give me the. Give me the real stem. इतना रखो. इसको नीचे रखो थोड़ा. कहाँ? सब पे. कैसे ब्लाइंडली नहीं लगा बेटा. लो. टॉप टेस्ट. सक्शन करो. चलो फ्लो रियल स्टेम ड्रेन डाल देना. So there are two potential bleeding points, three actually.
Camera
One is
needs
the branch of
adjustment.
lateral femoral circumflex vessel which you encounter when you are exposing. The second is the branches of median circumflex femoral on the back side of the capsule, and the third is the bone itself. We'll put 0 head. अंदर गया ना थोड़ा मार्जिन. ठीक है. ये put 0. 0. Put a 0 head. Externally rotate. Okay. 0 head. Real. The best thing is that the closure takes a minute, because you are just going to close the fascia over the tensor fascia lata. Dry mop. So when I go to the changing room, before I sit there, Deepak comes there. This is I've closed. Okay, come up. Gone in, the operation is over. We'll take one final picture and then we'll just close the fascia over the TFL and then skin.
Thank you so much, sir, for an excellent demonstration of this surgery. You made it look so easy. And like I already mentioned, a die-hard posterior surgeon, I am tempted to do it sometime soon now. Sir, and the audience is waiting here for the validatory function. So I request you to come here as soon as possible while Deepak does the closure job.
And see, this is the closure. So this is the closure and then we are out. And second thing is, whenever you see a direct anterior, you want to see how well it is done, look at the TFL. If that has been rogered, it means the surgery has not been done well. More pristine it looks, the better the surgery has been and less has been the struggle. Thank you very much. I'll join you there. We can switch off and.
Thank you, sir. Wonderful surgery. We enjoyed.
Thank you.
Thank you, sir.
While
Thank
we
you.
await Professor Malhotra's arrival, can
Another
we
5
look at
minutes.
the X-ray
And
which was
band karo isko.
is it available?
Another 5 minutes.
Okay. So that's the dual mobility image shot which has been taken. So he had to do a cerclage because of that small crack. He didn't want to propagate. So that has been nicely fixed. The cup, as he was worried, looks slightly lateralized. That was because of the mismatch, which was, he had no option. He could only reach till 46 and he had to put a 45. But the cementing looks good. The hip was stable and hopefully the patient should do well.
That was inventory constraint.
So are there any questions from the audience?
Would you like to tell us in which exactly is the time period during the direct anterior that you had
Extend the limb.
extended the limb? It was only for the female. Yeah.
Yeah, sure.
Grant sir, please come on stage, sir.
Yes, sir. The question is, if I understand well, what is the time when we start extending the hip?
Yeah.
So when the question is when we break the table, because we have to break the table to extend the hip. So we had a tie which is holding on the lateral half of the capsule. There is a tie on the lateral half of the capsule. So we make a T-shaped incision, and there is a medial flap and there is a lateral flap. We sacrifice the medial flap and we retain the lateral flap. So beneath that lateral flap are the abductors. There is a gluteus medius and the minimus. And the minimus has its attachments over that capsule. So what we are doing is we are putting a retractor between the capsule and between the abductors, and we are trying to lift that muscular attachments over that capsule.
You're trying to release the capsule
From the muscles. In the same way, what we are protecting is we are also protecting the structures which are behind the capsule. There is a piriformis there and there is a conjoint tendon there. So we are trying to protect that structures also, so that if we go inside out, we will not be able to see where the structures are attached. So when we are going from outside in and we are trying to release that muscular attachments over the capsule, we have better control over the structure which are behind that capsule. So first thing is to go, if we are talking about the left hip, it's a 2 o'clock. It is the superiormost part of the neck. That is the GT tip. Just distal to the GT tip will be the superiormost part of the neck. That will be a 12 o'clock. And that will be a 6 o'clock. And then on the medial side will be 9 o'clock. And on the lateral side, there will be 6 o'clock. So what the releases is from the 12 o'clock going anti-clockwise towards 9 o'clock. Towards 9 o'clock. And that is the posterior capsular release. These are the primary releases what we do during a direct India approach. And when we did that primary release and we have one bone hook which is always retracting that femur away from the acetabulum so that we can easily palpate the posterior half of the capsule. So there is a retractor which is pushing femur away and the capsule is tense and we can see the capsule very well. So we start doing releasing from the 12 o'clock and then 10 o'clock. This is the primary release, preliminary release what we do. After that release, we put a medial humen and we put a humen just behind the trochanter. And this is the point we start breaking that table after doing a primary release. And we start breaking that table. We know that the trochanteric overhang is in front of us. It is above the posterior column or above the posterior wall of the acetabulum. And now we want to understand ourselves how much release much we require so that this femur can further go upward, come out of that wound so that we can get a direct shot to the canal.
Is there a limit to the amount of extension in terms of degrees?
So this is where the offset handles play their role. So it is not necessarily you need a direct shot with the offset handles. It is just the matter that how much, and it is usually 30 to 40 degree of extension, which is more than enough to deliver that femur out inside the wound.
So if you get proper delivery of the proximal femur with this much of extension, then are you sometimes able to do it a regular broach handle also?
So we are not doing it with the regular
Are you using
because
offset?
it is the femur which is more tricky. Sometimes
Okay.
maybe in the acetabulum we use a normal handle rather than an offset handle, but femur is the tricky one and femur is the one which we have to spend some time. So it is always good to use an offset handle if you have for a femur rather than it will be a difficult task for you. You need more releases. What I'm trying to make you understand is there are primary releases and then a secondary releases. If you will not be able to deliver your femur up with primary releases and you don't have a offset handle, you may need to do a secondary releases to get a direct shot and you don't want that.
Yeah. So what would be those structures when you need to do secondary
So when we're
releases?
talking about primary total hip replacement, so we have a posterior capsular release, then comes the conjoint tendon, then comes the piriformis. In primary THA, only 40% patients need a conjoint tendon release and only 5% patients need a piriformis release.
Okay, so my understanding after seeing this surgery, one take-home point which I have made this point for myself and I would like it to share it with everyone is that when you are a beginner, when I was a beginner, I was told that first do a couple of hemiarthroplasties and then graduate to a total hip. And like Dr. Vikrant has brought out a point here, the femur is the tricky part. So it's not that you will start a DA and try to do a hemiarthroplasty. It would probably be equally difficult or equally, I mean, the difficulty level would be the same in case of a hemiarthroplasty or a total hip while doing it with a DA.
I want to add 3 points here, sir. When hemiarthroplasty in a traumatic condition, It is difficult to do with this approach because of three reasons in fact, because it is an intermuscular internervous plane. In a traumatic condition, there is always distortion of these planes. So it will be difficult to identify a plane, and you're starting in as a beginner, you have very likely chance you go in a different plane. Second thing is, because it is a poor bone quality, and the femur is the trickiest part. So you don't want to mess up with the femur in a very early go, and you don't have a poor bone quality femur. You are trying to rotate, you're not able to do releases, you're pushing yourself and you break that. And the third point is this bipolar head is a big head, and there is a rectus in front of you, which may not allow you as a beginner to reduce that big head inside the acetabulum. So these 3 points should be considered before putting your hand into the bipolar.
So if we can, so that brings us to that another first question which we had asked in the initial setting was, which will be an ideal patient which you would like for the youngsters out here to go about if they plan to do a DA?
So patient coming to you, lean thin, not muscular. And when you see the X-ray, you have a good working space. That working space is the space between the ASIS and the tip of the trochanter. That means a valgus neck.
Okay. And not a traumatic fracture, a traumatic neck femur.
Neck femur side, there are three
initial
things.
cases.
I mean, this is my perspective. Maybe few people be able to do that, but this is our perspective, how we start selecting a patients.
So if I can say that this case which we had, would it have been one of the ideal cases to start the DA with?
Yes, sir. It is not a very muscular main because as Indians, we don't have that quality of muscles which we expect from the Caucasians. So he is a male on which we can see in the opposite side, there is a valgus neck. Because avian, anyway, the head is collapsed. You may feel like that the neck is short, but that's not a condition. You can always see the opposite hip, that there is a valgus neck on the opposite hip. I have good working space. I will come well.
We'll just wait for Professor Malhotra to come. He's just coming out. And anything which you'd like to say about any complications which you, just for the people who were not there in the workshop, regarding the complications which can happen in the initial stages of doing a DA?
So it is very important to work on a femur. The only mainly the complications as per the surgical approach are limited to the femur rather than to the acetabulum. It is easy to visualize acetabulum with this approach. So it is difficult to go wrong with the acetabulum because of two facts. Because you are able to see the acetabulum as a direct shot.
Exactly.
The cotyloid fossa is there. There is a towel in front of you. Because as an arthroplasty surgeon, you know that how to place it, just like Dr. Malhotra told you yesterday, that if I do all the releases, and I expose the acetabulum and I give you to put a cup on the acetabulum, you will be very happy to do that because you know that how to put a cup inside the acetabulum. The more trickier part is the femur part, in which releases has to be done to deliver that trochanteric overhang outside into the wound. So it is trochanteric fractures, and because you're not getting a direct shot, maybe a fracture of the femurs, which you should be considered during the early part of your learning curve. But if you have seen well and done a few of the cadaveric workshops, these complications can be limited.
Yeah, you have a question out there.
If we, in doing an uncemented, we shatter the femur, and if we have to enlarge the approach, do a wiring.
I was expecting this question. I mean, the whole idea of getting into a workshop or getting into a mentor is not to do these complications. How to avoid these complications is very important. But sometimes complications are inevitable. It happens. That's why they are on the book. So the direct entry approach has an extensile part in which the incision can be curved laterally over the thigh so that you can see the vastus lateralis, and you can lift the vastus lateralis. You can put some clutch wires, and you can again put a same stem or the different stem or distal fitting stem. And you can also give a separate incision on the lateral side.
Another point, sir, when you're starting, like it was mentioned, I got the mind out clear. So I want to confirm, starting point of the femur, so said that we start at posterolateral part. Is that the reason if you don't do it properly, when you see a lateral shoot, the
Okay.
So what we are doing is a short stem. This is a Escolab short stem. It follows the neck. It has to sit on a dorsal side. Look, it has to sit on the dorsal side. When we are using a normal stem, because of the anterior bow of the femur, it has to go into center because it has to accommodate that bow. And that's why we don't preserve neck. We don't preserve that ring of the neck. Here we are preserving the neck ring, and it will follow that neck, and because of it is following that neck, it has to touch the dorsal side of the femur. But when we are doing a standard length stem, we are cutting the neck. We are not preserving that, and we are using a chisel to remove some part of the bone on the lateral side, so that we can get a direct shot inside the femur, and that direct shot can only be you can only get by the way that you are starting slightly posterior than the center of the neck.
So we have the post-operative check X-ray of the case which has just been done, and both the AP and the lateral views, they look absolutely fantastic. The bone coverage on the AP view, the inclination looks perfect. The anteversion looks, it's basically in the native acetabulum, unlike what we are used to doing in a posterior approach where we tend to give a little more anteversion. Here, since we are not violating the posterior tissues, this has been put in a native version. The stem sizing and everything looks fine. The limb length was definitely checked clinically. For the radiographic analysis, will probably require X-ray of the pelvis comparing both of that we can have subsequently.
No, we can also have intraoperatively.
Yeah,
you can have an image.
But on
you
this
can
X-ray,
see
we
the
cannot comment on that.
Yes.
But looks like a perfectly well done surgery here. So, any comments or any questions from the audience regarding this?
Dr. Krishna is also here. Any
Dr.
question,
Krishna.
any comments regarding previous surgery or any questions from him?
We can show the previous post.
The previous post-op also. And again, in the previous post-op, we would probably, the X-ray just shows exactly what has been done, and it has been done very well. So both the cases were tricky, tough, porotic, old, neglected cases. Dr. Krishna, your comments about the X-ray?
Probably the cement mantle is too thick, a little bit oversized cup.
Yeah.
But we couldn't help it because
that was purely because of the inventory constraints, and as an operating surgeon, he was well aware about that problem intraoperatively. So whenever you put in a cemented cup, normally in an all poly cup, you would like to have at least 2 millimeters of reaming, and this evolutus cup with a metal back, the metal cup, normally we prefer about 3 to 4 mm difference of the final reamer and the cup which you put. So in his case, he could only go 1 millimeter extra because there was no, had he gone oversized it would have blown away the walls. So
that's right. So I was worried about the posterior column blowout.
Absolutely.
So ideally, you should have a 3-4 millimeter over ream for a cemented cup. So here we were able to ream 46 and put 45. So that 3 millimeter it is exteriorized, which it's not great. But
that is something which probably in that scenario, I would say it was because of his experience, he could do it. A novice would probably try to go overboard, try to go up to 48 and blow away the walls, which would have been disastrous.
Yeah.
Accepting a 3 millimeter lateralization is probably better in this situation than blowing away the bone and then probably going in for nothing will fit in then.
Otherwise, there is a whiteout in the zone 1,
Yes.
which indicates that the cup will last at least 8 to 10 years. Cementing on the femoral side looks all right, and there is adequate cement distilled to the tip of the stem.
And considering the patient profile and the demands, I am sure the implant is going to outlive the life of the patient. So I'm sure the patient is going to walk from tomorrow.
Yeah, we should hope for that. But a comment on the X-ray. So if you see the lesser trochanter at the level of the teardrop, so these are not simple cases. So you should not, just undertake them lightly. Look at the other side. The lesser trochanter is almost 3 centimeters below the level of the teardrop. So if you have a high riding hip, which is more than 3 centimeters, these are tough cases because your ability to adjust the craniocaudal length must be available on table, either in the form of a modular implant or a cemented stem.
Yes.
The second thing is it's osteoporotic. She's not walking on it. So the risk of intraoperative fracture is higher. We also had one, despite taking all precautions,
Yes.
mobilizing the femur. And then acetabular access is a challenge in such cases. And the key to acetabular access is femoral mobilization. So if you go 3 to 4 centimeters below the lesser trochanter and erase the adductor magnus insertion or origin from the femur, you can do a 300-degree release. So you do the iliopsoas release, you do the anterior capsule release, just retain the gluteus medius and minimus insertion onto the greater trochanter for vascularity. And then you are able to completely internally rotate the femur. The other challenge in this particular case was that the knee was stiff. So
Yes.
there is no range of motion in the knee. So this is a recipe for disaster. So this case looks very simple
No, so
on the
again,
X-ray. Yeah.
We were fortunate to visualize this surgery because a youngster seeing this X-ray would, start to think that it's going to be a cakewalk and I'll finish it off. But the way you release the femur, you started off with a minimal access surgery. You were quick enough to extend it. You did all the releases and ensured that you don't end up with a periprosthetic fracture or the spiral fracture of the femur distally. Then you carefully expose the acetabulum. So all in all, I think there were so many learning points from this surgery, and we are really fortunate enough that because of your experience, you could showcase everything very nicely.
So this is a template for any revision procedure, whether it's acetabulum, complex revision, whatever it is. Key is to get a 360-degree exposure of the acetabulum, whatever it may be.
Yeah, and we call
then
it
you start from there.
The kind of releases which you did.
So this is the
literally-
release. This is it. So there is
Yeah.
nothing else to any
So
revision.
we
or
we
anything.
call it the hanging hip operation, where the hip only hangs from the abductors. Everything else was released.
So Dr. Krishna, one question.
If you're
to
not
Dr. Krishna.
careful, then the hip hangs the surgeon.
Dr. Krishna, one question to you. Like in such a case of high riding hip, so what will be your order of releases to bring the femur down?
Yeah. So the first is a conservative release. So the first release is just the short external rotators and the hip capsule. And then I will release the anterior capsule between the iliopsoas and the femur. So we'll just take a scissor and cut the anterior capsule off. So key here is if you're unable to internally rotate the femur beyond 90, it's unlikely that you will expose the acetabulum because you cannot translate the femur anteriorly. So that stage, I will release the gluteus maximus completely. You notice I just did a partial
Yeah, I
release
saw that.
initially. Then I will release the Gmax completely and then reassess whether I'm able to internally rotate it beyond 90. If I'm not able to internally rotate, this case I was not able to internally rotate, then I'm happy going further down from the lesser trochanter, releasing the adductor. And after that, if I'm still not able to internally rotate enough to anteriorize the femur for acetabular exposure, that is when I will take off the iliopsoas. So that's the sequence of releases. And if it is not coming even after that, then I have to do a subtrochanteric shortening for that.
Yeah.
Just a few points. First thing is that this is the kind of case where it's our duty to make sure that the osteoporosis is treated, give high dose calcium, vitamin D, and this patient will get zoldronic acid before she goes. And this patient will also get zoldronic acid. His bone was very, very soft, the other one also. So that's first thing. Otherwise, you will land up with big problems and a big risk of periprosthetic fracture. The only thing I wanted to comment, the only thing I would have done differently from Krishna in this case is, my approach is to just go and do the releases as he said. So I am not so quick to release the iliopsoas, but that's a moot point. I would also release the adductor magnus from the subtrochanteric or the below the lesser trochanter. The first thing to release should be the Gmax insertion, because that's the one which will cause the femur to crack if your assistant rotates. And all of us have had, most of us have had an experience with the resurfacing. So we used to deliver the whole head out, and that used to be possible only by excising or incising the anterior-inferior capsule. So we pass a Kelly's clamp along the psoas and just divide the capsule in front of it. So the entire anterior-inferior capsule, the rectus, which we so meticulously preserved in the direct anterior, is the reflected head is divided. All those things which are going to not allow the femur to go away from pelvis are to be divided. But that's not what I said I would have done differently. He did all that. The only thing which I do differently in an osteoporotic bone is to first get into the femur. And if I can't get into the femur, then also I at least put a reamer. Or if I can get into the femur nicely, I prepare femur first. The advantage is that then we have a bone hook, which is put onto the trunnion, and that can be used to lift, and you can do the capsular releases, and even you can retract the femur away against the trunnion. Because we have such poor bones in Indians, sometimes when you put the anterior retractor and push the femur away, the greater trochanter gets compressed or broken or fractured. So I would always like to protect the femur with something. This is a femur which is at very high risk of fracture. In fact, if it hasn't rotated enough and I need to do more releases and I need to rotate and I cannot put the stem, I'll put a reamer. An ordinary longitudinal reamer, canal reamer or something. Leave it in and then hold the femur through with a bone hook through that reamer, intramedullary reamer, lift it up and start releasing gradually. Because for releasing gluteus maximus, for releasing anterior inferior capsule, we have to gradually externally rotate. And there's a very thin line. You can just crack femur anytime you are a little careless, then you will just crack the femur and land in big trouble. So my theory is get something inside the femur, some kind of support, and then use that support to retract the femur, use that support. With that support, then try to gradually release all these scar tissue, fibrous tissue, inner revision, anything. Try not to break it.
So thank you very much, Professor Malhotra,
That
sir.
point is very, very valid. So I would have actually done it, but because of the osteoporosis, we were worried that the rotational stability to the implant is not there. So I had one patient where we were trying to do this and trying to retract because it was not rotationally stable. It broke the entire femur. So if you have an implant in the femur, it has to be rotationally stable. If not axially stable, it has to be rotationally stable. You noticed we went on going from 8, 9, 10, there is no rotational stability to that femur. So that was the reason why I did not prepare the femur in this case, although it was the first consideration. So Deepak and myself, we wanted to do the femur first and then put the retractor. But looking at that femur, how it was, so we...
As a principle here, that again proves another point, that you have to keep your approach flexible depending on the situation.
Exactly.
You can't be sold onto one situation. Every patient is different. The topic is exactly different.
Absolutely, sir. Horses for courses, and I think it takes years of experience to realize that, and that is how you come out of these situations.
Of late, we have been doing cases which are, having acetabular bone defect, high riding, proximal distal mismatch on the femur, and then you're ending up with subtrochanteric shortening. So this was relatively okay. So the only constraint was the implant issue in this, but some of the cases which we are doing are really, really bad.
So thank you very much, Professor Malhotra, sir, and the team. So everyone of us got lots of useful points. We learned many useful things here. So I'm sure everyone will appreciate that. And now we can probably move on to the next.
Actually, the next item first, I must thank the chairperson.
I'd like to invite Professor and Dr. Rajesh Malhotra on the stage, sir. Please, sir.
Like they say, all good things must come to an end. First of all, I must start by thanking everybody who's present in the hall for their patience and perseverance. I don't know whether it's your zeal to learn or just plain laziness, or maybe you're getting good sleep. I don't know, but thank you very much. Thank you very much for being here. You're a support. But I have always said that it will not stop me even if there was one person in the audience, because even if I've taught one person, I'm very happy. So if one person has learned, we have been successful, and this has all been worth it. So I'll start by thanking my friend, Dr. Andre, for flying all the way. I wish him nice, pleasant stay in New Delhi and surrounding, and he's got some time to make it really useful. I want to thank all my organizing team, starting with Professor Vivek Trikha, who was the organizing secretary, as you know. And we have Arpit here, Shubhankar, Dr. Burhan, who else is there behind the scenes? So they are all here. Then my dynamic co-organizing secretaries, Deepak for making the scientific program and helping in the surgery, Vikrant for helping the surgery as well as organizing all the logistics. and Vivek for providing wisdom. So I really didn't have to do anything at all. My job was just to give some speeches and talk to people. These boys managed everything. So let's give them a big hand. And I want to thank all my delegates. I want to thank Mr. Ravinder for audiovisual. I want to thank the industry, all the implant companies. I want to thank all the staff members of the auditorium. I want to thank everybody who made it possible. And personally, I'm very, very satisfied. We had two scintillating events. One was the direct anterior approach cadaver workshop. Even if it was the first one, I think it was received very well. People were very enthusiastic. And second was our robotic debate. Apart from that, normally we would, when we don't have these real life surgeries, we do anything between 8 to 10 live surgeries. So I was feeling a little inadequate saying that, we are closing at 12:30. So I just added one direct anterior. Also with the philosophy that this course, this event, we start with direct anterior and we end with direct anterior. Thank you very much for that. We'll see each other again. Please join us for lunch. Thanks a lot. Organizing team for a picture.
I'd like to invite the organizing team on the stage for a photograph. Dr. Vikrant sir, please come on the stage, sir. Dr. Andrew, can we have you on the stage, sir, please? Please join us on the stage, sir.
Recording stopped.